just terrifying. Like how, especially the universities. Good old Penn, huh? They're doing a good job. Harvard and Penn, yeah. My two alma maters. Like I'm totally like I'm off the donation list anyway. Yeah, it is just yeah, it's terrifying. Wait. Are you saying he's a divisive person? That's then why do they call him President Kumbaya? Huh? Tell me that. Right. It became okay. Yeah. And if you don't like it, you just say it's fake. Yeah. No, no. No, we're not reading the news tonight. That's it's too aggravating. Yeah. It's oh my god. Yeah. You have a eraser, but I'm gonna make you eat it. No. It, yeah. No. I graduated class of 600. I was the only Jewish kid.
Good morning, everyone. Good morning, thank you. So we are about to get started with the day. My name is Melissa Gerard. I am the Community Events Coordinator at the Foundation. And so I just had some housekeeping notes really quick before we get the day started. So if you look in your booklet, you'll be able to find the schedule for today. It starts on page 14. And everything is color-coded to let you know where you need to be. So if you are part of our community, the orange parts are for everyone. That's where we'll have all of our meals, times that we come together. Any of those times we come together will be in this room. This is where meals, breaks, coffee will be flowing all day long. That'll all be in this room. Everything that is in yellow is for everyone in our community. So whether you're a patient, a caregiver, you're joining us from a firm, that'll all be in this room, and we'll have a busy day. And then our clinicians will be meeting in a separate room. That meeting is invite only. If you have any questions about that, feel free to ask us. But those are all the things that are in pink. So if you're a community member, all you need to look at is the orange and the yellow for the day. The other thing that we have in there is the blue sessions, and those are for our bereaved community. That first thing that they will have is going to be at 9 o'clock in the morning, and I know the agenda says that it is in the executive room, but that has been changed to the committee room. It is right beside the executive room, so it's easy to find. It is on the lobby floor. If you come out of the elevators and kind of go around behind the elevators, it is right there. It's easy to find. Carolyn, one of our staff members, will be up there. She'll be outside the door being able to get you in there. If you have any questions, feel free to ask us. The only other thing I have is there are not restrooms close by on this floor. They're very close by, but you need to go up the elevator to the lobby, and they're right outside of the elevators once you get to the lobby. That is all that I have. So I'm going to invite up our chair of our board, Marjorie Zotterer.
Good morning, everyone. It's so nice to be here. For those who don't know me, I'm Marjorie Zotterer, and I'm a medical oncologist at Memorial Sloan Kettering, where with many of the people in this room, we run the Mesothelioma program there. And I'm chair of the board of directors, as Melissa mentioned, and we've put together a great program, I think, for you over the next day or two. First, yesterday, for the folks who were here, they had a great day on Capitol Hill, really advocating for funding dedicated or specifically called out for mesothelioma through the Department of Defense. And I think folks had a really great meeting yesterday, so that was great. And certainly in future years, something if other folks want to get involved in, there's always opportunities for advocacy. And then today, I think along with Kara Haymaker and Tobias Pikert, who chair the Scientific Advisory Board, we've put together a great program in all the different domains of groups that are here today. So I think you'll see some familiar and some new faces throughout the day talking about all of the different pressing issues that we're thinking about. I was thinking a lot, for some of you who've been to other meetings, you know, we've had meetings here at this site before, and I remember my first Meso Foundation conference was here probably, I don't know, a dozen or so years ago. I was very, very pregnant at the time, kind of waddling around. And, you know, I was thinking a lot about that experience and the things that I've been through, things that people have been through all those years. And the thing that keeps me engaged, the thing that keeps me coming back here is the incredible sense of community. So the community that we have as researchers, the community you guys have as patients, families, bereaved loved ones, community of sponsors from the law firms, from pharmaceutical companies, and the intermingling of all of us together about a disease that we're all touched by, whether it's personally, professionally, in some other capacity, and that we're all passionate about it, that we take time away from our busy lives to be here and to be together and to think about these issues and to prioritize what the foundation needs to do. And I think that the most important thing that we do is this, or at least in my mind, it's one of those things. I think it's a unique thing that we do, bringing everyone together. And I know for me, in addition to the folks that I deal with, back in New York in my practice, being here is always reinvigorating and energizing and is what motivates me to do more, by seeing all of the people who are touched by this disease and knowing that there's so much more to do and so much more we want to do. And that's just kind of my perspective. I also want to take a moment to thank the staff who have been slaving away for all the details to bring this event to fruition. And just maybe take a moment for a round of applause for them, because they really do a great job. And just thank you all so much for being here, and I think we're going to have a great couple days. So thank you.
Let's begin. So our first presenter will be Allison Massey-Tanner of Memorial Sloan Kettering, and she will give us a foundational talk about what to expect from this conference in terms of jargon, terminology, concepts, so that you're prepared for all of the next talks that you'll be able to better understand once you go through this one. So, Allison, can we get you up here? Yeah, just the arrow
Forward, okay. Hi, everybody. It's nice to see some familiar faces in the room. I am going to be your professor of Meso 101 today. We're going to be talking about the basics, hints and tips to help you better understand the medical terminology and language that will be used throughout this conference. So here we go. All right, so meso. There are 3 different cell types or histology, and this is based on the appearance of the particular cells. So you get your biopsy, the pathologist actually looks at the cells underneath the microscope, and he or she will then tell us what the cells look like. There is epithelioid, sarcomatoid, and then biphasic or mixed. So epithelioid is the most common type. It is about 50 to 70% of all cases. It tends to respond better to treatment. Sarcomatoid occurs in about 7 to 20% of all cases. This is more aggressive and more resistant to treatment. Biphasic or mixed is about 20 to 30% of cases, and this is a combination of both epithelioid and sarcomatoid. And the pathology reports may actually give you a percentage of which is the more dominant histology. Let's talk about staging. So typically we use the TNM system, so tumor node metastasis, and this helps us figure out if the cancer is phase 1, 2, 3, 4, right? Stage 1, 2, 3, 4. So tumor indicates the size of the tumor or deeper tissue involvement. Node indicates regional versus distant lymph node involvement. And metastasis indicates if the meso has spread outside of that primary region. So together, you all get a TNM staging, which then basically gives us whether it's a 1, 2, 3, or 4. For peritoneal, you might actually see a PCI, or a peritoneal cancer index, which is a score that's calculated by giving each of the 13 abdominal regions a score from 0 to 3. 0 being no tumor, 3 being the tumor greater than 5 centimeters. They add it all up together, and so a higher score indicates that there's more widespread or larger tumors. Once we have the stage and the histology, that then drives the treatment plan, right? So if you are a stage 1 epithelioid, perhaps surgery would be the right next step. If you're a stage 4 sarcomatoid, maybe a systemic treatment would be the right next step. Make sense? Okay. So let's talk about surgery. In terms of plural, PD is pleurectomy decortication. This is a lung-sparing surgery. So the surgeon will go in and remove just the pleura or the lining of the lung, but they leave the lung intact. EPP is extrapleural pneumonectomy, which means they actually remove the entire impacted lung, the pleura, and all the structures around it. For peritoneal, you'll see cytoreductive or debulking surgery. Cytoreductive is also CRS. After cytoreductive surgery, there are two different ways that we can give intraperitoneal chemo. One is called EPIC, and the other one is HIPEC. Now, EPIC stands for early postoperative intraperitoneal chemotherapy. During the surgery, they typically put in a port, and about 6 to 8 weeks after surgery, we start to instill the chemo. HIPEC is hyperthermic intraperitoneal chemo, and basically, when you're in the OR, they directly instill the chemotherapy into the open cavity. Okay. So in regards to systemic therapy, that means treatment that goes through the whole system. So this is supposed to get any cancer cell wherever it might be. So your medical oncologist will choose the best therapy based on what we talked about already, staging, histology, and if you have identified mutations, which I will get to in a few slides. So there's a couple of different ways that we can go. There's chemotherapy, which is cytotoxic, and it stops the growth of rapidly dividing cells. There's immunotherapy or immune checkpoint inhibitors, where we actually harness the body's own immune system to fight the cancer. Precision medicine is a personalized medicine based on the tumor's morphology. And then targeted therapies is actually a type of precision medicine where it actually targets a specific protein on the cancer cells. Treatment, systemic treatment can be given in a whole number of combinations. It can be given in a whole different number of patterns. So let's talk about the way it can be given. So adjuvant treatment is given after surgery. The goal is to reduce the risk of recurrence of disease. So an example is surgery followed by adjuvant chemotherapy. Neoadjuvant is given before surgery. It can also be called induction therapy. The goal is to make sure that the surgery is more likely to be successful. An example of this, in your notes, you might see neoadjuvant chemotherapy. Multimodality treatment is combination therapy. So if you get chemo, surgery, and radiation, that would be multimodality treatment. It can also be used to talk about combination treatment. So in some cases, people will get a combo of both chemo and immunotherapy. I wanted to use the word IO here to show that IO is a shorthand way for writing immunotherapy if you see that in any of the presentations today. In regards to lines of therapy, this talks about the treatments themselves. So the first chemotherapy that you ever get, or the first systemic treatment, I should say, is your first line. The next one is your second, et cetera, et cetera. You might see 1L noted. That's shorthand for first line. Another way that we can target cancer is through radiation. So external beam radiation therapy is a non-invasive radiation beam that focuses specifically on one part of the body. This can be given in multiple different ways. There's photons, there's protons, there's a whole slew of things above my pay grade. But there's also IGRT, which is image-guided radiation therapy. There's IMRT, intensity modulated radiation therapy, and SBRT, stereotactic body radiation. And clearly I spelled therapy wrong there. Sorry about that. There's also TTF, or tumor treating fields. An example of this is Novocure or Optune. And basically this uses electric fields to exert forces right on the cancer. So think like microwave ablation, high-frequency electric fields, things along those lines. Okay, clinical trials. So clinical trials are actually also known as research protocols. We kind of use the terms interchangeably, so you might see that. An objective of a clinical trial is the question, the why. Why are we doing this study? What are we looking for? Methodology is about how we're going to execute the trial. Desired outcomes and endpoints is basically what is the most relevant answer to the question, right? What's the question we are trying to answer? There's a whole bunch of alphabet soup that comes along with clinical trials and some of the research. So OS, PFS, ORR, CR, PR. OS is overall survival. PFS, progression-free survival, so how long people go without the cancer growing. ORR is overall response rate, so in totality, how many people responded. CR is a complete response, meaning can't see the cancer on the scans anymore. And PR is partial response, meaning that the cancer shrunk but is not completely gone. Many clinical trials will have arms, meaning that participants are divided into specific groups within the trial. So think Arm A will get drug 1, Arm B will get drug 1 and 2, and that clinical trial might be wondering if addition of drug 2 helps drug 1 be more effective, okay? I get a lot of questions about placebos when I'm talking about clinical trials, so I just thought I'd take the opportunity. It's unethical to do a trial where people only get placebo, right? So you're never gonna see a study where Arm 1 gets drug 1 and Arm 2 gets placebo. What you might see is that both Arm 1 and 2 get drug 1, but then that first drug might be a combination with the placebo versus drug 2. Does that make sense? And then again, it's a question of, did drug 2 help drug 1 be more effective? Clinical trials can also be randomized or non-randomized. So randomized is a trial in which the participants are divided at random into separate groups. There's literally a computer in the back that just spits out which group you're going to go into. And sometimes this is blinded, which means that your clinical team actually does not know if you are getting drug 1 or drug 2. It's all basically like on the computer. Non-randomized is a trial in which participants are actually specifically allocated into an intervention based on controlled methods. So if you have this mutation, then you go here. If you have this mutation, you go there. Clinical trials have 4 phases. Phase 1 is early phase, and this is when they're basically just evaluating safety and tolerability. So like if we give you a medicine, is it safe? Is it going to cause harm? And can you tolerate it? Phase 2 then takes the medicine and gives it to more people and checks for effectiveness and safety. Phase 3 then compares that medicine to standard of care. So is this better than what we already have or not? And then phase 4 comes after approval, and this is basically when you're evaluating the medicine like in real life, right? You're giving it to a lot more people, you're looking at it for longer term effects, and you're seeing more potentially rare side effects. So now we're going to talk about genetics and mutations. So this can get a little confusing. Germline mutations are inherited from your parents at conception. Examples are BRCA1, 2, Lynch syndrome, cystic fibrosis. So you get this from mom, you get this from dad, you share it with your siblings, you could potentially give it to your children. Somatic mutations are genomic alterations that happen after conception. So examples are HER2, ALK, EGFR, BRAF. This is the mutations within your cancer cells. It is not something that you get from mom and dad. It's not something that you can pass on to your kids. Next-gen sequencing, or NGS, actually looks at these somatic mutations. So I'm sure a lot of you guys have had Foundation 1 or Guardant 360 run on your tumors. This can be done in multiple ways. They're tissue, blood, and saliva. So tissue is actually looking at the cancer cells themselves. And then blood and saliva, sometimes we can actually pick up the DNA of the cancer within your blood or saliva, and then actually we would be able to forego an invasive biopsy. If on the next-gen sequencing you have alterations, mutations, things along those lines, that actually might lead you to be able to get clinical trials, and it's going to be where most of the clinicians are focused on for new and emerging treatments. And then lastly, once you have your NGS testing, your clinician might offer things such as novel therapies and gene therapies. Novel therapies is personalized medicine, so it's going to be targeting a specific protein or mutation within your cancer cells. And in doing so, if your cancer cell is the only thing that has that mutation, it will spare the healthy cells around it. Gene therapy is an emerging area, and this actually is an alteration of the genes, and this can be done through immunotherapy, viral therapy, and gene transfers. That's all I have. Hopefully I didn't go through that too quickly. Any questions? All right, if anything comes up the next day or so, I'm around, so feel free to just come up, introduce yourself, and I'd be happy to answer your question.
Thank you very much. It's very appreciated. So we have a few minutes, and because we are running a couple of concurrent meetings, our plural team is in the other room. We're going to wait for them to arrive. Meanwhile, I'll just share a couple of things with you. First of all, at 9 a.m., if you're a member of the bereaved community, we will have a celebration of life ceremony. As Melissa mentioned earlier, there has been a change of rooms for that. So in your booklet, it says the executive room, but it will actually be in the committee room. It is on the lobby level, just above us, so on the same side of the hotel. Everybody's welcome to it, but just bear in mind that this will be an emotional moment for many people. So, do attend if you're prepared for it. And then I really wanted to stress the importance of the sponsorships. The sponsors of this conference have been extremely generous. We could not do this without them, no question. They've been true partners in all of the work that we do. So I do want to give them some prominence. As you might have seen on our signage, Bellick & Fox is our top sponsor. Our next sponsor is MRHFM. Both of them are law firms, plaintiff law firms for asbestos lawsuits. So just to be clear. And I'd like to play a couple of messages that they've recorded for all of you. It's just a few seconds long, and since we have the time, I'd love to do it right now. So, James, are we good with that? All right, excellent.
Hi, my name's Joe Bellick, and I'm the founding partner of the law offices of Bellick & Fox. We support the mesothelioma community by providing first-quality legal representation to mesothelioma patients and their families. We're proud to support the Mesothelioma Applied Research Foundation so they can continue the work that they do every day on behalf of mesothelioma patients and their families.
And here is the MRHFM message for all of you.
At MRHFM, we exclusively help mesothelioma patients and their families. It's all we do.
This is why we are proud to sponsor the Mesothelioma Applied Research Foundation and its work to fund mesothelioma research and provide support services and education for patients and their families.
So in addition to Bellick & Fox and MRHFM, our other sponsors are Bristol Myers Squibb, Polaris, Merck, the Gorey Law Firm, Ikena Oncology, the Early Firm, and Novacure. So I just want to give a round of applause to all of our partners without whom we couldn't do this. Yes? I believe so. I see some hands raised over in the back as well. Yeah. Where's Free Taylor? All right. So, Dr. Friedberg and Dr. Sturman, we will begin with you because you're here.
Good morning, everyone. Was that too loud, Dan? Oh, okay. Good morning. It's a privilege to be speaking to all of you today. I'm a thoracic surgeon, and I thought what I would do is sort of for patients and caregivers kind of give you a background of how to think about surgery and some of the things that we think about from our end. I have no conflicts to report. I will give the disclosure that to a great extent, especially when you're talking about surgery for mesothelioma, and I'll make this point throughout the talk, a lot of what I'm going to tell you is based on my personal experience of doing this for the last 25 years. So what I'll give you is my take on what a patient or caregiver should understand before considering surgery as part of their treatment for this cancer. And I'm talking about pleural mesothelioma, not peritoneal. And then if time allows, we have some case studies that we could do, and then I'll try and answer any questions as best we can. So, selecting patients for pleural mesothelioma surgery. You start with this. There's different roles for surgery in the field of medicine. So take appendicitis. If you go to the emergency room with appendicitis, it's a pretty short conversation. You can have surgery or you can die of appendicitis. Pick one. So it's the only treatment. Then take something like early stage lung cancer, where if that cancer hasn't spread and you can see it's contained within that part of the lung, if you take that out, you can cure someone with surgery. So we know, because lung cancer surgery has a great staging system, that if you're a stage 1, your best chance of cure, black and white, is going to be to have surgery. Pleural mesothelioma is neither of those. It just doesn't fit into that category. And the issue is that you cannot achieve a microscopically complete resection, meaning that you can't remove all of the cancer. There's going to be, because it lines the surface, all the surfaces in the chest cavity, even after the most aggressive operation, there's still going to be invisible or microscopic disease remaining. And the analogy I'll sometimes tell the patients is it's like scraping paint. It can look like you got everything. If you go up there with a microscope and take a look, somewhere you're going to find a paint chip. So if you're doing surgery for mesothelioma, you have to combine it with other treatments because you cannot cure someone with surgery alone. So here's some facts about it. Surgery for pleural mesothelioma, let's be clear, I tell this to every patient, it is not standard of care. And I'll talk about this MARS-2 trial in a moment. But basically, some people, especially in the UK, might make the argument that surgery is contraindicated because of the latency period between asbestos exposure, which causes mesothelioma, and when you develop the cancer, most of the patients are higher or older, which means they're going to be higher risk. Achieving a macroscopic complete resection, which is the goal of these operations, it's a colossal operation, whether you spare the lung or take it. The current staging system, which you just heard about, does not account for some of the most important things that we as surgeons look for to say, yes, you're likely to benefit from this. So we're talking about selecting patients without an accurate staging system for a colossal operation that is not standard of care and is typically conducted in an older, higher risk population, right? So this is a big deal sort of decision-making thing. So here's what I think needs to happen for a patient to have surgery. The patient needs to be a safe candidate for the operation you're planning. It has to make sense from an oncologic, from a cancer perspective. and the patient must give informed consent. And again, this is not standard of care treatment. So, these office visits for me are often, hour and a half, 2 hours. I have to go to sleep at night knowing that if a patient signs up for this, they understand exactly what they're getting into. So how do you select patients who might benefit from surgery? Well, let's start with the first one, being a safe candidate. And the short version is you basically have to be fit enough to tolerate the surgery. And there's two operations we do. There's one where you take the lung out, and there's one where you save the lung. Personally, I just do the latter. I do the other one for other cancers, but not for mesothelioma. You have to be, taking out a lung is just like you would expect. You have to be, more fit, more robust, have a better performance status and everything else if you're going to take a lung out. So if that's part of the procedure that's being offered, that's sort of a higher bar to cross as far as your fitness. Here's what gets sticky. It has to make sense from a cancer perspective. And here's the big problem. You just heard about the TNM staging system. And again, lung cancer, breast cancer, colon cancer, if you tick off those things, the tumor, the nodes, and whether or not there's metastases, you know what the right treatment's going to be. Our staging system doesn't account for the two biggest things, at least in our series and in most, that will prognosticate for whether or not you're going to benefit from surgery. And that's the subtype of the disease. You just heard there's an epithelioid subtype, a sarcomatoid, and then cleverly called biphasic or mixed, which has the two types together, and the tumor volume. Those things are probably the biggest prognosticators as far as how successful or how much benefit you can expect from adding surgery to your other treatments. That's not in the staging system. This cancer is highly variable in presentation, so these are both patients I had with mesothelioma, and I would tell you that if that one with the tiny dot is sarcomatoid and the other one is epithelioid, it's a possibility that even though it's earlier stage, although it's later stage by the staging system, the one with the bigger tumor could potentially do better. So you have the different cancers, which the epithelioid or the sarcomatoid can behave differently. These are two different patients. These are two different operations, taking the lung out or saving the lung. Saving the lung, you can have a lot of tumor, a little tumor. So without a highly predictive staging system like we have for lung cancer, you have to assess each one individually. And that's not the case for mesothelioma. The two different operations, you can see the one on the left is where you're saving the lung, you take out all the detectable tumor. The one on the right is where you've taken out the lung, and you can see those white patches where they've reconstructed the sac around the heart and the diaphragm. So those are the two operations that we use to achieve a macroscopic complete resection. And then it gets even more complicated. I said you have to combine other things. So there's chemo or immunotherapy before surgery, after surgery. You can have radiation before or after. There's all sorts of intraoperative treatments. I personally am a fan of that, doing something at the time of surgery. You know there's invisible or microscopic disease remaining. That's an opportunity to attack the cancer one more time. The timing, when you do it, how you combine them, there's absolutely no standardization. And we're talking about a scary, rare cancer, maybe 3,000 cases a year in the United States, maybe 10 to 20% of those patients having surgery. And institutions, there's few places that do a significant volume of this tend to have, we're still working in silos, unfortunately. People are not, so there's no agreement like you would have with lung cancer, breast, that this is what you do, this is what you combine with it. Straightforward, right? So how do you get, life's like this, right? Risk benefit, which, do the benefits outweigh the risks? And how do you figure out if it's worth it? So I want to mention this. This just came out, this was presented at the World Lung Conference in Singapore just about a month ago. And this is the MARS-2 trial where they randomized patients in the UK to have surgery and chemotherapy versus chemotherapy alone. And what they found was at a median follow-up of 22 months, the chemotherapy group alone saw a survival of about 25 months, an overall survival you just heard about, and surgery was about 19 months. So it was, quote, a negative trial for surgery. At 42 months follow-up, there was no difference. But what I got out of this is that chemo alone, 25 months for patients who were fit enough to be randomized to surgery or not, To me, that's kind of the bar I think you need to cross. There has to be expectation that surgery is going to contribute significantly beyond that. If you're doing surgery, and again, a lot of times you're talking apples and oranges. A patient in the UK with the tumor that they were operating on may be totally different than what you're presenting with or what your family member's presenting with. So these aren't absolutes. But as a general rule, I would say that there has to be expectation from your surgeon and the team that that person is working with that if they add surgery to systemic therapy, which you should be receiving because that is the standard of care, that the surgery should benefit, that you would see more survival. And I kind of, in my mind, have 25 months as what that would be. So until we have a staging system that includes, and we just redid the staging system, we now have the 9th edition, and we added a measurement of the thickness of the tumor volume on the CT scan and the fissure, but we don't have tumor volume. So we'll probably need AI on that, and we're working on that right now. But until we have that and some molecular markers, et cetera, at this point, I would say selecting patients for surgery is still more art than science to a great degree. And then the last thing, informed consent. You know, your surgeon needs to make sure that you understand exactly, you know, what you're getting into and the risks and benefits. So, you know, what I would say is, you know, who should have this operation? You know, when I'm done, this is, I've showed this slide here before. I just love this. This guy named Raleigh Free. This is at Bonneville Salt Flats. He's driving a Vincent 150 motorcycle. And the way they set the land speed record in Bonneville is there's that line, it's a lake bed, and it's 3 miles long, and it's just a black line. And you get to go one time down, and you turn around, you come back, and they time you. And this guy went down and missed the world record by about a second. And he stripped down, before they could stop him, he stripped down to his Speedo. This is like probably the most famous picture of motorcycle. He stripped down to his Speedo. Why he kept his helmet on, I don't know. He would have been hamburger if he fell off. But he shed that weight, he spun around, and he set the world speed record. And I got to tell you, you know, when after I consent a patient and they decide that they want to do this, and it's usually, you know, I want to see my granddaughter graduate from high school or something like that. You know, this is kind of the mentality that I think of, that kind of courage. And the other thing I would tell you is that, you know, you need a team to do this. So if you're considering surgery, if family members consider surgery, you need to go where people are working as a team. That's absolutely critical. So I put together some case studies if we want to do that, Maha, however. So, okay, so I'll save those. So this slide, we can bring them up whenever.
So Bill, come on up. So my apologies, I was supposed to preempt Dr. Friedberg, but he stole the show at the beginning. So I'm Dan Sturman. I'm from New York University, formerly a partner of Joe's at the University of Pennsylvania. I'm the moderator for the session, and we have about 10 minutes, and we've got an expert panel up here and an expert audience. Many of you may have been considering surgery or have gone through surgery. And so on our panel today, well, behind me, we have Bill Ziegler, a patient who's been through this. We have Dr. Chong Huang from the NCI, Joe Furberger, who you've met, Ibayo Dagago Jack from Harvard, who is a medical oncologist, who'll be talking to us shortly about systemic therapy, and Taylor Ripley from Baylor, who's a thoracic surgeon who performs his operations. So we're open for questions if you have them. We have about 10 minutes or so. If anyone has questions from the audience, or maybe we have comments from the panel, specifically about the issue of surgery. So let me ask the question. I have no skin in the game. I'm a pulmonologist. So is surgery over for pleural mesothelioma? Should we not be doing it at all, period, after the BARS 2 trial?
So my answer is no, but like in my mind, what we got out, so if you're going to have exactly what they were doing there, then I would say no. But if you're doing something different, which most of us are, and I asked Taylor, but I mean, I think if we have a median survival with the same sort of subgroup of patients and we're between 5 and 7 years and they're seeing 19 months, I cannot ethically say that, no, that it doesn't make sense to continue.
But I do have in my own mind now that the bar that if we're doing a trial and the median survival is 26 months, and it seems like a similar population to what Mars 2 patients we're seeing, then I would say, no, you shouldn't be doing surgery. But if you're going to be adding, years beyond if surgery has expectation that you can add years beyond what you would see with the systemic therapy alone, then I think it's still reasonable to continue it.
Bill?
So as a patient myself and recalling back 12 years almost now, being out in the audience at a conference similar to this, I couldn't help but think to myself, should I be going through surgery? Do I qualify for surgery? So as a newly diagnosed patient, who should be considering consulting with the surgeon?
Taylor?
Well, I think all the patients should consult with a surgeon. There's really no disadvantage to being seen by a multidisciplinary team. So I think the point is to see a surgeon, see a medical oncologist, see a radiation oncologist, see a team that works as a multidisciplinary team in which we use a tumor board in order to discuss. But seeing a surgeon is a low-risk endeavor. It doesn't mean you have to go to surgery. The vast majority of patients I see do not go to surgery, but I still spend a significant amount of time talking to them. As Dr. Friedberg mentioned, I know when I have patients with mesothelioma on the schedule that I try to block out a much larger percentage of clinic for those patients because the discussion is just harder and more nuanced than the remainder of the tumors that we manage. Additionally, I never see a patient once and then go to surgery. It's usually a multi-step evaluation and a multi-step discussion before we put surgery on the table. So I would say see the surgeon.
Let's open up to the rest of the panel. So what others think about this?
Yeah, I agree. There's absolutely no reason not to see a surgeon. If only to hear from the surgeon that surgeon's not. I mean, I see patients all the time who got sent in by a well-intentioned community oncologist said, you can't do surgery for this. And sometimes they're right and sometimes they're not. I think it should be a surgeon who says you're not a candidate.
I'm going to make one comment there. It's not whether you can, it's whether you should. I think it's really important. Those are two it seems very subtle, but these are very technically skilled surgeons. So whether or not they can technically do the operation is not the question. It's whether they should do the operation, right? So Dr. Tagogo-Jack, what do you think?
No, we just chuckled to ourselves that I'm not a skilled surgeon, and so I know that I know this about
Me neither.
myself. Yeah, I'm a medical oncologist. I'm not a surgeon, and so I personally don't like making the decision as to whether or not someone should have surgery because it's not within my expertise. And so we do see people kind of as part of a multidisciplinary evaluation just to make that determination. I think your doctor probably has some sense. One of the key points that was mentioned here is, can the body tolerate surgery, right? So in clinic, sometimes someone will have heart disease or other things that I know that surgery may not be the right thing to do. In that case, I think that I feel comfortable talking about how surgery is not the ideal thing. And I think we don't have wonderful large trials to tell us, even for people going for surgery, whether to do chemo first or treatment before or after. But I am starting to think a little bit more about doing some sort of early therapy before surgery, even for patients that we're considering surgery, because our goal at the end of the day is we want to learn as much about the biology of the cancer as possible to try to figure out if doing more, right, being more aggressive will be beneficial.
Dr. Wong, should we be doing any surgery outside of clinical trials?
Actually, that's a very thought-provoking question, particularly for this. And actually, I'm going to echo and summarize in just slightly different way everything everybody else has said, which I completely agree with, is that, and particularly where I'm from at NIH, we view all cancers as quite complex. I don't think there is a single cancer out there that is quote-unquote easy, and that is appropriate to be managed by any single medical professional. I think it's a team effort. It is a multimodal intervention and treatment, and therefore requires input from multiple different medical professionals with different viewpoints of expertise. And and I think mesothelioma is sort of a poster child for being very complex. We don't quite understand it, and therefore we don't quite understand how to treat it very well. And I'm pretty sure everybody would agree that even with the team effort, it's still a difficult task to figure out the question about should. And so in a roundabout way to answer your question, I think that there's much more bang for the buck, so to speak, in a trial that we can glean, especially for this particular cancer, which is quite rare. There's not enough cases to go around.
I want to hear from Bill again.
Yeah, before I get to my next question here, I just want to let everybody know that the bereaved celebration of life is getting underway in the committee room. So just to let everybody know and be aware. My next question has to do specifically with newly diagnosed after they do qualify for surgery. Let's say they consult with the surgeon. Where should they be getting their surgery, and why does that matter? Because I was so fortunate to find the Mesothelioma Applied Research Foundation and see great surgeons like yourselves. Could you tell us a little bit about why it's also important to have a great facility behind you?
Yeah, I mean, this is, I think I can speak for the other surgeons on this one. Of all the operations we do, I think this one's probably the hardest. It is certainly the most taxing, and there just aren't a lot of them. So it's like anything. I mean, everyone in the audience has something that they do, and you just know that the more of it you do, the better you get at it. And it's just a really challenging cancer. And the other thing is that it's not standardized. It's not standardized. So this is not an operation someone should be doing once every year or two. It is just something where you need to go to a center of excellence that does this type of work and has the medical oncologists, not great surgeons, but great medical oncologists and pulmonologists and radiation oncologists who will be part of the team and are facile with the treatment of mesothelioma. I mean, I think you probably are a testament to the fact that that's just so important.
Last couple of comments before we have our next speaker. Any thoughts, Taylor? Any additional thoughts you want to share with the audience?
Sure. Can I ask one follow-up question after
Sure.
Taylor?
Oh, go ahead, Bill.
Well, as a patient going into some of my consults or meetings with my doctors, help me get feedback from you all on what kind of questions I should be asking so I can learn more, so I know what to do next, and I can take that next step.
I think the one thing I would say, right, I think surgery, we have to kind of go away from the concept of thinking of surgery as a single day event, right? I think there's a lot that happens after surgery, and so I think an important thing is, and people ask it, right? So what is the recovery like? How long will I be in the hospital? How can I expect to live after? Like, what am I gaining and what am I giving up by going through this surgery? And then what are the risks, right? And I think we have to be realistic, even when you take someone to surgery, that perhaps the outcome you intend may not be what happens, right? And then so people are as informed as possible, and there's that informed consent that we talked about, and you sign it having had all of the information. And I also think that if you feel after that conversation that you are completely overwhelmed and you want to take a step back and then discuss it with your family and discuss it with loved ones, I think that's okay too, right? It's okay to start by gathering the information. I don't think anyone expects you to make an immediate decision that day.
Last comment?
The only other thing, at the end of the day, you are literally going to be trusting your life to someone while you're asleep for 10 to 14 hours, and then they're going to be taken care of. So you don't have to be drinking buddies, but you definitely want to respect and trust your surgeon. I think if you don't have that feeling, it's probably I would think a non-starter. You need to have that aspect of the relationship has to be intact, and that's not something tangible. That's something only you will be able to sort out.
I'm going to take moderator's privilege here, and we're going to have lots of chance for additional discussion on this topic and others, and hopefully questions from the audience over the course of this morning and then throughout the day today. Our next speaker is Dr. Abayu Dagogo-Jack, who is an assistant professor of medicine at Harvard Medical School, a thoracic medical oncologist at Mass General in Boston, Massachusetts, and she'll be talking about systemic therapies for mesothelioma.
Also, panelists, thank you for your answers.
Perfect. Thanks, everyone. So as the sole medical oncologist on the panel, my name is Ibi Dagogo-Jack. As mentioned, I'm traveling from Boston, so not too far. And the focus of my talk is really systemic therapies for mesothelioma. And so a couple of key points. This is a short talk, and so I want to make a couple disclaimers. So we're going to largely focus on pleural mesothelioma, but a lot of what we do for peritoneal and other sites of mesothelioma, we borrow from pleural mesothelioma. We're going to focus on treatments that are used in the United States, and I'm not planning to discuss any specific clinical trial therapies because the clinical trials that are available can vary, kind of depending on when you need them. And so you've heard this already, right? And I think it feeds into how we think about systemic therapies as well. There are 3 major subtypes of mesothelioma. Most tumors are epithelioid, but we also have kind of a subset of tumors that are sarcomatoid, and in between we have biphasic tumors that have a little bit of both. When we think about systemic therapy, we tend to lump together biphasic and sarcomatoid. I hope that in the future we won't, as we get better in terms of kind of profiling tumors, identifying biomarkers and other things. But for the sake of conversations about systemic therapy, we tend to think of these as similar in terms of having some sort of a sarcomatoid component. And so that'll come up again as we kind of move through these slides or move through this discussion. And so the beginning of the slide uses the word systemic therapy. When I meet most of my patients with a new diagnosis of mesothelioma, and I use that word, they're like, what is systemic therapy? What are you talking about, right? Because if I go through most of my life having not encountered a diagnosis of cancer, that isn't a term that I toss around all the time. And so I think it's important to distinguish the two concepts, right? A local therapy is what you've heard about, right? It's surgery or radiation, and sometimes we talk about a type of treatment called ablation, where you either use kind of radio frequency waves, you use heat or cold to try to kill the tumor. What I'm talking about is systemic therapy, typically given intravenously, so through your veins or sometimes through a pill on a trial, not any of the therapies we're talking about now, that goes throughout or courses throughout your system, your bloodstream, with the hope of getting to all the sites of the tumor. And so traditionally, this has been chemotherapy. More recently, we've started to incorporate immune therapy. And then, of course, there's other kind of clinical trial drugs. And so one of the other things that people kind of ask me when they see me, and one of the medical terms we use a lot, that it isn't something we're born with an understanding of, is immunotherapy, right? So if you're not in the medical field, you may not have encountered immunotherapy before, and so it's a foreign concept. And so so this slide just exists to try to talk about the 2 relevant types of immunotherapy in mesothelioma. And so at the most basic kind of maybe oversimplified way to think about immune therapy is that you have cancer and you have an immune system. For some reason, the immune system can't engage with the cancer. And if we take it back, kind of like maybe many of you traveled here today, right? To get here, you had to pass through security at the airport. We call it checkpoints, right? And you had to show documentation. They had to prove that you were safe to proceed. We have similar checkpoints in our body, and these checkpoints are places where our immune system interacts directly with the tumor or interacts directly with an intermediate, right? We call these antigen-presenting cells. They hold up foreign proteins like a billboard, so your immune system knows exactly what to look for. The ways that the system can break down is if there are certain proteins on this cancer cell or on the tumor cell that tell the immune system that it's not foreign and calm the immune system down so it can't attack it, or if there's a block in the ability of that intermediate cell from presenting kind of the tumor particles so the immune system can recognize it. And so there are 2 flavors of therapies that block this. One is a PD-1, PD-L1 inhibitor. They're drugs like nivolumab or pembrolizumab. Problem here is that the PD-1, PD-L1 prevents its express, or prevents the immune cell from recognizing the cancer. So if you block it through an intravenous medicine, so an IV medicine, the immune cell can now recognize the cancer. The CTLA-4 is a little bit harder to explain. The drug that is most relevant in mesothelioma is ipilimumab. Here, the T cells are too tired, right? They're not engaged enough because there's another protein called CTLA-4 that tells them they don't need to be activated to attack the tumor. So in mesothelioma, these two particular checkpoints are relevant when we talk about systemic therapy. Another framework that we think about when we talk about systemic therapy is how can we tell if it's working, right? People ask me that. And so if you ever come across any medical literature or something, they use a couple of key terms, right? Response, we look for shrinkage. We're happy with shrinkage, but because mesothelioma can be hard to measure whether or not it's responding, we also like disease control, right? If you can stabilize it for a long period of time, that's good as well. We also use a term called progression-free survival. We tend to think of it as the time between starting treatment and when the cancer grows or someone unfortunately passes away. And then overall survival is just time between starting therapy and passing away. I present this just so it helps us think about the goals of treatment, right? So our goal as medical oncologists, as surgeons, as radiation doctors, et cetera, is to shrink and control the cancer. We want to halt the spread of the cancer for as long as possible, and we want to help our patients live as long as possible, and importantly, with a good quality of life. And so those are our goals for our treatments. Hopefully one day we'll say our goal is always to cure patients, but hopefully one day we'll get to that stage. And so what are the treatments we have available right now? So standard therapies your doctor can write for you if you have a new diagnosis of mesothelioma. So the standard initial chemotherapy is 2 drugs at the same time. This was kind of set as a standard about 2 decades ago. One is called a platinum drug, either carboplatin or cisplatin, and the other one is pemetrexed, sometimes called Alimta. Logistically, both of these are given together as an outpatient in the clinic. People are not hospitalized when they receive this treatment. It's 1 round or 1 cycle is every 3 weeks. We tend to give it for 4 to 6 rounds. Most people don't continue on the treatment because we haven't had sufficient data to tell us that it's better to continue some sort of maintenance. Rather, we give people a treatment holiday and we monitor the cancer. Some doctors do things differently, so your doctor may have continued it as maintenance. There are some doctors who might add a different chemotherapy to this cocktail. So now 3 drugs called bevacizumab or Avastin. That blocks the blood vessels that the cancer may need for it to survive and for it to traffic or migrate to other sites. That is not approved by the FDA, but there are trials supporting it, so your doctor could write that for you as well. So what can I expect as far as side effects from platinum pemetrexed? The most common side effects are fatigue, nausea, and so your doctor would typically give you anti-nausea pills and give you instructions on how to take them. Diarrhea and constipation, I tend to think of these as being related to the nausea pills, not necessarily related to the treatment itself, the chemo itself. Chemo targets rapidly dividing cells, and so people have lower blood count. As part of this chemo cocktail, people get folic acid and vitamin B12 to help prevent the counts from being too low. Sometimes if the counts are too low too long, your doctor might give you blood transfusions or kind of growth factor boost. You can also get swelling, allergic reactions. Rare, you can have an allergic reaction. So people get steroids when they get the chemo. It's not common to lose your hair completely from this regimen. People can have hair thinning though. And then depending on whether or not you got cisplatin or carboplatin, sometimes you can get nerve pains, some ringing in your ears. Important to mention that to your doctor if you have that. And your kidney function is monitored very closely on treatment. In fact, before each treatment. I think it's important to note that about 1 in 10 people end up stopping treatment due to a side effect completely, but others may need to interrupt it, so higher rate of people needing to interrupt it and a higher rate of people needing to reduce the dose to find the optimal dose for your body. What about immune therapy? So the standard immune therapy regimen is 2 drugs as well, so we call it a doublet of ipilimumab, targeting that CTLA-4 protein, and nivolumab or Opdivo, which targets PD-1. Each round is twice as long as the chemo now, so it's 6 weeks. Again, given IV as an outpatient, you don't need to be hospitalized for this, but a little bit different in that the ipilimumab you get once every 6 weeks, and nivolumab you get 2 or 3 times during that 6 weeks period, depending on what your doctor selects. You usually, unlike chemo where I said you stop after 6 to kind of 18 weeks, so 4 to 6 rounds, here you stop after 2 years if no progression. And the idea being that you've now re-educated your immune system as to what to kind of traffic your body and look for. The side effects of immune therapy are different from chemo, right? So most people don't have that fatigue, the nausea, etc. But when you rev up your immune system to attack a cancer, it can cause inflammation of your organs. It can look a little bit like an autoimmune disease. Most people do not get it, but it's important to recognize that you can get inflammation of the thyroid. Your doctor should monitor this lab test. We tend to look at it every 6 to 12 weeks on treatment. If you have skin toxicity, you can get a rash or itching, diarrhea. If intestinal toxicity, rarely people can get lung inflammation that causes a cough or shortness of breath, adrenal gland inflammation, kidney inflammation, or brain inflammation. These are all very rare. More commonly, you can have some achiness of your joints. I think nothing is too small to bring up to your doctor because it could be related to the immune therapy, and it does respond to steroids as far as the treatment. Here, 1 in 5 people end up having to stop the treatment because of a side effect. I think we should be reassured by the fact that we have lots of data now that says if you stop it because you have a side effect, it can still continue to work in your body because it lasts a long time. And so sometimes, as a doctor, I might have some concerns about giving someone 2 immunotherapies at the same time. We know that adding that ipilimumab increases some of the toxicities, and so sometimes we might give you 1 immune therapy by itself. I'll tell you right now that that's not approved as a single agent or by itself, but there's lots of data supporting it, and so most insurance companies will allow it. And the reason to do this is that it may be more tolerable if you do it this way. And in that case, we tend to pick the drug like nivolumab or Keytruda or pembrolizumab in that setting. So how do we choose between these two, right? Do we have data that tell us one is better than the other for a given patient? And we do. We have a big kind of phase 3 study that gave half the people the immune therapy 2 treatments at once, and the other half the chemotherapy 2 treatments at once. On balance, the immune therapy, people did better when they had the immune therapy, but I think it's a little more nuanced, and I'll discuss that in the next slide. But going back to those metrics that we talked about, right? Response, right? So the response was comparable with the 2 treatments, but the amount of people who had their cancer halted for a longer period of time and the amount of people who lived longer, right, was better with the immune therapy. And so most people who are newly diagnosed now end up getting immune therapy first. But I mentioned it's a little bit more nuanced, right? And that's the reason I mentioned epithelioid and non-epithelioid at the beginning. We've known for a while that unfortunately, when you have sarcomatoid components to your tumor, it doesn't respond as well to that chemotherapy cocktail that I talked about, that platinum pemetrexed. And for that reason, immunotherapy, when you get immunotherapy, on balance, people do a lot better, they stand to do a lot better than if they were to get chemo. And so if you have a newly diagnosed non-epithelioid mesothelioma, most doctors would give you immune therapy first. For epithelioid, there can still be tumors that benefit from chemotherapy and have very durable responses to chemotherapy. And so here it's more of a conversation. If you have an autoimmune disease, if there's some reason that your doctor thinks that you might do better with chemo, they might start with chemotherapy. And so I don't want to make it seem like those are the only treatments available, right? So there are other medications that your doctor can write for you if the ipilimumab, nivolumab stop working or the platinum pemetrexed stop working. There are additional chemos. One is called vinorelbine, the other one called gemcitabine. They're usually given weekly or every other week. Your doctor could talk to you about that. But this is the time point where we also start thinking about clinical trials and kind of talking to other physicians about clinical trials. Clinical trials can be IV therapies or they can be pill therapies. They can be available for all people with mesothelioma, or they might be available only if your mesothelioma has a specific change in it. And so your doctor might talk to you about some tumor testing at this point. And so key points before we kind of open it up to questions. I think it's important to note that we have 2 main types of treatment that are approved for mesothelioma, systemic treatments, immunotherapy and chemotherapy. Most people for each of these categories will get 2 treatments at the same time, so 2 immune therapies or 2 chemotherapies. It really is a conversation about which one to start with, but for non-epithelioid mesothelioma, I tell you most of the doctors in the field feel that immunotherapy should be given first. If you have any side effects, let your doctor know. Sometimes they can progress to become more significant if we don't address them early. Most of these are quite addressable. And I think it's important to note that even after some of these approved therapies run out, there are other therapies your doctors can give you, but it's also important to think about clinical trials and start those conversations early. And so with that, I will wrap up and turn it back to our moderator.
Thank you so much for that fantastic presentation. So we have a few minutes for questions, and we have both our panel and we have the audience. Yes, we have a question from the audience over here, sir.
Wait, speak in the microphone because we're on the live stream and they can't hear you.
Don't be shy.
Okay, thank
I know
you.
the front tables are kind of empty, but don't be shy about questions.
Yeah, I just have a question about the pemetrexed or the immunotherapy. If you've been on that and then you stop because you normally stop after a while, can you go back to those after a while and see if maybe it might help to go back to them if they were successful and they did keep you well enough? Is there any good reason to go back to them, or is it no longer going to be beneficial?
I think that's
after chemo, yeah.
Exactly. I think that's a very good question, right? So we tend to stop chemo before we have any signs that it stopped working, right? Because we want to give people kind of quality of life. And so if while monitoring the off of treatment, you see the cancer start to grow again, we tend to think about, as a 6 month, as a type of cut point where it might be beneficial to re-challenge or retreat with the same chemo. What I mean by that is that if the cancer starts to show signs of growing again within 6 months of stopping the chemotherapy, it's unlikely that going back to the exact same thing is going to be beneficial. And so we want to pick something else at that point. But if it's 6 months out, 9 months out, 12 months out, that means that your cancer was halted by that chemotherapy, and re-challenge or reintroducing that chemotherapy at the sign of growth is a good idea. Similarly with immune therapy, right? We stop at about 2 years for most people. But interestingly with immunotherapy, if the cancer hasn't changed at all, like it's stable and you've been on treatment for 2 years, many people may not need additional therapy. But if you do see the cancer start to grow again, it's a good sign that the cancer took 2 years, it took more than 2 years to start to grow again. And so my colleagues and I would reintroduce the immunotherapy, provided that your body handled it well, right? If we stopped it because you had inflammation of an organ that was severe enough that we felt uncomfortable, all of us, right? You as a patient, me as a physician felt uncomfortable treating you. We find sometimes that, people have done the data and done the studies in kind of other types of tumors, that if you give the immune therapy again, the inflammation just comes back. And so we're a little hesitant. We might do one immune therapy instead of the 2, but we're a little bit hesitant. We need a compelling enough reason to give it, because we don't, at the top of everything, all of our goals is to not cause any harm.
We have time for one more question here.
And this may be part of this novel therapy part of the day, but I had heard about this thing called Optune Lua being used along with chemo or immunotherapy. Have you heard of that? I'm over here.
Oh, okay, sorry.
Sorry.
I was squinting, sorry about that. Yeah, so Optune Lua is interesting, right? So I talked about systemic therapy. So Optune Lua is kind of a local/systemic therapy. For those who are not familiar with it, it's basically a device that you wear, right? It has these, basically, if you've ever seen people get like an EKG or unfortunately like CPR compression you've seen on TV, those sticky pads that they put on. So they basically put electrical current to the tumor, and it's hard to explain, but all cancers need a particular electrical frequency for them to grow and divide, right? And this company's concept is that we're going to break that up, right? We're going to change the electrical charge so the cancer cell can't divide, and we're going to do it in a way that's specific to the cancer cell and not the rest of your normal cells. But the way you do it is you deliver it locally. So you have to wear this little pack, and you have to ideally wear it for at least kind of 18 hours out of 24 hours a day. And so when they did that study, they took people with platinum pemetrexed, the chemo I talked about, we've not tested it with immunotherapy and mesothelioma, and added the little pack, right, the device to it. And they didn't compare it to people who had received chemo by itself, right? So it was just a single arm study. And at face value, the survival when you added that pack looked a little bit better than 20 years ago, right? 15, 20 years ago, when people first did that study that showed that 2 chemos was better than 1. For that reason, because we all want more treatments for mesothelioma, the FDA approved it, right, as something that people can have access to. So I say that all to say that it is an available therapy, but right now in the field, we're not sure if it's better than the standard therapy, and it can take a bit out of your body to have to wear that device for 18 hours or so, but it is worth talking to your doctor about if you're interested in it.
So please hold any additional questions. I do want to give the rest of the panel a chance to comment. From a surgical perspective, how do you look at systemic therapy for mesothelioma in terms of best combinations for what you may have to offer? Taylor?
So what we know with surgery is all the surgical trials and the survival associated with those have been combined with additional therapy. And mostly over the last 20 to 30 years, that's been chemotherapy. And so we always recommend that surgery is given with chemotherapy. However, what we also know is that patients who received ipilimumab and nivolumab or immune-based therapies did reasonably well on the recent Checkmate 743 trial, which we just discussed, that showed better survival compared to at least the historical regimens from 20 years ago. But what we don't know is, do we combine surgery with immunotherapy? So right now, many of us are actually taking that strategy of treating patients with immunotherapy followed by surgery based on clinical trials that are opening at multiple institutions around the country. So I think that our next biggest question is going to be, are the outcomes that we've seen better with surgery combined with immunotherapy as compared to our prior approaches?
Dr. Wong?
In general, to directly address your question, I agree with what Taylor said too, but I view these complex cancers as an opportunity to kind of throw the kitchen sink at this thing. So in general, my general viewpoint is I prefer systemic treatment up front, and if you're going to have any chance to alter the tumor prior to surgery, I think doing it before surgery in general is a good approach.
So I think that's a reasonable approach sometimes, but what we know from the IMPRINT study, which was chemotherapy followed by surgery followed by radiotherapy, the survivors were similar to what we had seen in chemotherapy and surgery, but of over a third, about 36% of the patients who didn't respond to systemic therapy progressed before surgery. So that led to a change where the new IMPRINT study was recommended surgery followed by chemotherapy. Whichever strategy is correct is still, I believe, an unknown. And so if a tumor is surgically resectable and we believe that surgery is the right direction to go, do we do it before or after chemotherapy is still uncertain.
I would provide a counterpoint. I think that my bias is to do the only thing I'm 100% committed to is that the patient receives a systemic therapy. And this is such, with safety in mind, my bias has been to do the chemotherapy or systemic therapy after surgery, because if you have a reaction, one of those reactions that you talked about, you may have gone from a safe surgical candidate to an unsafe surgical candidate. You now have colitis, or you now have some kidney damage. Now your window as a safe candidate may have passed. That said, I am completely, I think these should all be done under a clinical trial, and I think we need to answer that, and we need to be working together to kind of pool those. But given my druthers, I would do the systemic. We do in thoracic surgery, we'll do, some patients will have like a lung cancer that's very central, and you say, geez, if we could shrink that down some, we might be able to save part of the lung, whereas if we operate on them now, we won't be able to, so-called downstaging. This doesn't make the surgery any easier, giving the system. It's not like shrinking the cancer down makes the operation any easier, so it doesn't affect that technical aspect of it for me. So with an eye towards safety, my personal bias, but again, I'm open to doing preoperative treatments, would be to do the systemic therapy afterwards.
We'll come back to this conversation and more questions from the audience in a minute. I just want to take a few minutes and take you through a rapid-fire overview of the active clinical trials in mesothelioma. And just to say two things. One is, I think my bias, especially as someone who doesn't really have a skin in the game, I'm not a radiation oncologist, I'm not a medical oncologist, nor am I a surgeon. One might wonder why I'm here then, but I do sometimes myself. But it's really important for me to think about whether a patient a priori, right up front, should be considered for a clinical trial. And the second thing is, going back to what I just said about my role, I'm a pulmonologist, a lung specialist. I'm the person who might be the first person to see a patient with mesothelioma before we know that they have mesothelioma. I may see you for shortness of breath or chest discomfort or persistent cough. I may be the person as an interventional pulmonologist who does the biopsy that makes the diagnosis of mesothelioma, and I may be the one that has that first conversation with you before you're referred to a center of excellence to see an expert surgeon or an expert thoracic medical oncologist. And so I'm not that dissimilar from you in the audience, the patients and the loved ones, in trying to decide how to navigate what to do. Because again, I'm not an expert in therapy. I'm knowledgeable about diagnosis and staging and a little bit knowledgeable of some of the experimental therapies. So when I think about counseling a patient about clinical trials and I go through the panoply, there are so many, it's almost impossible to really sort out what I should be talking to the patient about, even though that ultimately will be a conversation with, for example, the medical oncologist. So there are surgical trials, and you heard about what neoadjuvant, this is a hot term in all of oncology, which is giving treatment in advance of surgery. I will say that this appears to be revolutionary in lung cancer, and there's some extrapolation to mesothelioma that this may also be revolutionary in mesothelioma, but we need more data. Radiation therapy obviously is something that's really important. We don't know how it fits in with the other trials. Immunotherapy trials, they're both systemic, and then there may be developing intratumoral studies or even combinations where you can deliver the immunotherapies directly to the site of the cancer, potentially in combination with giving things intravenously, again, in an experimental fashion. Chemotherapy studies, interestingly, and I'll show this in a second, as you go through the listings of clinical trials, there aren't that many studying what we would call classical chemotherapy, these drugs that kill tumor cells through so-called cytotoxic mechanisms. More of what you would see, and I'll show you a couple of examples, are so-called targeted therapies, which aren't classic cytotoxics, but rather agents given systemically which target specific abnormalities on the tumor cells themselves. Cell therapy is a very hot area. We have many of the world's experts who are actually here today, will be speaking during the course of today, and hopefully you'll have a chance to speak with them. And you may have heard of what are called CAR T cells, or chimeric antigen receptor modified T cells. And also, not talked about today necessarily, but it's another type of cellular therapy called TIL therapy, where literally the lymphocytes, the white blood cells that infiltrate the tumor, can be harvested from the tumor, grown outside the body, and then re-administered to the patient, sometimes modified. So two different approaches to using your own white blood cells. Some have been pre-educated, some have to be educated afterwards to treat. And then the other thing you realize, and for those of you who have peritoneal mesothelioma or loved ones of those with peritoneal disease, is that the preponderance of clinical trials that you'll find are for pleural mesothelioma. And so there are relatively few trials for peritoneal, and if you have even rarer subtypes, pericardial mesothelioma or mesothelioma of the scrotum in males called the tunica vaginalis, there are no trials designated for those types of mesotheliomas that you'll find in the medical literature. And then when you're thinking about clinical trials, it also can be confusing, and you heard this from Ali earlier, about the different phases of a clinical trial. There are actually 5 different phases, but I'm going to focus on phase 1, phase 2, phase 3. Remember that a phase 1 essentially is for the first and foremost, a safety trial. This is a drug or a drug combination that hasn't been used before. Is this safe and feasible to be used in human beings? Phase 2 means that you've probably done a phase 1 study, and you've shown that it's safe and feasible. Now, does this appear to work? And how it works, you heard from Dr. Gogo-Jack about how we analyze that. And then phase 3, we would compare that experimental therapy to a standard of care. So those are the main 3 phases. And then how do I go through this? Well, this website is something that you should all have embedded in your phones, on your notebooks, anywhere, because this is where I go. This is where I got the studies that we're going to be talking about in the next few minutes. Clinicaltrials.gov is something that the National Institutes of Health has as a resource for all of you. All of the clinical trials that I'll be talking about are listed there. They list whether these are actively enrolling, whether they've completed enrollment, whether they've been shut down, and why. They also have to update data on the number of patients enrolled, the outcomes that have been reported to date, any complications that have been reported. They list the principal investigator. They have her or his email address. You can reach directly out to Dr. Gogo Jack and get her information about a clinical trial she's running. And they even have all the sites, so you can find out if it's a 20-site study, is there a site near where you live? So I am not going to go into any great detail, just to show that I went through clinicaltrials.gov a couple days ago. And I went through literally 130 clinical trials. I'm just going to give you a quick overview, a smattering of some of the ones that I found. And actually, Dr. Ripley and I were discussing some of these today. So one of the key questions that we all face is surgery appropriate? And is surgery appropriate in the new era where we have immunotherapy? And by the way, the MARS-2 trial, unfortunately, did not answer that question. So there are a number of trials, in fact, there are probably 7 or 8 across the country that are looking at combinations of chemotherapy and immunotherapy, or immunotherapy alone in combination with surgery, and certain unique aspects of doing the surgery to try to see if this is going to be efficacious. Now, as you see, 2 of these are phase 1. 1 is a phase 1/2. So none of these is a definitive study that's going to get us to the answer that we need. But really important questions, and going back to what Dr. Huang said, a lot of really interesting biology that we're going to learn from these studies, because a lot of them have a lot of correlates from taking blood and looking at the tumor cells that we would explant at the time of surgery. And then there's some really interesting trials of combinations of radiation therapy and surgery, in which radiation therapy may not be used as you understand radiation therapy, but being used actually as a way of killing tumor cells and creating an internal vaccine where literally you're vaccinating the patient against their own tumor and then removing the tumor. So this first started about a decade ago at the University of Toronto. Professor Marc D. Perot there and colleagues led a trial called the SMART study, where literally they gave really high-dose radiation and then removed the entire lung, an extrapleural pneumonectomy, and showed the patients did really well. And then they've also moved on to Toronto to what's called the SMARTest study, where they're using lower-dose radiation in combination with other therapies to see if surgery outcomes can be better by using this upfront radiation therapy. And others are looking at combinations of radiation, chemotherapy, and surgery to see if outcomes can be better. So radiation does play a role, but in a unique way where radiation almost is an immunotherapy in some of these patients. And then people are looking at radiation in combination with other immunotherapies. So these are 2 trials, one for Memorial Sloan Kettering, one for the Mayo Clinic. One where they're using, we heard about the IMPRINT study from Dr. Ripley, where they're using a type of radiation therapy that can encompass the entire pleural surface in a patient with pleural mesothelioma, and combining that with pembrolizumab. Again, this is a phase 1 study. Again, safety and feasibility. So it's going to just give us some early information about whether this is reasonable and safe to do. And then the group at the Mayo Clinic in Rochester is doing what's called SBRT. You might have heard this as CyberKnife, for example. It's a way of targeting specific areas, almost like a postage stamp focused area of radiation, and seeing if you can do that in combination with immunotherapy, whether that would actually enhance the benefits of immunotherapy alone. Again, an early phase trial will give us some interesting information about safety and feasibility and maybe the biological activity, but it's not a definitive study to say that this should become a standard of care. I will say that the first trial up here, unfortunately, in my search of 124 clinical trials, is, I think, and I can stand corrected, the only phase 3 randomized controlled trial, which is international, in mesothelioma that may be leading to a new standard of care. It's called the DREAMER trial, and it's a beautifully designed study, originated in Australia, now an international study across the world, multiple centers, in which we're comparing chemotherapy and immunotherapy to chemotherapy or combination immunotherapy. And hopefully will give us an answer as to whether chemotherapy and immunotherapy for patients who aren't surgical candidates, and this is an interesting question about whether we should be extending this to those who are surgical candidates, is going to be a new standard of care. A phase 3 trial. We need more of these. We don't have enough. And then the other 2 interesting trials, one at the NCI, with a good friend and colleague, Dr. Rafid Hassan, taking a novel immunotherapy, injecting directly into the tumor in combination with an immunotherapy that you heard about from Dr. Dagogo Jack, ipilimumab, which is given intravenously. Again, a phase 1 study, a feasibility study, and then a really interesting study at Mount Sinai, where before surgery, they're injecting a immunotherapy directly into the tumor, again, to see if they can make the patient have a vaccine-like effect, use the patient's own tumor as a vaccine prior to removing the tumor. Again, this is not an exhaustive list. This is just examples of what you can find in the literature. And then I put chemotherapy trials in quotation marks because, again, ironically, as we think about classical chemotherapy drugs, you heard about pemetrexed, cisplatin, carboplatin. If you look 20 years ago, you would have found combinations of different chemotherapy drugs listed. You don't see those as active trials currently. So these are 2 unique trials, one at MD Anderson led by Ann Tsao. Again, this is a phase 2 study, and one at the University of Chicago led by Hetty Kindler, another phase 2 study. But these are drugs which are not classic cytotoxic chemotherapy drugs, which are targeting specific aspects of the tumor. One, a specific protein on the tumor cell, and the other, a specific mutation in the tumor's DNA. So again, these are probably closer to what we call targeted therapies from the world of lung cancer, which is looking at a specific abnormality in a tumor cell, taking a specific treatment that is targeted against that abnormality and trying to get good outcomes for the patient. I mentioned cell therapies. There are a variety of cell therapies that you'll hear about later today in some of the novel treatments. I think these are really exciting. And again, a lot of them have to do with taking your white blood cells out of your body, genetically modifying the receptor on the white blood cell, the T cell, that binds to other cells in the body, specifically we're hoping tumor cells. And there are unique ways, for example, Sloan Kettering is combining a receptor for an antigen called mesothelin, which is on mesothelioma as well as other cancers, with a way of actually building a checkpoint inhibitor directly into the CAR T cell, which is, I think, a brilliant approach. And there's some other approaches that are being studied now at Penn, my former institution, which I think are very early phase, and we hope to learn more about these cellular therapies. But again, these are not ready for standard of care. These are still early phase 1 trials, really safety and feasibility. And then in peritoneal mesothelioma, unfortunately, we have relatively few studies. Again, looking through the 124 active clinical trials for mesothelioma on clinicaltrials.gov, these were, I think, only 2 that were specifically for peritoneal. There are others that may include peritoneal, but they look at combinations of chemotherapy given into the peritoneal cavity and systemically, adding immunotherapy, still looking for that best combination. But remember that there's maybe 1/10 the number of peritoneal patients as there are pleural patients. And so it's hard to enroll patients into clinical trials, and it's hard to have a lot of clinical trials in this disease. So I try to give you a really rapid overview of clinical trials in mesothelioma. This is my way, again, of what I do when I see a patient, and a patient has a specific stage of the disease, subtype of the disease, other clinical problems. This is the kind of search that I go through. Hopefully you too will utilize clinicaltrials.gov, which is a remarkable resource to be able to get some of this information. And we only have a couple minutes, so I'm going to open up to the panel and say, what do you think about clinical trials? Should this be the first thing that we discuss with a patient, or should we be talking about standard of care first and clinical trials only if patients don't do well?
I would favor with this particular cancer that clinical trials should always be encouraged, personally. Until we're doing much better, I think that clinical, as long as there's expectation the patient's going to get benefit, I ideally would think every patient with mesothelioma would be on the clinical trial.
No, I would agree. I think it's important to be seen for a clinical trial early on. I think most of our clinical trials are focused kind of later line, so after traditional therapies. But I think that one thing to point out with the DREAMer study, unfortunately, it closed like 3 weeks ago because they couldn't get enough people on it. And I think that it really is like education about like the provider community. It's easy to start a therapy off the bat, but a bit hard. We find it a bit more challenging to enroll to first line, so your first treatment trial, because most people see their doctor in the community, right? Not perhaps at the centers that have the clinical trials. So I think it's important for us to start to think about clinical trials from the beginning for that reason, to answer these key questions.
If no one else has a comment, my last comment would be that for this particular disease, I think with the complex biology and the complex treatment, I don't think anybody single-handedly can claim that there is a standard approach. And so by definition, I would echo what Dr. Friedberg said initially, is that they should all come and get considered into a trial in one way or another, either early, late, or at some point. But I don't think that this is a type of cancer that is just routinely treated out in the community and then it disappears.
Can I ask two? Yeah. Can I ask doctors? Can I ask the two non-surgeons here? What are benefits to the patient beyond, I mean, we're benefiting future patients with a clinical trial. That's the real goal at some level. We're trying to learn more, but are there immediate benefits to a patient being in a clinical trial? You're taking both.
You get 2 microphones if you're in a clinical trial.
Yeah. I mean, I think that it's important that, we have to point out from the get-go, right, that we don't know. Clinical trials, for the most part, are exploring investigational therapies, right? So we don't know, especially phase 1, right? So we don't know how well it's going to work. There may be some aspect of your tumor that makes your doctor think, usually based on laboratory studies, that makes your doctor think that maybe your cancer might benefit, right? But the other thing I would point out, kind of along holding these two things true, is that the therapies that we talked about started as clinical trials, right? The only way to get across the finish line with our current regulatory climate is to start as a clinical trial and make your way through phase 1, phase 2, phase 3. And so for that reason, I don't think that the absence of your doctor being able to tell you this will directly benefit you right now is necessarily a deterrent for the clinical trial. I think that you have to have a very involved discussion of the potential side effects, how far along the trial is, what it would take for you, right? Do you have to travel 10 hours for this trial? Does it make sense within your journey at that point?
Let's open to the questions to the audience. Are there any questions to the audience regarding the clinical trials for myself or any of the panelists?
We have a very quiet audience today.
Oh, there's a question in the back. Thank you so much for the question. Hopefully you're not a plant. I did not talk to you beforehand.
I actually have 2 questions.
Great, thank you.
One is about the chemo immunotherapy combo and what you're seeing. And the second is about CAR-T and TIL and how pervasive is that? I saw that those trials are happening at 2 different hospitals, and do you have any information about those?
For the chemo-immuno, it is the standard of care across a bunch of different diseases, including kind of our neighbor in the chest, so the lung cancer, and so the rationale for borrowing from those standards is the reason to do those trials. What was presented was a chemo plus an immune therapy called durvalumab, but there's other ones being conducted kind of across the US, across the world, looking at other combinations. This was a phase 3 study based on phase 2. Phase 2 means they already know how safe, they already know what doses to use. There was one conducted in Australia, one conducted in the US, that showed that people tolerated it just as much as we expect from immunotherapy, right? So those side effects I talked about, the chemo side effects I talked about, there were no brand new side effects, and there wasn't any additive side effects. And there was a hint based on a single arm design, meaning they didn't compare to anything, that people might do better with that than the historical standard of chemo by itself. At the beginning, I mentioned that there's many different immune therapy combination trials because I wanted to kind of leave a little room to mention a different trial. that we saw at one of our conferences this year, which was looking at a different immunotherapy called pembrolizumab, right, Keytruda, in combination with chemo. And there they directly compared it to standard of care chemo. People live longer when they got the chemo plus immunotherapy. That has not made its way to our approvals yet, but that's the reason people are excited about these combinations of chemo plus immune therapy. So I would not be discouraged that that one has closed early. There's multiple ongoing ones, and we hope as providers that maybe one of these will stick. There are some intriguing things that we see, but it's all of us are working hard to try to figure out who is it that would benefit from maybe getting 3 drugs, right? 2 chemos, 1 immune, or 2 immunes versus 2 chemos. And we still, as a field, have our work cut out to try to sort through that.
We have the question about CAR Ts. Dr. Huang, you're at the NCI. We have a lot of TIL therapies and others going on to the NCI. Do you want to make a comment about the current status from your perspective of the status of cellular therapies?
Well, in particular to TIL, we do a broad, ongoing, long-term intervention trials with TIL, but notably, we don't do it for mesothelioma. So I'm very familiar with the TIL program under Dr. Rosenberg's guidance, and they've tried multiple different types of solid tumors, but this is one of the ones that is not currently being pursued, and I'm not sure why, although that's a good patient question, and I'm sure if you make a referral to the NCI, we'll ask Dr. Rosenberg together, but there are considerations too in terms of being able to, this is an unusual tumor, unlike the other ones where part of the TIL treatment is that you have to have visible tumor left, or at least in the current incarnation, you have to have visible tumor left behind so that they can monitor the effects of the TIL treatment itself. So this is, I'm not sure how we would work out those logistics, at least for mesothelioma. It's a little weird tumor because it doesn't manifest in wide distribution. It's predominantly localized to one chest or the other in its most common form.
We're going to shift gears a little bit, and we'll have time for other questions and comments afterwards.
Can I also just say one thing?
Go ahead, Maya.
We do have breaks together with our clinicians and scientists, and that was on purpose. Please don't be shy. Feel free to go up to them because that is the entire point of this conference. So we can do your question. Can we do it after the presentation? Thank you.
We'll do a couple quick case presentations. So these will also be forums as we discuss these cases for more questions, and so you can incorporate your questions as we present these cases. So this literally is a patient that I saw Tuesday, and from a pulmonologist perspective, is a both an interesting case presentation, but also, unfortunately, an all too common case presentation. So this is a very nice 71-year-old gentleman, originally from Croatia, emigrated about 50 years ago to the United States, who works in the construction industry. Former smoker, just for 7 years. He quit almost 50 years ago. And as I mentioned, he had significant occupational asbestos exposure history. So starting in 2020, he presented to his primary care physician with episodes of pleurisy on the right side. Pleuritic chest pain, pain that occurred when he took a deep breath, and he was found to have fluid which was accumulating in his chest. So this went on for a year, or over a year, and finally he ended up in the emergency room. And in the emergency room, he went in, and you can see on the top left-hand side, you'll see what's called an axial section of a chest CT scan. There's a cross-section through the chest at the level of the heart, which is in the center. And on the right-hand side, it's actually your left, but his right, you'll see some grayish fluid which is surrounding the right lung. This was felt to be pneumonia with what's called parapneumatic effusion, which is the inflammation of having an infection in the lung causing an accumulation of fluid. So they drained the fluid from his chest in the emergency room, sent him home on antibiotics, sent the fluid off for analysis, and did not make a diagnosis, neither of infection nor of cancer. And at the bottom, you can see the repeat CT scan that he had just a couple of months later. And as you look at his right-hand side, which is your left, you'll see an area at the very bottom of the right lung, this little area, arcuate area of density. This is just what's called atelectasis, or lung that's not fully aerated, left behind from when the fluid was there. And so he went on for several more months and had more chest discomfort and was found to have more fluid, but not a lot, not enough for another drainage procedure on a chest x-ray done. So this is now almost 2 years into having recurrent right-sided chest pain, presenting to doctors, presenting to an emergency room. And finally, he has a chest CT scan done now almost 3 years after initially developing symptoms. This chest CT scan now shows not just fluid, actually minimal fluid, but shows thickening of the right-sided pleura and adenopathy, which means enlargement of lymph nodes in the center of the chest and on the side of the chest near where the thickening was. And the concern on the read of this chest CT scan, now 3 years later after presentation, was for a possible mesothelioma. They then did a PET CT scan, which is a combination of an anatomic study and a metabolic study, which allows you to look at both the structure of the organs of the body, in this case, the structure of the thickness of the lining of the lung, and the metabolic activity. And they saw that the metabolic activity was elevated in that lining as well as in some of the lymph nodes. And then at a community hospital, he underwent a procedure called a bronchoscopy, which is putting a scope with a video chip at the end through the mouth. Some of these scopes have ultrasounds built into them, and they could then go down and sample some of those enlarged lymph nodes that were seen on the CAT scan and on the PET CT scan. And unfortunately, the biopsies were, again, non-diagnostic. They saw what are called atypical cells, but they were not enough for the pathologist to make the diagnosis of any cancer, let alone mesothelioma. At this point, now 3 years later, he was appropriately referred to a community thoracic surgeon who performed what's called a video-assisted thoracic surgery, which is a way of using small incision surgery, cameras inside the chest, to try to visualize the chest cavity and take biopsies of the thickened lining. And finally now, in March 9th of 2023, 3 years after initial symptoms, an egregious delay, honestly, to make the diagnosis of mesothelioma. And have you heard from Dr. Dagogo Jack and others, there's different subtypes. This subtype was the most common, called epithelioid. At this point, he had been in a community hospital, and he was then referred to our cancer center at New York University in New York City. And our surgeons are experts in robotic thoracic surgery, and he was interested in, not that there's actually a wide range of published experience in mesothelioma, but he was referred for consideration of robotic surgery. Our surgeons looked at the results from before, and to their credit, we presented the case at our multidisciplinary tumor board, and the decision was to repeat the bronchoscopy because of the findings on the CT scan, and specifically the PET CT scan that showed increased activity in the lymph nodes. We did not believe the non-diagnostic results from the outside hospital. So our interventional pulmonary group went back and repeated this endobronchial ultrasound-guided biopsy, and all the lymph nodes sampled showed evidence of epithelioid mesothelioma. So now we have a patient who has had a pleural biopsy done by a surgeon confirming mesothelioma, and we have multiple lymph nodes that are involved with mesothelioma. And so he was started on treatment by one of our medical oncologists, who's an excellent thoracic medical oncologist, but not a mesothelioma expert, with the combination that you heard from Dr. Dagogo Jack, pemetrexed, Orlimta, and cisplatin. And he tolerated the treatment quite well. And our oncologist repeated the PET CT scan after 2 cycles of chemotherapy. And the patient's disease appeared to be stable, both in terms of the thickness of the disease as well as the metabolic activity. And the treatment plan, the treatment was going well. He had no adverse effects. The initial plan by our oncologist was to complete about 3 to 4 cycles and then have the surgeon that originally saw the patient at our cancer center go ahead and do the surgical resection. And then the patient saw me. And then we were talking about what else could be offered for this patient if surgery were not going to be an option at this time, because the patient wasn't convinced this is what he wanted to do. So based upon the medical literature, there were a number of options that were discussed with myself and the thoracic medical oncologist together with the patient. We could add bevacizumab, which is a so-called anti-angiogenesis therapy, which in a large randomized study in France, when added to chemotherapy, showed some benefit for the patient. We could, based upon the study that was recently presented at the American Society of Clinical Oncology, again mentioned by Dr. Dagogo Jack, we could add pembrolizumab to his regimen. We could consider, for the question of the audience, adding tumor-treating fields to the treatment. And if the disease will progression, there is data from the CONFIRM study from Dr. Dean Fennell and others around the world that at that point, single-agent immunotherapy with nivolumab might be appropriate. And then I was asked, as someone who does know something about mesothelioma, whether this patient should go on to surgery. And I had to say that at that time, given the extent of nodal involvement at baseline, despite the fact that he had done well with therapy, that I was not thrilled, and we'll hear more from the panel what their thoughts are, about going ahead with a major cytoreductive surgery in this patient with multiple nodes involved, despite the fact that he appeared to be doing well with therapy. So what do pulmonologists do? We order pulmonary function tests. I thought this would just be fun because we rarely show pulmonary function tests at a mesothelioma conference. It is interesting that when you measure lung function, because mesothelioma is often pleural mesothelioma is a circumferential disease that surrounds the lung, you can actually use, and some studies have used, one of the measures called vital capacity as a response measurement to see where people are responding to systemic therapy. So the other thing that's important to do if you're taking a patient to surgery is to have these as baseline measures so that you can compare afterwards, because part of the quality of life measure will be to see whether or not lung function is impaired. So the patient continued to tolerate the treatment well, minimal side effects, did very well, no shortness of breath, continued to have evidence of a clinical response, although not dramatic, and his PFTs were normal, and certainly, if he was going to go ahead with surgery, were more than adequate at that time. So based upon the initial discussions with a medical oncologist, while waiting for the decision about surgery, he had pembrolizumab added to his regimen. So he had 2 additional cycles of pemetrexed, carboplatin, and pembrolizumab, and then has been on maintenance therapy with pemetrexed and pembrolizumab since that time with an excellent performance status, and with a repeat PET-CT scan just done last week, which showed continued decrease in thickness of the pleura, decreased metabolic activity both in the pleura and in the lymph nodes. And then we had just come back from the World Conference of Lung Cancer, where we had heard the MARS-2 trial results. And at this point, we decided to defer further intervention, and so a surgical intervention, I should say, and he is going to continue on his current maintenance therapy. So I open to the panel. What should be done next? Should he go ahead and have surgery? Should we have done surgery already? Dr. Dagogo Jack, did we do the right thing by adding pembrolizumab to the regimen, which is not currently standard of care? What do people think about this entire presentation?
Well, I'll start. So it's an incredibly interesting case, and I would tell you that, we've talked about the deficits in the staging system for mesothelioma right now compared to, at least with respect to surgery, compared to other cancers that we treat, where we know the stage is this, you're going to benefit. And to some degree, I would almost say that each treatment that you do, surgery-based treatment, almost needs its own kind of staging system. And so looking at our last 60 patients, which we presented at World Lung, the lymph nodes did not meet statistical significance. There was a trend toward not doing as well if you had lymph nodes involved. The big one was tumor volume. If your tumor volume was over 500 milliliters, then you would be better off not having surgery. And then the major one was the subtype of the disease. So this patient has low volume disease, and I would just kind of eyeball it. I haven't seen the rest of it, but I would guess that that's going to turn out to be 200-300 mils. It's not a lot of cancer, it doesn't look like. And it's epithelioid subtype. I would personally have the discussion with him, and he's already declared that he has a more indolent form of mesothelioma than most, although it appears to be accelerating now. But 3 years without doing anything for the most part, the tumor's kind of telling you that, maybe this is a window of opportunity. I don't know. So I would personally have the discussion with him saying that lymph nodes aren't good, but for us, in our hands, it would not be an exclusion criteria. But I conclude every one of these visits with the patient saying, look, at the end of the day, if you decide you don't want surgery, I'm the last one in the room that's going to argue with you about it. It's not standard of care. It's ultra aggressive. So a lot of this comes down to what is this patient, does he want to be really aggressive? In which case I would consider offering him surgery. You'd have to go through the rest of the testing and so forth. But right now he's treading water, and if he's happy with that, and he's obviously has a reasonable quality of life, then I think that it's fine to continue doing what you're doing. But if he's of the mind that I want to be super aggressive, I personally would think that surgery, it would be worth having the discussion with him.
Other thoughts? Feel free to give constructive criticism.
Also, I cannot in my wildest dreams envision being able to achieve a complete macroscopic resection robotically, because I do this operation to get the tumor off the surface of the lung requires inflating the lung to do it, at least the way I do it. So I would be worried about having, gross tumor left behind.
Yeah, I agree with that. I think a robotic approach to targeting this tumor is very unlikely to achieve our goal. And the goal is MCR, macroscopic complete resection. It's defined as removal of all visible and palpable disease that is clearly associated with better survival. So our goal is not to eliminate incisions. Our goal is to eliminate tumor. And if we compromise on that, surgical outcomes will not be adequate, no matter how we get there. I do a lot of robotic surgery, but don't think it's appropriate for a case like this. And then lastly, I think talking about this patient specifically, this is an unusual situation. And this patient situation is important because it shows what we see as clinicians and what you deal with as patients, and shows our limits of our trial. Our trials show this patient had progressive disease after one treatment, therefore we treated and we showed some response. But how do you incorporate a patient who initially got cis-PIM approved in 2004, then added Pembro, not quite approved, had a bit of response on chemo, then progressed, then didn't progress on chemo immunotherapy, and then draw a conclusion from that? It's essentially impossible. Right. So I think we've got to set some baselines, and the baselines are going to show us what comparison should be. Dr. Sherman has talked about randomization, and when patients are not randomized, they're put in a single-arm study, such as a phase 2, and all receive one treatment. And the comparison is to compare to history or other tumors. If you look back at the median survival of the original chemo article, it was 12 months. If you look at the current studies, the control arms are the same regimen, and they're significantly higher, up to 16 months. So if we're comparing back to 2004, I think it's no longer a standard. And fortunately, patients have done better with surgery, and they have done better with chemo. But across the board, these newer trials have had median survivals about 18 months. Checkmate 743 with combined immunotherapy, MAPS with adding Avastin, they're all about 18 months. And then what we saw in Mars 2, which still has a lot of data to be vetted, the median survival was 19 months. The original, one of the major original trials was in 1999, before patients were selected appropriately by Dr. Sugarbaker. The median survival was 19 months. Now, our data that's coming out with the new staging system is showing that the median survivals can be 29, 30, or even higher in surgical patients. So we have a more modern baseline. So if we do look at phase 2 trials and they're compared to data from 20 years ago, I think that's no longer appropriate. Our historical control should be basically 2017 and onward, so that we're speaking about how patients with the modern regimens do, which fortunately has improved substantially.
No, I think it's a very good point. The only other point I would make is that I think as much as we can, I know that it's not easy to do so, is I think we need to determine upfront if we're going to take someone to surgery or not. And the reason being, it gets a little confusing to try to figure out what we call the contribution of components, right? What is helping someone when you start with chemo and then you add immune or you add all this. And I've done that. I've been guilty of doing that in practice as well, right? Where I did it last week, where we did 2 cycles of carbopem and then we're like, well, it's stable, let's add durvalumab, let's add something, right? But I think that this is why we like clinical trials, to get back to the question of clinical trials, because to really document whether or not people are benefiting from that type of approach, you have to do it in as rigorous a fashion as possible, right? And that's the reason when I gave my talk, I said throughout it, your doctor might do something different, right? Even the question of maintenance pemetrexed, right? Whether to continue it after 4 rounds. I think we have nice data that suggests that it might not benefit most people to do so, but I still have colleagues who do it, right? And people who feel like it's helping the cancer and you want to do more at that point. And so I think that, this case to me just highlights how individualized our treatments are and how we need to invest at the same time in clinical trials, but we also need to listen to the patient in front of us too, right? Maybe in this case, that was the appropriate thing to do, like to add the immunotherapy based on the data that we've seen. And I think it also speaks to what the doctors were thinking there, right? Sometimes we have trials and our approvals haven't caught up to the trials yet, and we as doctors feel uncomfortable kind of not doing what we think might be a better therapy while waiting for the government or someone to approve the therapy. And so do I give many people in my clinic the combo of chemo plus 1 immune therapy? Yes, if I can get their insurance to say yes.
I'm going to make just a real quick comment and then end this. Everybody made shared great perspectives and viewpoints, and I agree with all of them. This type of case, at least where I practice, we would view as a window of opportunity to do the case surgically. You have a guy with indolent disease that has self-declared biologically. He's done well despite nodal involvement. He's got an epithelioid favorable histology. He has actually responded to drugs, and while the response to drugs has kept things stable, there's still tumor there. And at the end of the day, if all things being equal, or the patient is either willing, healthy, and informed, this is one of those opportunities where I think you stand as a large community to gain a lot of information, both on the doctor and patient side for this type of particular case. This is a very interesting and nuanced presentation.
This is a great segue, too. Let's hear about a surgical case.
Yes. Hi, Joe. So that's a great point, and the quality of life thing. So Melissa Culligan, who's not here, is actually doing her PhD on quality of life studies related to patients having surgery for mesothelioma. I think it's something we've been focused on: overall survival, controlling the disease, but not
for this cancer, where surgery is not standard of care, if you're talking about surgery, I think quality of life needs to be weighted equally with the extension of life. And that's a common question. That's something that we often face, and probably one of the best things for that patient, if I were to see him, I would have him talk to patients who have had the surgery. At least the surgery that I do. You know, it's different if you're taking a lung out or you're not taking, you know. So you try and find an analogous patient and someone who's got a comparable sort of state of fitness and have him talk to them. But that's really, you know, to establish that connection is probably the only way he can have it in his mind. But like I said, you know, if at the end of the day, you know, he doesn't want surgery and he's thought about it, you know, that's, but people come in all the time. I hear patients, lung cancer, everything else, you know, I'm not going to get him, you know, I'm not going to get chemotherapy. You know, why is that? Well, you know, my sister's friend's cousin's mother knows this guy who lived down the street from someone who owned the fishing store, and he got chemotherapy and he lost all his hair and then he died, you know. And so, you know, they need to get it firsthand. And for someone concerned about the quality of life, and he may talk to one of these patients who's had it done, and they'll say, that's not for me, and that's fine. But I'd say at this point in my heart, I don't feel like he would be giving informed consent either for or against surgery without talking to someone that's had it done. Dan, did you want to do some? So I put together a couple of case studies. You know, mesothelioma is not mesothelioma is not mesothelioma. So I just put these sort of brief scenarios together, and maybe we could go down the panel and see what each person. So this is this one, a young patient with this very little amount of disease. So it's a healthy 43-year-old woman. She ran the Boston Marathon 2 years ago, and she did the Broad Street Run in Philly last year. She had a car accident. They got a CAT scan. Everything was okay, but they found these small nodules. And she saw Dan, who sent her for robotic surgery, and she had a biopsy. And that little tiny thing right there turned out to be sarcomatoid, pure sarcomatoid mesothelioma. So maybe we could just go down the line, what each person would counsel this patient or what you would offer. Taylor, you're first.
So this is a rare situation, and I'm sure that's why you put it up, because sarcomatoid mesothelioma is a less common histology, and it historically has had the worst survival, and the patients struggled with this disease the most, regardless of therapy. There's an exception to that now I'll mention. But the first thing I would do is fully evaluate, get a CT scan, make sure lymph nodes are assessed, see what the extent of disease is, because detecting sarcomatoid disease in an asymptomatic patient picked up with a car accident is really unusual. So most patients present with sarcomatoid with a symptom, chest pain, shortness of breath are the two big common ones, and then we treat. What we know is, I think sarcomatoid, the data in sarcomatoid has been the most interesting and the most impressive in the last 20 years. In Checkmate 743, which is the trial that showed the immunotherapy showed benefit maybe as compared to chemotherapy with ipilimumab and nivolumab, the median overall survival was about 18 months. The chemotherapy arm was 8 months, which was in line with prior studies. And so the increase was from 8 to 18 months with immunotherapy. That was the biggest jump in survival in mesothelioma of a trial that's ever been seen. So I think that immunotherapy has really become the standard in the frontline therapy. However, somebody with one spot in one location, I've never seen a patient like this.
Well, there's more. If you scan the rest, there's nodules sort of throughout.
So he's hiding things. It's the gotcha scan.
It's minimal disease. The whole tumor volume's maybe 50 mils. It's just these. When Dan went in with his robot, what he saw was, that there was sort of studding of the parietal pleura and some of the visceral pleura, but it's really sort of just tiny little nodules sort of throughout.
Would you treat?
Would you offer the patient surgery?
In an early stage, young, healthy, fit patient, I would offer her surgery.
And would you save the lung or take the lung?
I would save them, almost never take the lung.
Okay.
Yeah, I think to me, so it's a young patient, has a sarcomatoid histology. I think that maybe, we talk about something called lead time sometimes, right? I think that maybe we're just catching it very early because of the car accident. I would worry that, no disrespect to my colleagues, but I would worry that no matter what we did locally, that this cancer is stubborn and it would find some way to come back. And I would also kind of have a little bit of reservation about the sensitivity of my available tools in terms of detecting the disease, right? So a PET scan. And so you have to have a certain amount of tumor volume. And I say that to say that I think that we're underappreciating the volume of disease. And so this is a patient that she's young, she's healthy. I probably would give immune therapy with or without surgery, because I think that perhaps this is our opportunity. The thing that we lose sometimes when we talk about medians, when we say the average person lived this long versus this long with this therapy, is that immunotherapy, and the reason that we like immunotherapy as medical oncologists is that there's a tail on the end of the curve sometimes, right? There are some people who are here many, many years later, and we right now don't know who they are, but maybe that's this lady, and maybe by giving her the immunotherapy now, her immune system, when there's a lower burden of disease, can now start patrolling the body and try to figure out what it needs to be attacking. And so to me, this is an excellent candidate to give a doublet of immunotherapy, cross my fingers and hope that she tolerates it, and it might be less work for her immune system to do it now at the volume of disease versus trying to have it battle a lot of disease in her body.
So this goes back to our conversation about can and should. Right, so there's no question that we have 3 superb surgeons here in the audience that they could get a macroscopic complete resection on this patient. Unless there's a lot of hidden disease that we're not seeing used on PET CT scan or other workup that the patient has. The question is whether that's the right thing to do. It's important that if you look at the medical literature, and obviously the medical literature is not the sum total of all knowledge, but it's where we base our decisions, there's never been a surgical trial showing any benefit to a patient with sarcomatoid mesothelioma. Period, end of story. So if I'm discussing this with the patient and discussing it from a medical literature perspective, I could say technically it can be done, but I don't think it should be done, and I would refer the patient to medical oncology.
John, how about you?
Again, I always drop back to the opportunity to learn more. I think this is, again, a rare opportunity to learn a lot about a disease that we don't understand how it progresses very well. I acknowledge every comment is correct, is the literature doesn't support intervention in this particular subtype of histology, but again, being where I am a little bit biased in terms of gaining more knowledge. So.
All right, now I'll give you the right answer. No, so I would be extreme, so one thing, every patient, especially with this cancer, is different. That's the way I think you have to look at it, because this cancer is crazy. Sometimes, and these guys will tell you, you'll be operating and the cancer will be soft, almost jelly-like in one part of the chest, and another part will be like, like a piece of wood. Some places it peels off nicely, in some areas it's invasive. It's extremely variable, and so the course of these patients is as well. I would be, even with that, so I would tell you that even to take that out, it's going to be a big operation. And I would agree with Dr. Sturman. Outside of a clinical trial, I personally would not operate on that patient, with the exception that she got the immunotherapy and maybe 2 years later she's behaving, bizarrely, and it's sort of slowly growing and it's remained in the same place. At that point, I would consider doing something off protocol, but it would have to be that it's like every now and then there's 2 types of lung cancer, right? There's small cell, which is the one that spreads early and often, and then there's the non-small cell, which is the one that we operate on. But every now and then you take out a nodule and they go, it's small cell, and you call the pathologist, you go, no, you mean non-small cell. They go, no, it's small cell, because you have one that's behaving like the other. This would have to be, for me to operate on this patient, it would either have to be on a clinical trial or it would have to be behaving like an epithelioid, not like the sarcomatoid, which, as Dr. Sturman said, our studies and everyone else, we just really haven't seen a benefit of adding surgery to the systemic therapy. How about this one? So it's this patient, 82 years old, and let's put him between these two. Let's say he has about, you would guess, sort of a lower volume disease. He presented with a pleural effusion and shortness of breath, which is how a lot of these patients present here. Maybe I can find, here. This is how he presented. He presented with shortness of breath, and so this is actually an interesting scan. So this is the left side, this is the right side. The black thing is the right lung. This is a patient I took care of in Baltimore. This is the left side. All this gray stuff is fluid. That little tangerine there, that's the lung. It's all squashed down. Dr. Sturman talked about atelectasis. That's the lung all squashed to nothing. The heart is getting pushed over to the other side. See, this is the diaphragm, your breathing muscle. See how it's like a dome, which is what it's supposed to be. Look at this side. It's turned in like this, and that's the stomach getting squashed. And this explains a couple of presenting symptoms that you or your loved one may have had, where the patients who present with fluid like this have two things. One, they have shortness of breath, obviously, but the other thing is they can actually have what's called early satiety, or I take a few bites and I'm full. Well, no wonder. You got a 2-liter bottle of Pepsi pressing down on your stomach there. Of course you're going to get full quickly. So that's one of the reasons that intervening early to remove the fluid. But let's say that this is that patient. He's 82, but he's still, he works in his wood shop. He walks, he has dogs. He goes for a 2-mile walk with his dog every day, slower than he used to. He's a non-smoker. He used to smoke a long time ago when he was in the service, which is where he had his exposure. And you biopsy, you drain this fluid, and you do some biopsies, and it turns out to be pure epithelioid mesothelioma. He does not have any obvious nodes, and he's 82 years old. Good 82, but he's, his kidneys, his liver, his heart, everything else is 82 years old. Taylor, what would you do?
Well, he actually, in terms of quality of life, he's most likely going to benefit from removal of the fluid. So that's a simple answer. There's several ways to do that. Usually the most simple is put in a catheter called a Pleurex that many of y'all are familiar with. It sits in the pleural space. You drain it about every day or every other day for a couple of minutes, and it keeps fluid down. But just removal of the fluid, he'll probably feel better. Without doing extensive workup, and my bias is operating on an 82-year-old is pretty rare. I probably would not. I'd put him on multidisciplinary tumor board, discuss with medical oncologists. He'd probably get systemic treatment, and we would just make sure the fluid is adequately drained so he can breathe adequately.
No, I would agree, and I think that one key point I hear as a medical oncologist is that you said his kidneys are his age, so I would presume that his creatinine clearance is not excellent, and that is something we think about when we think about the chemo I talked about. And so I think that if we're talking about systemic therapies, of course I agree with you fully that addressing that pleural effusion is kind of the primary strategy, but I'd probably be leaning towards immunotherapy as the treatment for this patient.
Dan, is he a candidate for a clinical trial in immunotherapy? He's 82.
Well, having gone through the entire 124 active clinical trials right now, and my eyes are blurry from having gone through that, I think there are only 2 trials that I know of, and I think it's Dr. Adusamili may be in the back, I think, perhaps, but he may have one of them, which is an intrapleural CAR T-cell trial, which is a phase 1 trial, which would not be my first choice for someone who's initially presenting with mesothelioma, presuming we've made the diagnosis. And the other is either an intravenous or intrapleural trial, again of CAR Ts at the University of Pennsylvania. That's it in North America right now. So we don't currently have, that's much to my chagrin, intrapleural therapies. So again, going back to the comments, we can control the fluid through any number of different means. We could put in a tunneled pleural catheter to manage the fluid. We could do a pleurodesis procedure by putting talcum powder into the pleural space after expanding the lung. that should be the first and foremost goal, to alleviate the shortness of breath and manage it. And there are lots of different ways that we can do that. I probably would do that and then have the patient go for a multidisciplinary evaluation.
So you would palliate them with a Pleurex catheter? Is that your preferred?
There's been many studies looking at the comparison between talc pleurodesis and tunnel pleural catheter, and they're about equivalent in terms of alleviation of dyspnea. So I think you have a choice discussion with the patient whether, if they don't want to go home with a tube for a few weeks, then you do a pleurodesis. If they don't mind, you can do that as an outpatient. I can almost do that in the office.
Chung, what would you do? Is this a window of opportunity?
No, this is probably where I step off the bus, but the 82, so the age group, in this issue of fragility, I think is critical. And so I think in the general overall calculation, the general benefit of surgery is probably diminished in this particular case.
All right, you guys ready for the right answer again? Again, I would say every patient's different, and personally, my oldest patient is 86, and she actually holds the land speed record for getting out of the hospital in 6 days. It's usually closer to 2 weeks. By the same token, I've had patients in their 40s who have lived hard, and for lack of a better term, I would say are too old to have surgery. I would have the conversation with him if he's in good shape, and we did all the testing, and it looked like he would tolerate it. Older patients tolerate surgery; they don't tolerate complications. And you'd have to understand going in eyes wide open about terrible things that could happen. But if he had low volume disease, epithelioid, he was in good shape, and was of the mind to be aggressive, I would at least have the conversation with him. I would not summarily dismiss him based on his age, but the stakes are obviously higher.
I get to give Dr. Friedberg the hook, which I've wanted to do for the last 25 years. But this session is overdue, overrun, but it's been fantastic. I hope you've enjoyed the interesting discussions, the different opinions that we've had. Thank you for the audience for your fantastic questions. I think we have a small break right now, Maya, so grab some coffee, some snacks, and then another fantastic session coming up. I'd like to thank the panel, Dr. Ripley, Dr. Tagogo Jack, Dr. Friedberg, and Dr. Huang for all being amazing and for never agreeing with anything that we had to say.
Thank you to our panel. We will be back here at 10:50. So please come back. We will start right on time.
So are you a lefty now?
No. So she's interviewing right now. So, but but they. Oh, yeah, come serve. Yeah.
Do you like it?
I don't know. I started December, October 1st. So he learned the system of yeah. So his family school started. $3 RTL. I'm from with that. How you been? Good. They went through all 6 treatments.
Yes,
it's good.
Well, it's good to be back in Philly. Yeah, that's
At this point, I don't think I should do anything.
I just wanted to say I'd opt for surgery every time. Good, how are you?
Good.
I'm still here.
That's good.
So that's pretty amazing.
Yeah.
Dr. Ripley did surgery on me 9 years ago.
Fantastic.
Several times.
No, that was. I still talk about that. How you been doing?
Good. Good.
Are you seeing your tongue now?
Well, they kind of told me surgery's off the table now.
Yeah, if I could just grab your slides, I'm going to move this out of the way.
Pec muscle being, But I've actually.
I think it runs better if it's on the.
Since February.
Do you need the? I have the.
So I've been on Pembroke for 5 years. He's good. He's here. He's in Dr. Come say hi.
Okay, I can do it right before the next presentation.
Yeah.
We have a live chat.
This is the hotel's laptop, so they're gonna wipe it all out. Yeah, you got it.
Exciting.
Wow, okay, wonderful, thank you.
Hi guys, Garrett. How are you? Good. Yeah, to get an arm wrestle. Garrett. Oh my God. I'm good.
I'll come right down, just give me 1 second.
You could run the model in his head and see which parts would fail, like when he did an AC, and then like anytime he built something, like the final thing. Yeah, it's fast. Crazy.
Hi, what'd you think?
That was wonderful.
It was good? Yeah, it was fun.
Yeah, I decided people aren't here for the break, so that was a really good discussion, so I thought it was good, even if it was
Okay. I realize that one of the pictures that I have that the agent's names I'm trying to get rid of. I make sure the presentation's not straight. If you need a copy of my presentation, I will resend it to you.
Yeah, so we'll have to edit it from our video.
Yes.
You got it.
Okay.
I'll
It was on
delete
the
it.
last PET scan.
You got it.
The name. So.
I'm gonna write myself down. No. I thought it was different questions. I do, yeah, I remember now. I need to get them. Yeah. You can do it on my laptop. Or you need the, no, yeah, it's already.
Go
We are getting ready to start again because we are always on time. Just kidding, we've never been on time. This mine, I have to take it, sorry. All right, I have your presentation set up. Well, that's not it. This is it, right? Yep. All right, here you go. All right, our next session we'll be covering novel therapies. We have Dr. Prasad Adusumili from Memorial Sloan Kettering here and Dr. Rafid Hassan from the NCI. And please, the two of you, give us a really good overview.
Okay, thank you. Good morning. I'm glad to be here. As mentioned, my name is Prasad Adusumili. I'm a thoracic surgeon at Memorial Sloan Kettering Cancer Center. Our laboratory research is focused on studying mesothelioma immunology and immunotherapy. Most importantly, what is known as a CAR T-cell therapy for the clinical trial. And my co-chair is Dr. Hassan, Rafid Hassan. Most of you know has done extensive work for the last couple of decades on targeting mesothelin by multiple methods. And he's at the National Cancer Institute. He's the head of solid tumor oncology there. So I just want to update you what we have done, obviously, with the Mesothelioma Applied Research Foundation, has funded us initially when I was a junior faculty. So as we know, just to give you an overall view, you all know that 2003 was first when the dual chemotherapy was approved with a median survival of 12 months from diagnosis. And the immunotherapy, the 2 checkpoint blockades combination, was approved in 2021 with a median survival of 18 months from diagnosis. So that's where we stand. Immunotherapy, obviously in solid tumors, 1 in 5 patients respond excellent, but the other, even other, lung cancer, bladder cancer, beyond that, the responses are not seen. But when we, Elizabeth Zaffe group at Johns Hopkins, when they looked at 5,500 solid tumors, the 2 markers we look at to see if immunotherapy is going to work, mesothelioma, unfortunately, is the lowest of all the tumors in general. And Keytruda, the anti-PD-L1, PD-1 agents that are tried in the second line after the first line chemotherapy has shown a median survival of 10 months. So that's where we stand. So in the laboratory, we have in addition to studying patient tumors, we have a good mouse model. As you can see, with the mesothelioma, this is a tumor encircling both lungs and heart. And that's where what we have done is what is called a CAR T-cell therapy. Essentially, our immune cells recognize anything that doesn't belong to our body, but the cancer fools the immune system. So the CAR T-cell therapy is where we take the peripheral blood in the blood bank, isolate the immune cells, T cells, and genetically engineer them so that they can recognize a protein, which is myself and Dr. Hassan is targeting mesothelin that is expressed on mesothelioma. If we can make into billions of cells, the immune cells of patients' own immune cells, and we give it back to the patient as a blood transfusion. But as many of you know, the mesothelioma is in the chest, so what we have done different is directly giving to the chest cavity rather than giving to the blood. There are several scientific and immunological benefits. And even when we give within the chest, the immune cells that are genetically engineered, these CAR T cells, cancer exhausts them. After a while, the immune cells get exhausted. So that we use checkpoint blockade in the mice to reactivate the CAR T cells and keep them going. These are some of the patient examples where you can see on the screen, left-hand side for you, what is lighting up on the PET scan. Once we give CAR T cells, at least 3 doses of checkpoint blockade, though the patient in the middle is the patient with multiple metastases throughout the body. After giving CAR T cells, survived for about 2 years. And now we have a 5-year, 6-year, and a 4-year survivors. This is after they initially failed chemotherapy, and some of them failed immunotherapy. So this is not from the diagnosis, this is from the CAR T cells. We have treated about 41 patients to date. And as shown in the middle of the 2 boxes, about 2/3 of the patients received these CAR T cells as a second line after chemotherapy, and 1/3 of the patients received after 2, 3, or 4 lines of therapy before. The median survival from the day they received CAR T cells about 16 months. But most importantly, what we translated to clinic, give a dose of CAR T cells, patient's own immune cells, genetically engineered, and then give checkpoint blockade or Keytruda to reactivate them. The median survival is 18 months. So this is very encouraging, and this patient median follow-up is about 52 months. And among them, the PD-L1 negative, technically PD-L1 negative patients are not great responder to immunotherapy, but as you can see, close to 2-year median overall survival from receiving the day of CAR T cells. And these patients from diagnosis are a median survival, that is half of the patients survived more than 3 years. We are getting ready to write this manuscript because this is encouraging. Again, this is 10 years of work done from 2010 to 22, step by step, going back between the mice and the clinical trial patient samples that we have translated. But happy to say, most importantly, which is very important to this group, functional quality of these patients is excellent. We have videos. I do not have permission to show you. We have at least 10 patients after the 15 patients, that is more than 3 years. Unless we tell them on the scan they have cancer, they do not feel anything. Functionally, they keep up the weight, and quality of life is good. This is something different. When we reach constantly in our body, the immune cells, cancer cells are fighting. But I think we reached a state of equilibrium. We are not there yet to completely eradicate mesothelioma, even by this approach, because the cancer is still there on the scans. And of course, this is carefully selected, carefully conducted, high-risk clinical trials. This is what we need to do, phase 1 and phase 2. So I think we reached a state of cancer equilibrium, but the next step, we have done some other modifications, which we hope to start the clinical trial. As we learn, we can modulate more genes as we are learning specifically mesothelioma. So the next clinical trial, we will be modulating at least 4 genes. The results I have shown is 1 and 2, but at least 4 genes. The FDA is very approving of these therapies because of the safety that we have shown. To date, we have treated 65 patients, and we have not had any treatment-related, this particular treatment-related major toxicity. So hopefully FDA will approve our next 2 genetic changes that we are going to put in the immune cells and move forward. So that's a brief introduction to what we have been doing at Sloan Kettering. And Dr. Hassan. So.
Thanks, Prasad. So I don't have any slides, but I just wanted to share some thoughts about novel therapies for mesothelioma and in general regarding patients. So as Prasad mentioned, we have also been focused on developing therapies targeting mesothelin for a long time, used different approaches, and over the last several years we are using again, T-cell therapies targeting mesothelin, similar to what Dr. Adesumilli mentioned, where we take the patient's own T-cells, we modify them in the lab, and then infuse them to the patients. And but what I want to talk about is, in general, if you are a mesothelioma patient, what are the options in terms of clinical trials or novel therapies? In general, in patients who are surgical candidates, and we'll hear a little bit more about that, but especially in patients with peritoneal mesothelioma, in general, we believe that surgery is a key component which has clearly been shown to improve survival in peritoneal mesotheliomas, where the surgeons are able to remove the vast majority of the tumors and clearly improve survival, and that may be one of the reasons patients with peritoneal mesothelioma have a significantly better prognosis. So usually I see patients as a medical oncologist when they are newly diagnosed and where we feel that surgery may not be of benefit. We, of course, have the patient seen by our surgical colleagues. So in mesothelioma, at least we have some options these days. For a long time, it used to be a combination of 2 chemotherapy drugs, which Pemetrexed, Alimta, and cisplatin or carboplatin. But over the last 5 to 10 years, there has clearly been patients with mesothelioma who respond to immunotherapy, and which culminated in the approval of immunotherapy a couple of years ago by FDA approved it. So for our patients, there are options when they're newly diagnosed and surgery is not an option. And the most common type is the epithelial mesothelioma, where the patients, depending upon their circumstances or depending upon the clinical condition, can get either chemotherapy or immunotherapy upfront. And if they respond to it, that's great. If they do not respond, then we can switch it. So we have 2 different type of drugs that the patients can have. If it is sarcomatoid mesothelioma, then clearly immunotherapy is the preferred upfront treatment. So in our practice over the last 2-3 years, we have seen changes in the way the patients come to clinical trials. In general, most of the patients either have had chemotherapy and more commonly have had chemotherapy plus checkpoint inhibitors. So in many of the referral centers, the patients are seen after they have had standard therapy. So that's where the questions come up. What are the novel therapies? What can we do if chemotherapy and immunotherapy is not working? So for that, there are a lot of clinical trials. As you know, the clinical trials are called phase 1, phase 2, phase 3. Phase 1 trials are the very early trials, which are based on activity in animals or in the lab, and they have gone significant rigorous evaluation in the lab to the point where the physicians and the scientists bring them to the clinic, and it's a very regulated process, both at your own institution, but ultimately these type of trials are approved by the Institutional Review Board, and of course also approved by the FDA. So a lot of thought goes into the starting a phase 1 clinical trial. And a phase 1 clinical trials are usually first in human study. These are drugs or treatments which are done for the first time in patients, so they have a lot of safeguards. And usually phase 1 trials are done at bigger hospital, tertiary hospital, where there is sufficient infrastructure to monitor the patient. And that's where many of you will, if you participate in phase 1 clinical trials, get to know your research nurses who are very knowledgeable about these type of studies. And these trials can be very intense, such as the most intense trials are what we call as the CAR T-cell trial or the T-cell therapy trial, where we take the patient's cells, modify them, and give them into the vein or into the pleural fluid, as Dr. Adesumilli mentioned. Phase 1 trials, we need to monitor the patients very closely. We can treat only a certain number of patients at a time, because if you see a side effect in one patient, then you have to slow down the number of patients you enroll and watch the patients very closely, because we are monitoring the patients closely for toxicity. So in phase 1 trials, when I see patients, I discuss the potential benefits. Again, these are first-in-human trials. We can say what we see in the lab, so the patients understand that it is possible they may not get any benefit from the drug, but it's also possible that they could get side effects from the treatment, and sometimes they need to be in the intensive care unit or other complication. But we do have safeguards in place, and we talk about that. We monitor you very closely, so that is a good situation where everyone is keeping an eye out for the patients for any potential side effect. So phase 1 trial in general requires more commitment from the patients, and we greatly appreciate the time and energy they spend traveling many times from all over the country or staying in the hospital for a month or so, depending upon the nature of the trial, and agreeing to participate knowing that they could get side effects and the benefits are not clear. So, but the phase 1 clinical trials are the key. So all the drugs patients get, nivolumab or ipilimumab or chemotherapy drugs, all drugs that are approved go through this process. And so I think it's very important to participate in novel therapy trials and hopefully get benefit. But many of the patients that I see say, I understand that I may not get benefit directly, but it will help other patients down the line, which is really important. So if we do the phase 1 trials and we see the outcomes are that we see some potential benefit, and then we decide to go to the next stage where we treat more patients. We know what the dose is, what's the right dose, what the side effects are. So typically we go to the next stage, phase 2 trial, where we might treat typically 20 to 30 patients and to see if we really see the response and further define the side effect. And most of the drugs which do not progress further are at that stage where if you see a promising result, then we go to the phase 3 trial, but if we don't, then we stop the development. But even in trials which do not work, we learn a lot that helps develop new drugs. And if the drugs show similar enough activity, then they go to the phase 3 trial. These are big trials, usually 300, 400 patients, where patients get randomized to get the new drug versus what's considered as standard of care drug. And there we are looking at different objectives, such as what is the overall survival, and these are the trials, if they are positive, lead to the approval. So in terms of mesothelioma trials, there are trials which are specific to mesothelioma patients, for example, targeting mesothelin, which is a protein expressed on mesothelioma cells. But many of the drugs which are approved, many of the novel therapies don't necessarily have to be a mesothelioma specific trial. For example, the 2 drugs which are approved, pemetrexed and cisplatin, that clinical trial was initially not designed for mesothelioma patients. While they were doing the phase 1 trials, they had a few patients with mesothelioma, and Nick Vogelsang and others at the time saw that, well, we see some activity in mesothelioma patients, And then they shifted that phase 1 towards a mesothelioma trial, leading to the phase 3 trial, leading to the approval of Alimta in mesothelioma. But that trial was for patients with solid tumors. It had nothing to do with mesothelioma. Luckily, there were a few mesothelioma patients in that study, and that led to the approval. Similarly, the other drugs which are approved for mesothelioma, the immunotherapy, was for any solid tumor. It was not specific to mesothelioma, but once we saw hints of activity in mesothelioma, that led to its development. So in terms of some of you who are looking at trials, clinical trials, that if you have a mesothelioma-specific novel therapy trial, that's great. But if many of the cancer centers, many of the local institutions will have novel therapy trials which are for patients with advanced cancer, solid tumors, and I think those trials, although they may not be mesothelioma specific, they could be beneficial and show activity, and if sufficient activity leads to development. So I would say that these are things that need to be discussed with your local oncologist is the key. Even if our patients go on clinical trials, we maintain very close relationship with the local oncologist so that they are aware of the treatments that the patients are getting and what the potential side effects are. And once they go back home, we can have a close relationship with the local oncologist, and we can inform them of some side effects that we might be anticipating and have that close connection with the local oncologist and patient. So in closing, I would say that it's very important to participate in clinical trials, but get more knowledgeable about the trial, and usually your best person to know more about are the research nurses because they are totally involved with the trial and they know what are the patients who might be eligible or not, and they are the ones who always remind us what to do once we are treating patients. So I think research nurses, patient coordinators, these are important contacts for any of the clinical trials. So that's some of my thoughts. So I think Dr. Edisumuli and I will be happy to take any questions from the patients or anyone else.
This is your time to ask questions. Yes, sir.
Yeah, I just have a question in general about CAR T and where you see that right now. I don't know how long that's been in the works, but do you see the CAR T kind of being the best once you've exhausted all the other already FDA-approved types of trials or medications? Or how do you see CAR T, and when do you see CAR T being maybe moved to a next phase? Do you see any potential for progress? I think it's in phase 1, I'm not sure, but if you can just explain a little bit where we are with that,
sure.
I appreciate it.
So CAR T cells are clearly active in blood cancer. So, a single dose of patient's own T cells, which are modified, can completely eradicate lymphomas or myelomas. So there in the blood cancers, it has been, transformative. And patients are living longer and getting cured with a single infusion of the CAR T cell. But blood cancers are easier in a sense because the tumor cells are circulating in the blood. So once you give the CAR T cells into the blood, they see the cells, kill them, and these T cells can survive longer. But solid tumors are very difficult. Right now, I would say CAR T cells thus far have not shown sufficient activity in solid tumors. Recently, there was a trial in pediatric cancers where the CAR T cells in solid tumor showed activity. But right now, I would say the CAR T cell field is still in what we call as early stages. We're having some success, but not a lot of success yet. And that's why our group, Dr. Edisumuli and others, we are working hard, because if we are able to succeed with CAR T cell in mesothelioma, it will have a huge impact, not only on mesothelioma, but many common cancers, ovarian cancer, pancreatic cancer. So that is the holy grail right now, how to make the CAR T cell work. we're making progress. We are seeing some patient with responses, but I don't think we are at a stage where we'll get an FDA approval in the next few years, but we are making progress one step at a time.
I agree with Dr. Hassan. Obviously, this is an investigative stage. That's where we are. But this investigative stage is based on 10 years or 20 years of work, and we are glad to explore tumor immunology in mesothelioma. But as I mentioned, our immune system can only fight up to certain dose. After that, the enemy will take over. But having said that, the advantage of CAR T cells, what Dr. Hassan explained in leukemia, lymphoma, myeloma, they targeted one protein, and most of the cancer cells, almost 99% of the cancer cells express that protein, and also the liquid tumors are much more easy to treat. Solid tumors, mesothelin is expressed at a high level, but not 100%, that's number one. And two, currently we are tilting the balance by giving CAR T cells, genetically engineering. How it is different from chemotherapy or even the checkpoint blockade immunotherapy, we call it as a living drug. Meaning, if I had a headache and I take aspirin, in a couple of hours, the aspirin levels in my blood goes up, and after a few hours, it gets excreted. Whereas immune cells, once they see a target protein, one cell will divide into thousands and millions and billions of cells. So it's a living drug, meaning that was the dream in leukemia lymphoma that was achieved if we can give one dose. And those are the patients that failed multiple lines of therapy, 3 to 6 months survival, but for years they're doing well, not requiring any therapy, good quality of life, cancer is completely gone. Because if we can engineer the immune cells to recognize and they keep proliferating in the body, they keep the cancer at bay or eradicate. But in solid tumors like mesothelioma, there are several hurdles. We are not there yet. We are learning from all these clinical trials, so it's a still investigative stage. But on the other hand, we did benefit from what they learned in leukemia, lymphoma, myeloma. It used to be 2 to 3 months after taking the blood, genetic engineering, giving to the patients. But now companies can do it in 1 week to 10 days. Costs are coming down, and we learned a lot, and all that knowledge we are benefiting and bringing into mesothelioma, but still in investigative stage.
Hi, is there any reason to think that the same concept would apply to peritoneal meso?
Yes. Yes, it could apply to peritoneal, and we, at least in our trials, we also treat patients with peritoneal mesothelioma. I think the biology is the same, and they express, for example, mesothelin. So yes, so we are including both patients with pleural and peritoneal mesothelioma.
Do we have any other questions from the audience? Rich, would your question apply here too? Okay. I have a question. We did a Meso TV some time ago about the truck T cells. What is the difference between the CAR T cells and the truck T cells?
Yes, so truck is a rather cute name, but it is basically, the principle is the same, that you take the patient's cells, modify them, and then infuse them back to the patient. So without getting into the details, with the CAR, there is one signaling domain, whereas with the truck, there is more than one. But overall, I would say the principle is the same. You target mesothelin, you take the patient's cells and modify them and inject them. But there are also CARs which are being modified in different ways. So I would say it falls into the same class of drugs.
So with the genetic engineering, typically I'm allergic to pollen. Once the spring starts, when I go there, my T cells will recognize the pollen, but the other immune cells will come and give the boost for me to go after whatever are allergic reactions, or in that case, cancer. So immunology in the last 50 years, we learned what are all the other cells doing, what are the elements. And now with the genetic engineering, we can put everything in the T cell. So the CAR is initially targeting a protein on the cancer cells and putting a couple of elements. But as we are learning, we can do multiple genetic engineerings. Truck is one aspect of it. And now within the CAR, as I mentioned, the next trial, we are going to do 5 different modifications within the genetic engineering. And now people are going even up to 8 to 10. So that's the advantage with one of the, when I said living drug and immune cell. instead of giving one aspirin or one cisplatin, we can make all these changes within the immune cells that's going to stay in the body, provided we can do it safely and provided we can increase the efficacy. So these are different versions of CAR T cell truck and then what we also call armored cars. So.
Thank you. We have another question.
Hi, Dr. Hassan. Nice to see you outside of NCI. For those of you who don't know me, I've been a 22-year peritoneal survivor, and Dr. Hassan is studying me. And I've been around a lot, and there are many new faces here, and there's lots of crazy big words that many patients don't understand. And I love the way Dr. Sternman in the last session talked about, well, you can do surgery, should you do surgery? And we were talking about clinical trials, and clinical trials are really important for science because we have to improve what we know, and we're such a small population of patients with a rare disease that the science is really important, and recruiting us into clinical trials is important. So my question is, based on your knowledge of the field and patient care, that we can participate in clinical trials, when should we? And how should we? Like, how do you make those decisions?
Thanks, Sue. So in terms of clinical trials, there are different types of clinical trials. So there are clinical trials which are aimed at learning more about mesothelioma, about the biology of mesothelioma. So once we learn that, we can develop better therapies. And many of us have trials, what we call as natural history trials, and many of you have participated in that, where you see us or some other institution, another investigator, you donate your blood, your tumor tissues, the extra tumor tissues, allow us to study that. And that has been extremely helpful in bringing out new things about biology. For example, learning about the BAF1 mutation, the BAF1 mutations which are in the blood, BAF1 mutations in the tumor, learning more about mesothelin. So those allow investigators to develop new things. So those are the natural history trials. So that would be any patient who comes in, even if they come to see us for consultation, they can participate in that. And so far, almost always the patients are very generous and willing to donate their tumor and tissues for research. The other type of trials are more longitudinal studies. For example, patients who have a germline BAF1 mutation, they are at increased risk of developing different cancers. So we follow some of these patients long term so that we can detect if they are at risk for getting other cancers, we can detect it early, monitor them very closely. So there are other trials, and for that, patients or individuals can participate at any time. Then the other category of trials are the therapeutic trials, which are the treatment trials. And some of the treatment trials, as we'll hear about later, are even for newly diagnosed patients, because those patients might be getting some novel therapies up front before their surgery. These are called window of opportunity trials, where we have a patient who may be eligible for surgery, but before they get surgery, they get the drug, whether it's immunotherapy or some other treatment, and then we can, at the time of surgery, look at the tumor and see how we have modified the tumor. So there can be trials for newly diagnosed patients also, so it depends. But most often, at least as medical oncologists, we see patients after they have had standard treatments, which today would be defined having chemotherapy and immunotherapy. But I would say, even if you are considering a clinical trial, it's better to look at some of those early on, because for some of the trials, such as the CAR T trials, it takes 2 to 3 months or more to make the drug. So if we take the patient's blood, then we have to make the CAR T. And that process is complicated, and it could take 3 to 4 months just to make the drug. So we try to see patients early on while they're getting regular treatments with their doctors, so that if they're eligible, we get their blood and start making the drug, so that when we need it, it is ready. So in general, when you enroll on clinical trial varies. If it's a natural history or it is a screening study, you can do it anytime. But for treatment histories also, it is good to kind of think about it early on, and so that if we have to make the drugs, we can do that. And many of the medical oncologists that you'll be seeing are familiar with it, or you can bring it to their attention, and so it varies.
We have a question from the online chat. The two of you represent two different institutions, the National Cancer Institute and Memorial Sloan Kettering Cancer Center. Is it possible to compare the different approaches to CAR T cell production and application between the NCI trials versus the MSK trials?
Yeah, we constantly do that. I mean, these kind of meetings and conferences are a great place for us to meet and discuss. Dr. Hassan has been a leader working with Ira Pasta on describing these mesothelioma and targeting other approaches. There's so much I learned from that studies as well. And within these studies, again, we analyzed the immune cells, why certain patients responded well and why some patients did not. And we analyzed the biopsies and the peripheral blood. And again, same thing Dr. Hassan has done in the recent manuscript. So that comparison, direct comparison, we're all different human beings. Each patient is different. But we're having said that within the factors of the tumor, immune cells, and other factors, we do compare our results, not only the results, but also the samples, and learn from it. So,
I would just like to echo that, and I think because mesotheliomas, the investigators or the physician scientists who work on mesothelioma, we are a close-knit community. We get to see each other, learn from each other's trial, and I think that has been very helpful for the field.
Several years ago, I heard that when they're putting the T cells back into the body was a significant event for the body. Can you address that? Is that a big problem?
Yes, so that is a big problem because we give a lot of T cells. And once the T cells see the tumor, they proliferate. As Dr. Adesumile mentioned, these are living drugs. So these T cells increase in significant numbers. And in some patients, it can lead to significant side effect. The most common side effect is what is called as cytokine release syndrome. Basically, your body produces a lot of substances that can cause fever, they can cause your blood pressure to be low, can cause difficulty breathing. But all of us now have a lot of experience in treating those symptoms. And so sometimes the patients require special medicines for this. And the other side effects are sometimes patients can get inflammations around their lung or inflammations in their belly. So those are some of the side effects that we keep a close eye on.
thankfully, again, we learned a lot from leukemia, lymphoma, myeloma trials. This used to be a big issue. When patients got CAR T cells a week later, when they're proliferating, reach the peak, very high fevers, patients going to ICU. But it now became such a standard of care, like many of the physicians and nurses can treat it. And obviously FDA approved as a standard of care in those trials. And that's where a lot of knowledge we learned that we don't have to repeat again this in the mesothelioma. How to safely manage, why patients are getting high fevers, when, what is the time period that probably they're going to get the fevers. And that's why we ask the patients to stay close to the hospital, major centers, at least in the first few weeks, so that we can immediately recognize and act upon it. So.
Do we have any other questions? Okay, thank you very much. Oh, we do have one more question.
Hi, just a quick question. Are there other protein targets for CAR T cell therapy that have been investigated? And I guess a general question, when patients are diagnosed and they have their tumors analyzed, are the expression levels of mesothelin quantified or distinguished in any way? Do you think that might have an effect on their response to these kinds of therapies, or is it pretty much highly expressed across all mesotheliomas, pretty much the same throughout patients?
In terms of, there are other targets for CAR T cells in solid tumors like other targets, HER2 and others. But mesothelin is interesting because it is expressed in many solid tumors and has low expression in the normal mesothelial cells. But sometimes there could be expression in the lung, and so that's something we need to keep an eye on. In terms of, as Dr. Adesumilli mentioned early on, that if you have a mesothelioma tumor, maybe 90% of them have mesothelin, but there are also some cells which may not have it. So, or they may have it at low levels. So for some of the clinical trials, for example, the trials that we do at NCI, we check the patient's tumor for mesothelin, and by pathology, just want to be sure that there is enough mesothelin for the patients to go on the study and get benefit. But in general, mesotheliomas have a lot of it, but at our institution, we still test it before enrolling a patient.
Just to add that in addition to looking for other targets proteins, now with the genetic engineering, we are at a stage we can target 2 or 3 different proteins at the same time in the same immune cell. That's one approach we are doing. Second is we learned from in mesothelioma, mesothelin is expressed high, but in lung and breast cancer, the cancer cell keeps it inside. For our approach for the CAR T cell to recognize, it has to be expressed on the cell surface. So now our lab and others have been doing this to how to bring it out. If the mesothelin is inside the cell, how to bring it out to the cell surface so that immune cells can target. So in addition to additional targets, there are other approaches, genetic engineering, we are doing that already in leukemia, lymphoma, myeloma, they are in clinical practice already, those approaches.
One more question. I'll get there eventually.
Hi, my name's Locke. It's really nice to meet everybody. I'm a patient. Was diagnosed 2.5 years ago working with NIH and also at a City of Hope in Southern California. One thing that is good, and I don't want to, I'm a little confused as a patient. It seems like things have been fairly static for 20 years in terms of chemotherapy, and then most recently there's been a development with immunotherapy as another FDA approved. But now it seems like there's a proliferation of type of treatments that are people going after CAR T, targeted therapies. I mean, it's great that as patients we have these options. It's a little confusing though also with these options. And it seems like it's actually really hard to find someone that's kind of like the front door to figure out what other door do you go through. You know what I mean? And you guys are all kind of, in some ways, separate pillars. And it's great to have these symposiums, but what do I do when I go home? Do you know what I mean? Because a lot of these doors are kind of one-way doors for us. So when we go through, it's like, well, do I do a chemo plus a double immuno? Do I do, you know, whatever neoadjuvant, you know what I mean? Post-adjuvant, you know what I mean? Whatever all that stuff is, right? And so it just seems like a lot of different options. Obviously, every patient is different, but it doesn't feel like I have a Sherpa to kind of help guide to go through. Do you have any advice on that, and where do you think that's kind of going?
So that's a great question. So I think that you're right. So there are a lot of options, which is good, a lot of investigation going on in mesothelioma. Then the question is, how does patient figure out which study to do? Should I do a study close to home? Should I do a study at another place? And what are the advantages or disadvantages of participating in a particular clinical trial? So if we have patients for which there are standard therapies, you know, in my practice, I would say that if you're newly diagnosed, surgery is not an option, then we have 2 FDA-approved therapies. And if you want to be closer at home, spend time with your family, we know what the side effects are, we know what the benefit is. So I think there it's a little bit easier to say, because you could say, okay, you could get this therapy with your local oncologist, you don't have to leave your home, you can continue at work, and these therapies have been shown to have benefit, and we know what to expect in terms of side effect. Then the question comes, you have had the chemotherapy, you had the immunotherapy, what next? And then that's when you look at clinicaltrials.gov or talk to the foundation, and they might tell you there are these 4 trials at different institutions. So I think in that case, it requires discussion with the physicians or investigators at those sites to get a better sense of, is it a phase 1 trial, is it a phase 2 trial? If it is a phase 2 trial, has it shown some benefit? So I think there is no easy answer to that. And you might hear, okay, this went through the phase 1, we saw some activity, and we know what the side effects are, so that might make it a little bit easier from the patient's perspective to participate in. But many times we don't have that information, and then you have 3 different novel therapies in phase 1 testing, and then I think that's where you need to have a discussion with your local medical oncologist who knows you the best and can be your advocate and kind of get an overall sense what might be appropriate for you. I don't know if that answers the questions for me. No, I got it. So I think your comment was that many of the local, it's such a rare disease, and many of the local medical oncologists might not be familiar with what's going on. So I think that is true, and I think maybe that's where things like the Meso Foundation might be, because they keep tabs on what's going on throughout the country. They might know what's going on in California or New York. So sometimes the foundation nurses might be helpful to tell you what the different studies are. And also many times if you talk to one of us, for example, we might say, oh, you are in New York, it may be better if you see Dr. Adesumuli or Dr. Zauder, or at Memorial, they're doing similar studies. There'll be less disruption to your family, and that's a reasonable option. So many times we do that, try to see what might be a good option for the patient locally.
Thank you to both of you. We really appreciate it. Do you want me to just get rid of it?
Yeah.
This one? It's here.
Sorry. Thank you.
Yeah. Thank you. Next, security alert. Makes sense from the imaging team. Next up, we have our imaging presentation. I've seen a version of this presentation before, and I have to tell you, this one has definitely opened up my eyes about all sorts of issues about imaging. And I don't know if you're like me, I sometimes look at those CT scans and x-rays, and as the doctor is telling me about it, I'm thinking, how are they seeing what they're seeing? So we have had a little change in our schedule. Dr. Sam Armato from Chicago could not make it today, but we have with us Dr. Christopher Strauss from the University of Chicago, and Charles Simone, Dr. Charles Simone from the NY Proton Center. Thank you. Come on up.
I love microphones. First and foremost, I got to make sure everything's adjusted because I'm a little taller than most people. Everyone can hear in the back, correct? Okay, super. This is actually one of the talks where you might want to move up to the front row because it does, based on imaging and what you can see, so it depends on the projector, and if you can't see certain things or things are not highlighted enough for you, I very much want those in the audience, and particularly the back row or the back half of the audience, to wave your hands and we'll adjust as we go along. Having said that as well, I'm excited to be here, but I'm always trying to learn my new audiences and what are your needs. And that's really tricky when it comes to imaging. My fellow radiologist is a radiation oncologist, and I'm a diagnostic radiologist, but who specialized in interventional radiology. And we're here to sort of help break the understanding of imaging, which has actually transformed medicine in the last 100 years, but in particular in the last 20 and 30 years. There's a lot of unknowns. It is not a lab test. And what we're doing in using imaging is really an art in terms of interpretation. And my goal over the next 15, 20 minutes is to sort of give you a little bit of insight so you can ask questions and have a better understanding as to why we're choosing this particular imaging modality versus a different one, or in combination, or how we're actually using this to treat your disease and what we're looking for and that kind of thing. So, having said that as well, this is a lot of precursors here, my goal is to meet your needs. And I can tell you right now, we've uploaded a whole bunch of slides. Some are going to go very fast. They're just meant to be placeholders, and they're there to mostly just titillate and excite you and say, ooh, look at that. But in general, my goal is to answer your questions. And so we decided last night, we much prefer you to start asking questions as we're talking. Put your hand in the air. We do not mind a break because to a certain extent, if I only go through 5 or 10 slides, each of us, it will be better for us in terms of meeting your needs than for us just to be rambling on and not. And I also don't quite know what everyone knows. Some people know a few things, some people know nothing. So we're going to try to sort of identify, I'm going to be basing this a little bit on what eyeballs, so you're like, oh, nodding heads, or uh-oh, I'm looking lost. So give me some reactions. We'll adjust on the fly, all right? Having said all of that, I know it's a big ask. Chicago, University of Chicago, so more is happening across the country, not just on the coasts. And I've got to once I figure out my buttons. It all starts with imaging, and that really started about 110 plus years ago with this man. This is Wilhelm Röntgen, for anybody who recognize him. He actually was the first Nobel Prize winner. He actually was the man who invented X-rays. He was the one who was in his lab at one point and realized that he was, to cut it short, exposing film across the room with this new device he was playing with, and he actually put 2 and 2 together and said, hey, this thing is doing something to my film. And he basically then turned around and grabbed his wife, of course, the poor thing. She actually had to put her hand under for 90 minutes and took the very first world's X-ray, and this is her right hand, being Europe, that was her wedding ring, on her 4th finger. And he went on, and things have developed pretty quickly over the next few years in terms of producing X-rays. Notice how much protective equipment is around that X-ray diode on that table. Everyone is getting exposed. Nobody understood the downsides of radiation, which we're going to talk about a little bit later in our chat. But it was a way for us to look inside the body in a way that no one had actually done before. Everything previously had been potentially a few biopsies. There was very early pathology going on at this point, but prior to that, it was all based on symptoms and a little bit of guessing. Now we're able to look inside the body with lots of nifty equipment that's been developed over the last 100 plus years. And to a certain extent, some people have actually stated 5 of the top 10 advances in medicine have all related to imaging. It's allowing us to not only diagnose and see things that we couldn't see before, but most importantly, and you've been learning about some of the treatment options, what works and what doesn't. And we're able to divert their attention and say, focus here, don't do that. This is what's really helping without necessarily cutting you open. And that's obviously the key, all right? This is more modern equipment. Obviously, we take images, and we're going to talk about different imaging modalities in the first few more minutes. So we have X-rays, CTs, CAT scans, PET scans, MRI. I'm going to touch briefly on each of these. Again, focus your questions mostly on CTs and MRI. It's what we're going to be really talking about. But at first, this alphabet soup is actually going to be sort of break down what the man behind the curtain. It's really not as confusing as it sounds and looks, but the X-ray itself is what is at issue. So unlike Superman, who sort of zaps people, we're going to talk a little bit about waves and energy waves. And this is really a simple diagram of different types of waves, and right in the middle where you see that very colorful rainbow is visible light. It's very narrow. It's actually what we use to see the sky and trees and dirt, and otherwise we have rays that are shorter wavelength above and longer wavelength below, and these are things you know. So that's visible light. We've got radio waves that are very long, and we use those obviously to run radios. Microwaves, everyone uses it to heat their coffee. TV remotes are all low. But then we have X-rays, which are higher energy. And the reason I'm focusing on telling you the wavelength is the higher energy, it has the capacity to hit cells in such a way that actually then can alter them and sometimes kill them. That's what his job is. My job is to use them in a way that helps it from a diagnostic standpoint. So let's talk a little bit about the physics behind it, and I'm talking less than 30 seconds. I hope I'm not going too fast, but we have an X-ray source. You can see a Christmas cookie. What do you get? You get that. That is actually my little friend, a dachshund. That's a cookie that he ate, didn't even chew it up, and you can actually see the cookie in its full outline in his stomach. And we actually did an X-ray to identify where it was located, and he's looking a little guilty down there, and in the end, what do you really see, right? It's denser. And that cookie is denser than the other tissues, and the fact that we can sort of see it against the fat and the other soft tissues, muscles, et cetera, allows us to outline that component. And so this concept is going to be extrapolated over the next many slides, where we actually not just look at plain films, but CAT scans and other imaging modalities to sort of say, hey, we can get better and better at this over time, all right? But at first, this is Waldo, right? Everybody knows this. You have kids or have grandchildren. This is actually the eye test. These kids find Waldo within seconds. And why do they find Waldo so quickly? They're trained to find Waldo. They know that Waldo has a red and white striped shirt. He's got a funny hat. He sits a certain way, glasses, etc. And they scan that thing so fast, and you're going, what? I don't even know what page I'm on. And he or she has already plucked them out. Said, there he is. And they're so excited. That's what radiologists do. That still makes me excited when I find things. It's not just puzzle solving, but we're trained to actually identify this stuff, and we can get into other questions later about how it's actually done consciously, but actually about 95% subconsciously, and that's a whole conversation and lecture unto itself. X-rays, it's again about shadows. And so we can sit down, and if this diagram is a quick sort of a moniker, you can see there's the human there holding different fruit, a banana in her left hand and a pineapple in her front hand. But depending on where the light bulb is, and the light bulb then could be X-rays, it creates different outlines and shapes based on what is there. But if you're looking at the light bulb from the front, you can't see the pineapple because the rest of her body is blocking it, and vice versa. And so we always are looking for two views. And this is an analogy as well for us to be looking at different imaging modalities. So we'll be looking at plain films as well as CT, MRI, ultrasound. We'll use these different components to get a better understanding, a three-dimensional understanding, and sort of in terms of personality of that tumor over time. And so we're going to not only have the element of what is the tumor, where is it located, what is it shaped, but also where is it on April versus October versus 2021, 2023. We want to be, that time element is that fourth dimension. This is a standard chest x-ray. First and foremost, am I going too fast for anybody? Okay, just sort of getting warmed up here. Standard, so this is our two views, again, where we have a PA, which is on the left, and on the right is a lateral. It allows us to see objects sort of more three-dimensionally. And I'm trained to actually not only identify things, but to actually obviously look for normal versus abnormal. Classic example, people get bones. The ribs are what you see sort of stripes going across. Those are the denser calcific bones. Where there isn't bones, you're seeing gas and soft tissues, and it's less dense. More black versus more white. All right? The heart is that sort of that object you see in the sort of in the middle, and in the front. Is there a pointer? I am looking, I see it here.
It's a top button.
Well, it used to be a top button. How about, no. Deader than a doornail.
I think it's maybe off.
Okay, sorry about that. We'll let her work on that. But you can see the heart sort of in the middle, and on the lateral, it's sort of in the front of the heart. And we know that the heart, where it's located, just to give you some reference. We're going to go in and talk a little bit more about different things. But fundamentally, this is a standard chest radiograph. Again, and we are looking for different densities, and there are 5 different density groups. I don't expect you to remember these at the end of the day, but just to have you identify, we can't distinguish on chest films and plain films within the family, but we can only see the different families to each other. So we can denote air from soft tissue, air to metal, bone to soft tissue, etc. But we can't, within soft tissue, distinguish muscle from vessels, from blood, from other things that all land in that category. If that makes sense. And that's going to be important when we're talking about CT and MRI and why we're choosing MRI in particular downstream. So let's play a little bit of a game. What is this? All right, got a baseball bat. Everyone pretty much just sees it. Why do you know a baseball bat? Well, because you've had one in your hands. You know its shape. And if you actually start looking at this, it's not just the outline of the baseball bat. You can see it's denser towards the end where it's thicker versus the neck and the handle of the bat. You can see striations. You can see the wood, etc. But these are, again, they're things that you're applying your knowledge of this item, and you're applying it to the images that you see. And we just do this times 1,000 when we're actually doing our day-to-day work. This is actually Sammy Sosa's bat for anybody who's a baseball fan. He actually, if you remember, he was going after the world record for the number of home runs in a given year. Thank you much. And indeed, he had a corked bat in the middle of one afternoon. And so I stayed up till 3 in the morning and imaged all of his bats one night to prove that none of them were corked. And this was bat number 27, just so you know. CT scans, so we're off of plain film. CT scans really are the extension of plain films. Now, we had plain films for about 110 years through about the 70s. In very late 70s and the early 80s, we developed something called CAT scans. And this is actually a plain film here on the left. This is going to become this. We're actually still using x-rays. We're looking at things in sequential slices. So we're actually looking at these three-dimensional objects, and we're literally cutting it up mentally and visually in different orientations, axially, sagittally, coronally, so we can get a three-dimensional understanding of what's going on. So this machine essentially is a donut, and some people call it the donut. You'll go through on the table, and that's the patient. You can see their head, and there's a X-ray machine, X-ray tube, spewing out X-rays with detectors that are actually spinning at a very high rate. And we're taking literally thousands of chest X-rays, although very minor ones, very small ones, but they add up, and we can clinically then, and using mathematics, create these images that you're now going to look at. This is actually the cover taken off. That's my gym bag, just to give you an idea. That's the X-ray tube, and then the detectors down here. But imagine this thing spinning around literally several hundred times a second, all right? There's our baseball bat again. This is just a quick reference to how we actually start thinking about the shapes of different objects. And if you cut the object in different directions, it gives you different outlines. And that's, again, what we're doing when we're doing diagnosis. To sort of take that one more step, though, and this is much more fun, I actually sat down with my, years ago, and got a treasure box, and you can sort of see the handles on the side and ribbed little things. I took stuff out of my office and my secretary's desk and actually a few other people's desks. There are 40 different objects in there. And this is my analogy to the human body, right? The trunk of the body. There's a lot going on there. So there's lungs, and there's organs, solid organs like the liver and spleen, et cetera. And you have to be able to distinguish them. What X-rays are okay at, because they're all overlapping, CT is so much better at distinguishing and sort of helping us see what's behind what's I can't say that word today, but the intersection. Thank you. And, thank you. To sit down and actually sort of unwind some of these images, which you can't necessarily pull apart in your head necessarily, and we can also get much, much more detail. CTs, actually, we can get now down to, if you really use really good CTs, literally under, you know what a millimeter is? I know this is America, but we can get down to even 1/10 of a millimeter in terms of some of these sensitivities. Now, in general, it's on a millimeter, just think it's relatively small. Such a difference compared to what it was 30 years ago. But we're still advancing our components so they become much more sensitive. This box is a bunch of items, different things, and I tell my medical students, I used to give them a bottle of wine. Now I'm not allowed to do that. That's considered not PC in this day and age, unfortunately. But I say, where's the slinky? Who knows? And if I sat down and my microphone went up, I can hear the echo. Sit down. What quadrant is the slinky in? B. Very good. Absolutely. And why? Because you, again, like the baseball bat, you're applying that knowledge. You know it's round, you know it's metal, and you're able to identify it. And that's what we're doing. We're cutting up the body in different directions. This like a bread slicing, so it's going from side to side. So you can see the top of the box versus the handles and the bottom. And then you could sort of slice it up. And who can see the little vase I took off of my secretary's desk with potpourri in it? Who sees the pine cone, right? And you can start identifying things quite readily, but when you're actually looking in different directions and different slices, they may not appear in every slice. So you have to sort of keep in your mind what you've seen and what you haven't seen, where it should be, what's normal. And then you can also look for things like this. And then we slice from side to side, or we can do specialty slicing and reconstructions, as we call them, to see the cat, which you couldn't even see on the other first slice I gave you, the first picture I showed you. It was hidden behind a lot of things. And that's my analogy to the tumor. We're actually using these different methods to actually identify, highlight the components that are important to us, and actually we are trying to find to exclude or include. All right? So hence my joke, it's a CAT scan, there's your cat. This is a real patient. Here you go, this is actually the scanogram at the very beginning. Here are the lungs, arms up here, neck, versus the pelvis and the legs down here. These arrows are identifying the axial, a coronal, and a sagittal slice. You can see that in this case, pleural mesothelioma, we'll just call it that. Here on the left side of the patient, look at how much smaller the lung is relative to the relatively normal right. Here are the correlating examples. You got this pleural thickening sort of around the lung, compressing, holding it shut, versus the normal lung on the opposite side. And we're going to use that comparison point that we have in the lungs in particular to help also increase our diagnostic capacity. So we reproduce things at different levels. Again, another axial cut, and I'm looking at this just to retract these things up and down. You can see the arrows that are actually then identifying the actual tumor. We're looking for its involvement, whether it's invading critical structures, such as down here right by the aorta. This tumor is probably growing into the wall of the aorta, and it's something that we would identify for our physicians that we're working with to make sure that they understood either what they're treating, but most importantly, the advantages and disadvantages of certain treatment options, particularly the surgeons. We work very closely with them to make sure that they have the information that they need. And we have a specialized way of doing this so that we actually do it the same way, whether you're in Chicago, in Philadelphia, in LA, wherever. And there's a standard system called the RESIST. You might see it in your reports. It's so that we read exams in such a way that we can take the data. Again, someone mentioned earlier about how this is a relatively rare tumor compared to some, and it's really important for us to be able to combine our data across the country, across the world, and so we have a system in place that says this is how we're doing it so that we can use information from everywhere to actually create better data sets to actually bring about improvements, if that makes some sense. So this is actually another example. So we go further down, not only do we have the standard pleural measurements, we also are looking for invasion. And again, the CT is very good, very fast, relatively inexpensive way for us to identify this very three-dimensional structure. And this is where I also want to say, one of the big stressing points and stressful points of mesothelioma is unlike certain tumors which tend to be in the lung and they're round and it's discrete, meso grows in a very special way, and it's very hard necessarily initially to find it, but also then monitor and see how it's changed. Fundamentally, we're going to leave the discussion of change and how we use imaging from a treatment perspective to my partner in crime for the next half of the lecture, but you can start seeing that it's a very complex shape. And it can sort of grow in one place and not grow in another, and we have to be able to chase and see those subtle differences. But most importantly, we very much want to see its involvement with other organs, especially when it's outside of the pleural space itself, because that will change surgical options right off the bat. And we need sometimes special imaging to help confirm that. This is another example. A coronal cut, again, you can see the spine here and the pelvis, but this is the lung up here at the top. These are your diaphragms, these curved structures here, and you can see the tumor has grown through the diaphragm and it's starting to grow into the abdomen. So we're actually wanting to find when it goes from one cavity to the other, and this then becomes bicavitary disease, which is something, a term you may have seen in some of your reports. Speaking of reports, let's talk a little bit about some of the reports. I wanted to just sort of throw one up there. Again, part of our RESIST measurements is also standard reporting. So we also then are able to talk to our physicians in an equivalent fashion, whether the oncologist versus the surgeon versus your general practice doctor. But most importantly, these have different sections so that we don't miss things, but they also know where to look for things. As I said, it's an art, so every radiologist is a little bit different in how they interpret, but the standardized reporting method is really important for us to actually make sure that on the receiving end that they have what they need and they are hearing it and seeing it, as opposed to skipping over it and accidentally not seeing that information. So that's actually a critical component if you're not seeing that on a routine basis. So different sections I'm just highlighting there. One more different type of imaging option, and that is PET imaging. And some of you may have heard of this, you may have already had them done. This is actually where we, again, have discovered a new method to help identify disease in a special way. So what we've done is we actually, I may come back to this slide quickly, but I wanted to, oops, I'm going the wrong way. It's basically using radioactive glucose, and we actually will inject it into the patient. We can pick up that information with special cameras as it circulates around the body, and it preferentially goes to tissues that are what I call hungry. All right? Certain tissues eat glucose at a higher rate. The brain and the heart are classic examples. They're very active organs. They need a lot of fuel, like a teenager. Certain tissues are more like regular adults, and actually some tissues are more like elderly grandparents. They don't eat it half as much. And so we're using this difference as a way to help us find very subtle disease. And this is actually an example where you can see the brain is super hot, the heart is really hot, but we can see very trace amounts down here in the peritoneum, which might have been missed in the classic exams where we're looking by either with CTs or MRIs, and we can't necessarily see very small or very subtle disease because it's mixed in with a lot of other organs that look the same. But we can use this to actually identify very, very subtle disease. And so this is being used now in combination. This is actually a classic example of where we have PET scanning with superimposed CAT scanning. So this is actually 2 scans taken, and we merge them in a way that allows us to superimpose a really good anatomy of the CT with the very sensitive PET scanning, and we put them together. All right? So if it's bright, take a look at it. Often it can be tumor, like that arrow. So really, the other big thing is it's also functional. I think maybe when I talk about being hungry, tissues like to chew up and need the energy. That's the same thing as basically saying it's function. I'm actually able to look at the cells in their productive aspect and use that essentially against them so I can identify them much more readily. It's in movement when the others are not. This is actually an example of that radioactive glucose. That's the ring. We just attach a little radioactive fluorine on just to help do our thing. This is just an example because just everybody knows a little bit of physics. When I say E MEC squared, the 2 positron and electrons merge and they create X-rays exactly in 180-degree direction. And so we have special cameras that actually learn to pick up those X-rays, and we can use this to triangulate. So when we actually see something, we can place it in this larger 3-dimensional structure, and that's actually the basis of PET scanning and how we can actually create 3-dimensional imaging, which then become pictures. MRI is another classic example, and I hope I'm not going too fast, but this is another family of imaging. It came online around the 90s at this point. And in this particular case, we put you again into the large magnet, which some of you may have already done. And what we're doing is we're actually putting all of the tissues, but in this case, just think protons, water, and we're actually lining them all up. They all line up in the direction of the magnet. And then we take radio waves, and we actually put in energy into, and we knock the tissues out of phase, as we call it, phase being the bore of the magnet, and we actually kick them out of their standard, their position, and then they ring back down to baseline, back to it, and we listen to the sounds that the different tissues are making. And it literally is that simple. I know it's kind of confusing to think, but this is the analogy where you get different bottles, they make different sounds based on how much fluid is in there, but every single tissue has different ringtones to it. And we will use that information then to actually create the actual images, such as this one, where we actually have, again, skull up here, brain, mouth, spine, and you can see then tissue, soft tissues, in a much more intricate and detailed way that we can't even see with CT. CT is based on density, like that original cookie in the dachshund. So depending on how dense or less dense it is, we can see differences, and we use that to create images. But MRI is using a totally different method to actually identify and differentiate these tissues. In particular, you can see how fat is very bright and other tissues are very dark. I won't get into the specifics unless you have questions about it, but it allows us to actually identify and create a better understanding of what those tissues and tumors in particular look like on the inside. And so these combinations can be used along with biopsies and other tissue imaging methods to help differentiate what we think it is. We can actually even use MRI to actually do spectroscopy, to actually look at and pinpoint and say what types of wavelengths that we actually have and actually identify the components that are within the tumor. We're doing some of that as well. This is actually, again, just looking at the same tumor in different directions, just to help emphasize that we're, again, based on the anatomy, the destruction and size, what is it involving, what is it not involving, but more importantly as well, the actual tissue of the tumor itself, and these all become part of our report and what we're actually looking for. And on that note, unless there are some immediate questions, I'm going to hand over the podium to my colleague, Chuck, who's going to talk more about tumor response and go from there.
All right, so I'm going to lower the microphone. And that was really fun. You guys essentially in 25 minutes got 5 years of post-medical school training. Now you know every type of imaging. So now I'm going to, in the next 10 minutes or so, try to just say, now that we know everything about imaging, how do we apply it to our discipline in treating and helping to manage patients with mesothelioma? So one thing that we regularly do, a lot of what we talked about right now has been diagnosing. So identifying something early on before any treatment. Once treatment's delivered, though, we then re-image, and all of you and your family members have been said, you need a scan every 3 months or whatever the frequency that your physician has given you. What are we doing with that? Well, we're assessing the tumor response, and CT is really the best way to do that. There are advantages of MR, advantages of PET, but CT is kind of the standard way. We can very clearly and probably better than other modalities measure the exact size of a tumor. And we can say, okay, well, the tumor was 3 months ago this size, now it's this size, so did it respond or not? How do we do that? Well, there are defined ways that we measure if a tumor has responded or not. One is the RECIST criteria, where we look at a specific measurement protocol and we apply that to say, did the tumor shrink, did the tumor grow, did the tumor stay the same? Now this is a nice example. This is a lung cancer, and you can see, where's your pointer? The top one, okay. So very clearly you have a little nodule in the lung. You can measure the length, the width, the height. Even just one dimension, you can say in the longest plane, it's this. In this case, it was 12 millimeters. So now that you had treatment, say you had chemotherapy, now it went down to 8 millimeters. So you can physically quantify how much it's changed. Well, that doesn't work quite as well for our mesothelioma patients. You can see, for instance, in the chest, you have oftentimes a concentric rind. You don't have a single one dimension that you're measuring. Do I measure this thickness here? Do I measure the length here? In the belly, same thing. For peritoneal cases, you usually have diffuse kind of patches throughout the abdomen. So how do you really measure mesothelioma? Fortunately, our field has developed specific measurement criteria for mesothelioma. All criteria really revolve around taking the measurements and saying, did it grow, did it not grow? And we use these. So if your doctor's saying the tumor's progressing, what does that actually mean? Well, it typically means that from whatever the tumor was before the treatment, it's increased by at least 20%. That's what we call progression. If your doctor says that the tumor is responding well to treatment, that means that the treatment's actually shrunken by at least 30%. Ideally, it shrinks 100% and it goes away, but response means at least 30% shrinkage. Complete response is going away altogether. What we now know is not only a single dimension of response, but volume really makes a difference. And so some of you may have been heard or told at diagnosis, oh, you don't have much volume, that's a good prognosis. But we never really could quantify that much before, again, because of the challenge of measuring something. This is coming off a little darker than what I see on my screen, I apologize, but again, this is very diffuse, so how do you really measure this well? We know, though, that people with a large volume of disease at diagnosis generally don't do quite as well as people with less volume of disease. How can we quantify that now? Well, we actually can essentially use artificial intelligence and segment. We can take a program could then essentially trace all the abnormalities, because we know these are the ribs, and if you look on this side, from rib in, there's nothing. This is all black, so black is air, your lung. On this case, here are the ribs, but now you see not air, so this is the disease. We can use a computer program to essentially trace all of this area and calculate a volume, and we can then have more prognostic information for our patients. Some of you may have been told you need to have IV contrast every time you get a scan. Well, why is that? Well, this is what a scan looks like without IV contrast. You can have some fluid in the lungs, pleural effusion, and then kind of all this stuff in the center of the chest. This is the lung, but what's in the center of the chest? The vessels coming off the top of your heart. There are lymph nodes, there's airways, etc. How can you differentiate all of them? If you give an IV-based contrast for CT scan, the contrast preferentially accumulates in vessels. And so you can see here, this looks very bright. That's what the IV contrast is doing. And in fact, there's different brightness for vessels that are arteries versus veins. And so now we can say, oh, this is artery versus vein, and this is neither. Right now, I can't really identify kind of this jumble, but now I can say artery, vein, potential space, what is a lymph node. All of them will have different uptake of this contrast, so we'll be able to differentiate, yes, in fact, I can see that the tumor is grown or not grown, as opposed to not necessarily being able to measure it well without having that contrast. This is something that we commonly hear. What is the concern about getting too many images? I will say in one word, nothing. I don't want you to worry about this. The fact of the matter is, this is a concern for somebody that has no disease, is in their teenage years, and is expected to live for 60, 70, 80 more years, and they've had lots of images, what is the risk to that person? Well, even that person, it's about a 1 in a million risk of having something happen. What we do know is the risk of getting a cancer from radiation really is related to age. So people at young ages, you can see the risk is much higher. The average age of a mesothelioma diagnosis is in the late 60s in the US. Of course, we have many outliers, including people in this room. But as people get a little older, once you're kind of in the 40s and higher, the risk really approximates 0. And that's assuming that you're going to live 40 and 50 years to develop a secondary cancer. Typically, on average, from the time of an exposure of a high-dose radiation to getting a problem is 20, 30, 40 plus years after. And that's a high-dose radiation. Again, we're talking about something that's a very, very low amount of radiation. So, if your doctor says, we really want to see what the response is, I need you to get a scan in 2 months, get that scan in 2 months, because the concern is if we can identify if a tumor is progressing. Now you heard in the last talk, there's so many more therapies than we had even just a couple of years ago. Before it was kind of chemotherapy or bust. Now we have immunotherapies, targeted therapies, CAR T-cell therapies, combination therapies. So if we can identify things earlier, all those therapies actually have a better chance to work than if you wait until they're a bigger recurrence. So the benefits of imaging far outweigh any kind of risk that you may be worried about. Just to quantify that, the risk of having a problem again is close to 1 in a million, again, in young, healthy people. My colleague had to put this in, but spending 2 days in New York City is actually more risk than having all the x-rays that you can ever have from diagnostics. So I need to worry when I go back home to New York, but I think suffice it to say, you guys don't have to worry about the risk of imaging. And then lastly, in the last 5 or so minutes, just how do we apply imaging to radiation oncology? You're going to hear a lecture from Dr. Sengel later this afternoon talking about what is radiation and how do we treat tumors. Well, I'll just say, the imaging is critical. In fact, our field, radiation oncology, used to be therapeutic radiology as opposed to diagnostic radiology. The fields have split since the last 50 or so years, but it's very, very critical, all the imaging that we do. In fact, this is what a plan will look like. And Dr. Sengel will explain this more just in the interest of time. I won't, but these are all beams coming in to target an area. This is a pleural nodule right off the heart. This is the heart here. This is an area we want to treat, so we're sending beams around in a plane or discrete beams to target that. But how do we actually target it? We need to, one, identify on imaging, and then have the radiation dose calculated on the imaging. And that's what it looks like when you calculate the dose. This is a patient with a pleural mesothelioma invading the heart even. You can see colored equals radiation, so dark color is high-dose radiation. These lighter blue colors are low-dose radiation. But on this imaging, we can actually see exactly where the radiation is being deposited into the tumor. High dose, the red, more likely to kill the tumor. So what are the roles of imaging in radiation oncology? Well, certainly to diagnose new conditions, to stage patients so we know how to most appropriately treat them and say what therapy they should be getting. We use it to delineate the target. So essentially, in these 2 examples, I need to actually circle where the tumor is. I need to actually account for motion. Every time a patient breathes or every time that they're having a different gas in their belly or anything else, the tumor in the belly, the tumor in the chest, all of them move. So I need to actually account for that and do something that we haven't even talked about today, a 4-dimensional image to account for that. But then I contour out where the tumor is, where the tumor can be, as well as all the areas at risk for where the tumor is. And then I figure out how to actually deliver the radiation dose. So delineating out the different tissues is a big part of what we do. And then as I alluded to, then we can assess for the response. After I give radiation, I do an image 3 months later and I say, did it respond? The answer almost always with radiation is yes. The question is at what cost and what toxicity. So the response rates of radiation are higher than what we see with any type of systemic therapy, but not every mesothelioma is amenable to getting radiation. So Dr. Sengel will talk about that a little bit more. And then we can actually use imaging as ways to understand for prognostic. Again, bigger volumes is a little bit worse prognosis. We can actually evaluate, I alluded to, radiation is great, provided you don't cause toxicity. We can actually use imaging in the post-treatment setting to predict who will actually even get toxicity, which is pretty neat. We use PETs and MRs to some extent in radiation oncology. Most of what we do is CT scan. But PET scan, we can really identify disease in the lymph nodes in the center of the chest, as well as disease outside of the chest altogether, including in the abdomen, where CT is not quite as good as a PET scan. And then on the MRI side, And this really helps with surgery as well as radiation oncology. Sometimes the CT does struggle to say if a tumor is invading from the lining of the lung into the chest cavity, what really is tumor versus the chest wall. An MRI can do that very, very well. Same with in the apex, invading up toward the vessels and the nerves coming off and going into your arm. Same within the belly. So these can be really good tools to help with planning for surgery and radiation. And then a little bit provocatively, a PET scan, we talk about a standard PET scan. So for those of you who had it, you get an injection, you have to sit in a quiet room for about an hour while that radio tracer goes throughout the body, and then you get a scan over the course of just a couple of minutes, and then you go home. Well, the fact of the matter is, depending on when you actually get that scan, if you're not sitting in a quiet room for an hour versus 30 minutes versus 3 hours, the images actually look different. And so a standard uptake is at 60 minutes. But if I did the scan on this patient here, I would see their tumor here in the lung, and it looks like they just have a pleural effusion. And it doesn't look any different from the CT scan. I didn't really gain any information. Still a pleural effusion, still a mass in the lung. But if I just change the parameters on how to do the scan and I waited a little bit longer, now I can see, well, there's pleural effusion, but there's actually disease in the pleura there as well. And now I can actually target that specific disease with radiation oncology. So remember the picture of how I deliver the beams. I want to be ultra precise, literally to the millimeter. But if I'm actually accurate to the millimeter, I need to know what that millimeter is that I'm treating. And that's why advanced imaging can help me. If I had a CT that looked like this, I really can't tell anything in this area. Is it fluid? Is it tumor? Is it collapsed lung? If I do a PET scan, I can see there's actually only a little bit of disease here, and now I can use my radiation to just target this one small area instead of treating this whole big area. The bigger an area you treat, that's what really drives side effects for radiation oncology. So advanced imaging really helps me to, one, more effectively treat the tumor, and then spare side effects for all of you from the treatment. And then last concept is, radiation response assessment. So, we have this big mass that's along the pleura here next to the vessels coming off of the heart. I treat it with radiation, and radiation can kill it. So that's great. Now the brightness that we see on a PET scan will decrease because it's not as active anymore. But what happens in its place, radiation actually causes inflammation. And the truth is a PET scan can't well differentiate inflammation from active tumor. What PET scans are looking at is activity. What's using sugar? Whether you're repairing from inflammation from radiation, whether you're a tumor that's actively trying to grow, all of those use sugar. So now that I treat a tumor, this is another mesothelioma here that we treated. This was the mass before treatment. Post-treatment, it's great. I don't see any mass anymore, but I still have these 3 little kind of bright dots. So I need to follow this patient and say, did I kill all of the tumor and that's just residual inflammation from radiation? Or is there a little bit of cancer left? Certainly smaller than what we started with, but maybe there could be a recurrence. Fortunately, in this patient's case, it was not. It was just inflammation from radiation. But that's where we really work with our colleagues in radiology to understand the evolution of changes over time after treatment. And then lastly, just kind of forward thinking for artificial intelligence. You heard me talk about it for segmenting to try to determine volumes of disease. We're using this a lot more in radiation oncology as well. What we do know is when we target with radiation, there can be changes during treatment. Those changes could be the tumor shrinking, we're doing our job, which is great. It can be a patient loses or gains weight. It can be that the fluid reaccumulates in the lung. Any of those changes can actually change how we're delivering the radiation to a patient, because we're sending the radiation and we're hitting an area accurate to the millimeter, but if that millimeter now is different because of any of those changes, we need to potentially replan our patients. And artificial intelligence and advances in imaging are helping us to do that easier. So again, we can more fully treat the tumor and more optimally treat the tumor while minimizing side effects for patients. And that's it.
Lots of questions.
So now you had 5 years of radiology and 5 years of radiation oncology.
Hi, my name's Maggie. My father has prostate cancer, and recently he went through a different type of PET scan, a new PET scan that I had to look it up because I'm not a doctor.
PSMA scan.
PSMA, yes. And so they use a binding agent that helps to identify the prostate cancer cells. Is there any ability to do that for mesothelioma? Are you guys looking into that? Anything that can bind to?
Yeah, so what she's referring to, so prostate cancer, we usually diagnose it by a PSA. That's a trigger, it's a screening test, just like a colonoscopy for colon cancer. As the PSA rises, that's a concern that could there be prostate cancer. And it's, while it can be produced in a few other areas of the body, 99% of PSA is produced in the prostate gland or cancer from prostate. So scans now can actually specifically target PSA and look for where is it in the body. And that could be a site of metastatic disease from prostate cancer or all the disease inside the prostate itself. Right now, what we use in mesothelioma is, you saw the example FDG, so using a specific label. There's a lot of interest in using other labels. I think as of right now, we don't have anything probably quite better. There's some fluoride-based and other things that potentially can be on the horizon, but kind of the standard, if you're getting a PET scan right now, it's kind of always the FDG.
Yeah, just to add 2 extra seconds on that, the G is glucose. And so the question is, do we use something else that the cells are using as a precursor that actually then drives its attachment and its signal? And so yes, very early on, but we're miles away from something that's a little more advanced in that regard. So don't hold your breath on that one, but we are looking into those things. There are some specialty radiopharmaceuticals that people are toying with, but we're not in the near future. Yeah.
Hi, so you raised an eyebrow with me when you talked about the uptake time for PET scans from 1 hour to 3 hours. Who makes that decision?
Yeah, and it was a little bit of a provocative slide. If you're going to a radiology department, you're going to get the standard kind of 60 minutes. And why they call it, the brightness that we're looking at on the picture, it's SUV, which means standard uptake. So you need the same machine parameters, the same scan time, you need the same your sugar value before you actually get the scan. So there's a lot of things that need to be the same. Me as a radiation oncologist, I have a little bit of flexibility in playing with some of those parameters to try to more optimally target treatments. But if you're looking at response, you really want the standard, what did you have 3 months ago, what do you have now? And so it's always going to be the same length that you're getting.
We talked earlier about oncologists that are at hospitals that don't specialize in mesothelioma often are not as educated or aware of the disease. When it comes to determining whether therapy is working or not, how critical is it for the radiologist to be from a facility that sees the disease on a regular basis versus a facility that may not see it that often?
Can I take that one? The answer is it can make a difference. I don't really want to alarm anyone, but it is not, as I keep saying, diagnostic and analysis of imaging is more of an art, and you really want the person who's doing this 1,000 times, not 3 times, and hasn't really seen it as often. Those exams, make sure if you have them done in, say, a rural area because you're 5 hours away in a flight, make sure you get those images and get them into the hands of the others so they have them for comparison. But if it's possible, you will have it's just better overall and for consistency to have your imaging done at the same place and preferably at the highest level institution. It isn't a lab test that's identical place to place.
You talked very briefly about artificial intelligence and its use in scan reading. Could you tell us a little bit about the prevalence that it's currently being used in the identification of mesothelioma, as well as its accuracy levels?
I can touch a little bit on that, and the answer is limited at this juncture. We, at my institution, actually one of the places who invented AI for breast imaging 35 years ago. Actually, one of the, get into that another day or catch me after lunch. Bottom line is, early on now with meso, we are beginning to toy with certain algorithms, looking at lung texture as a way to particularly identify, in this case, actually not the meso, but the effects and side effects of meso. So people have been alluding around and talking about pneumonitis and some of the side effects that you can get from treatment. We're using AI as a potential way of helping us there because it's very subtle and it's often missed by people. But we're still a little ways from that. The analogy is, if you saw how complex that nodular thickening is around, et cetera, if it's easier to see a single nodule versus that, The same thing is with AI. It's very complex, and we're still a ways away from it. It's definitely going to be a tool that we are very interested in utilizing, getting not only a better handle on, but using it to make ourselves more efficient and consistent from scan to scan, and that will bring about better results. It will not be a substitute or happen very quickly.
And just I'll add, I mentioned earlier the PSA, the colonoscopy screening tools. So we know for lung cancer, people that have a smoking history are recommended to get low-dose CT screening. And there we're seeing more applications of AI, where an AI is able to see nodules in normal lung tissue pretty well. Still experimental, but a lot more research there. Because of the complexities that we've all talked about, it is harder for meso, but I think we're going to get there.
I have a question about imaging in general. I'll stand up. I'm peritoneal, and when they did the CT scan, they found disease. They decided to do a PET scan before deciding about surgery. After the PET scan, they said, "Oh, there's very little disease. I think we're going to cancel the surgery." They went ahead and did it, but when they opened me up, they found hundreds of tumors. And so I think we all live with scan anxiety. My question to you is, now when I get my follow-up CT scans, standard of care, I almost don't believe the results. I think, did you really look? I mean, is there anything you can suggest to us? I mean, I have my CT scans regularly, and every once in a while I say, could we throw in a PET scan just for fun? And they say, sure, if that makes you happy. But I mean, I guess I'm looking for, are there any other exams or any other, we hear about 3D, 4D, AI. What else can we do to reassure ourselves that we're really seeing everything that's there?
Okay, this answer is going to be just a tad longer. It's not 2 sentences. Because what you're doing is you're applying an assumption that is unfortunate. And it's understandable, but it's what's getting you to where you are. Bottom line is, these scans are not perfect. Scanning is not only the interpretation is an art, but fundamentally the thing that you didn't quite get enough, and I can certainly go into more, especially one-on-one on the side of the room, but the resolution of these scans is not perfect. It's not like you can see it in front of you. And so that was the difference between the surgeons. They actually could see things that are so much smaller that the scanning methods that we have in play couldn't necessarily detect, and they register on images. So when you think about it, and this is a way overgeneralization, pretty much things that are under a centimeter and certainly under half a centimeter just will not be seen on PET scans. It doesn't have the resolution. It doesn't have the capacity to do it. The scanning, the cameras can't pick up and triangulate and create those images that represent the actual tumor. So the surgeon can see stuff that's a millimeter. So they can actually see things and identify it, especially under the microscope, that we couldn't necessarily see on scans. CT, I can go into other different methods, but that's another reason why we do things in combination. So it's really about the sensitivity of the study, not that they didn't look per se, but yes, there's an element of people who are more experienced and more likely to find it in those standard locations that other people will skip over. So it's a combination of the two, and happy to expand on that answer for you.
And if you have an 8-point...
Or seeing new things. So you're actually stable to where you are. It may not be a perfect representation of what is, but it's still you're stable. And that's really, that time difference is actually a critical component as well. We probably should emphasize that slide in future talks, just because it's looking for the change, not as much as what is, and to a little extent how much, but again, it's the change. Did it respond? Did it not respond? And if it didn't respond, let's try something else.
I'll just add, if you have what's measured on a CT is an 8.6 centimeter mass, and CT would be much better at measuring than a PET scan would, a surgeon takes it out, they may find it's 8.9 centimeters, but still in the same ballpark, so maybe slightly different. But something that's 3 millimeters, that may not even be seen at all in a scan, whereas a surgeon's easily going to identify it. So as you heard, that 5 millimeter threshold, even on CT, is an important one. And that actually can represent millions of cancer cells that we just can't see on at least present day imaging right now.
Oh, yeah.
My question is,
What takes so long to diagnose mesothelioma? My husband had a physical, 2 physicals a year, every year, with no indication he had anything. When his lung filled up, they took off 1.5 liters and still had more, but they had to stop at that so his lung wouldn't collapse. But when the doctor did his biopsy, he said it looked like someone just opened his chest and threw cancer in it. Same when he had his surgery. And I just wonder what took so long. They cannot see it at all on a chest x-ray?
That's a good question. You know, in our country, the average time from symptom to diagnosis for mesothelioma is 6 months, much longer than other cancers. And 6 months for mesothelioma makes a big difference. You know, a lot of times it's because they're vague symptoms. So it sounds like this is plural with the symptoms you're describing.
Yes.
You know, patients can have pain, and that's not, you know, often a symptom that will make people immediately lead to a cancer that only has about 2,000 plural cases a year in the country versus 20 million people present with pain in their chest every day. They can have shortness of breath, but that's also attributed to an average patient who's about 70 years old. Is it heart? Is it, you know, exercise? Is it other things like that? So from a clinical standpoint, we have a tough time. A primary care doc who may not have seen mesothelioma before may not be able to immediately draw the connection. But then even when you get to the scan, it sounded like there was a lot of fluid. And you saw the one example in my talk that I did. It just looked like a big amount of fluid, and we couldn't really see underneath that fluid. So as you heard on an x-ray, you can't really differentiate different classes. You could say fluid and tumor all look one way, air looks another, but you really need to get the fluid out to be able to see what's underneath on an image. When they try to get the fluid out, the fact of the matter is just using a needle and sucking fluid out, only about 1/3 of the time do you actually make a diagnosis of mesothelioma. So sometimes people are in a cycle where they have the fluid drained a couple of times before, one, we either see something on an image, or two, we get enough cells in that sucking of fluid to be able to make the diagnosis.
And this is where I want to add, this is where the audience, you guys can actually help. We talked about how advantageous and a good thing for you to get to academic centers in particular for your workups and for your disease treatment. One of the real benefits there is we are able then to collect additional information. I think part of the problem, as you said, is symptoms are attributable to a lot of different things that are much more common. And one of the things that we're actually hoping to do in parallel with all the different treatments, which we've been focusing on lately, but is also how did this patient present? What other elements, particularly genomics? We haven't talked about gene therapy, not therapy, but genes and their role in this as well. And what I'm leading up to is these larger studies are also looking at numerous different components, symptoms, as well as and the like, so we can identify reasons to do better screening. What we lack is screening capacity for mesothelioma when it comes to earlier detection. We've got it for breast, we have it for colon cancer, well, better for colon cancer, and other types of tumors. Yes, it's time for us to be focusing on that as well, and there's big debate. Write your congressman. I mean, should families that have mesothelioma, for various reasons, whether it be work or for genetics, should they be getting annual screening exams with CT? That's the kind of thing that's in discussion now, and I'm sure this organization in particular is front and center on whether or not and how to write your congressman and say, this is the kind of thing that we need you to be focusing on. And I hope I'm getting a nod from the back of the room from the organization. But this is the kind of thing that we need information to justify and to show why it's valuable and pertinent, not just imaging. I hope that helps a little bit, and it is a problem.
The doctors, we went to a big university once ago, and the doctors kept saying, you know, why wasn't he diagnosed earlier? And I'm thinking, what did we do wrong that he wasn't diagnosed?
But let me say right up front, you did nothing wrong. Do not feel this is on you or on your husband. Unfortunately, there are many tumors that fall in this category. It's very hard. There's very few symptoms that are related until very late in the game. You're living your life, and there's no reason to be looking as well. So don't take on that added burden. It's not deserved. I hope everyone hears that. That's really important to know.
Thank you so much. We are actually ready for lunch, have been for a little bit, but we will be back here at 1:20 with our peritoneal panel. So lunch is in the back of the room.
There are no online questions, I mean, I assume, or there were?
There was one, there was one.
Because I'm happy to respond to them, or I'm sure both of us would, so. That's fine, good. I'm sticking around just for that. I meant to say that out loud.
But you can. I mean, you can sort of say like block my clinic from 8 to 9, and I'll go 9 to 1 instead, or something like that. You can do that.
Yeah, I mean, I'd start with most people.
See patients at 10 p.m. in the clinic? They come?
Kieran.
Yeah, I
Nice to
did
meet
it. Your,
you.
the,
There were a
the,
lot
the
of
giant
questions.
Yale talk.
Especially when it came down to the case studies. Those were really interesting to.
Good, okay. Hey, Mike. Okay.
So, yeah, wonderful.
I need to steal your my little document.
The
What happened
dongle?
to Julie Powers?
What's that?
Where's Julie? Powers.
Powers?
Oh.
She resigned in
Yeah, that's a sticky
September,
wicket.
So what?
Julie Powers is that's a
Hang on,
sticky wicket.
that's a hot mic.
Oh, sorry. Why would you leave the mic on?
This thing is so valuable because I
I
lose
have
it.
the exact
Do you
same
know
one.
how many I have?
I
can't
have
find
one,
any.
and it's gone.
I can't
I just
find
bought it
any.
on Amazon. All right, I'll bring it back.
Yeah, no worries.
This one takes a regular USB, right?
Yes.
All right, cool. I'm just kidding. Is it okay when I come up, I'll just plug it in, or do you want me to give it to you first?
You can plug it in. I think it's better to run it off the laptop. You just drop it on the desktop and run it.
All right,
But
you,
if it works,
we have time. Like I can just bring it. All I did was like I added like
all
one
the
little
time in the world.
Hi.
Hello.
So I spoke to my daughter.
Yeah.
Her name is Devin, and her email address is Devin T. Tafaro is her last name at meta.com. She says if you email her and let her know where you stand on getting the approval, she said, yeah, I'll do my best to help.
Yeah, I understand.
And there's no guarantees, like she says because people are reaching out to her all the time, she goes, I don't have the back phone.
That's what I think,
That goes
yeah.
right to but she'll try. She'll try to help you.
Okay, that's wonderful. Can I take
because,
this?
And she thinks that you got kicked off because you moved to, take this, is me, so you know who I am.
All right.
She thinks you may have gotten kicked off because when you moved to Washington, they think it's a political organization, not a nonprofit.
No, it's because of California, because California distinctly took our California nonprofit status away. But I filed 12 years of tax filings. California reinstated us.
Okay.
So we're good on that front. It just happened.
Right.
So I
So
just
tell her
need to-
your story.
Yeah.
And see how much you can help.
Okay.
Do you have a card?
Yeah, that's my card.
You do?
Yeah.
Okay. Great.
Thank you, Mike.
You never know.
You killed it
Yeah,
for
I
a
will-
reason.
Yeah, I did.
Okay.
I'll be right back.
Okay.
I just
No,
wanna...
I see why.
You're gonna show this.
Because I was coming to check.
They are.
That's not the way I would have gone, but okay.
So
Um,
it'll reconnect.
I'm going to reconnect it right now, so let's make sure that it does.
I'm old. I can't see.
I know. Here, this one.
Oh gosh.
Right next to it. Let's see if it can work. I like duplicating because, yeah, go back one.
Yeah, I was like,
I
I think she needs my help.
I'm
No,
going.
I didn't. I just needed to take it offline.
There we go.
Yeah, no, I completely understand.
You now know one, but that will be up.
So the only one I actually I mean, you can just put both on there if you want. Just call
So
it a
you
day.
updated it?
I just added.
Let me take it. Let me delete it because I have it here. This was here. I'm not gonna delete anything. I'm just gonna move it.
Yeah. So I have two talks, right? There's the.
This is what you have.
Yeah, I'm doing this, but
Oh, I see. So this is your case study.
it's my case study
Got
and
it.
it's the Melina and my slides.
Okay, so I had Melina in your slides already, but so if you've updated them since this morning.
I have not updated the Melina and my slides, but the case study, which I just did, is like very slightly.
Perfect. Just making sure that we're on the same page.
And how does it work? Because the case study's not. Oh, it isn't here.
Yeah.
Yeah, so we have that in there. It's fine.
Okay, this is your flash drive.
So,
Does this make
surgical
sense?
case study, that's the one that I'd be doing. And then we have the Melina and my slides are this one, which I haven't changed since yesterday night.
So
to all of the people that submitted images of their loved ones. It was a beautiful ceremony, and I think everyone that was able to be there really enjoyed getting to see all of the memories and pictures and stories that were shared. If you've had the chance to go out into the foyer out here, you'll see that there is a large blue ribbon with some smaller ribbons on there, and some people have written their loved ones' names and some messages of hope and support. We invite the rest of you to also take that opportunity to write on a ribbon and put it onto the board. We're hoping by the end of the conference we can fill the entire ribbon with smaller ribbons of messages of hope, support, your loved ones' names, anything that you would like to share on those ribbons. So if you have a chance later on this afternoon, we invite you to go out there and add to the board. I hope you all enjoyed your lunch and enjoy the rest of your afternoon. Thank you.
Our next speakers for our afternoon session are going to join us for the peritoneal mesothelioma panel. We have here with us moderating Dr. Karen Taraga. He is at Yale University. Dr. Andrew Blakely from the NCI, Dr. Garrett Nash from MSK. And then also, the way we did it this morning, we had our medical oncologist up on stage as well. If you'd like to join us, Dr. Marmorelis from UPenn and Dr. Offen from MSK, feel free.
Thanks, Maya. Well, good afternoon, everyone. It's really nice to see all of you here, and it's nice to be back. You know, we're going to talk a little bit about peritoneal mesothelioma, and forgive me, I think we'll kind of mix several parts of our agenda into one sort of big conglomerate of things so that we can kind of keep the conversation dynamic. You know, obviously feel free to ask questions. You know, we're hoping to make this interactive and hoping that, you know, we can review some of these things together. But I think, you know, this is one forum where I don't need to tell most people that peritoneal mesothelioma is not pleural mesothelioma. And I think that's a very important distinction that we all need to make. And I think when we are advocating, when we are you know, thinking about trials, we're thinking about new studies, it's very important to recognize the differences. We know that they are more associated with germline diseases. We know that they have very different prognosis. They respond differently to treatments. And what we also have to be careful of is there's a lot of nihilism, you know, a lot of nihilism in the physician community, in the community in general, around how patients do with peritoneal mesothelioma. And in fact, among surgeons, because of the way peritoneal mesothelioma looks, a general surgeon that actually visualizes a peritoneal mesothelioma can be very overwhelmed and wrongly prognosticate patients. So I do think it's a very important thing for us to recognize that this is a unique disease. I think the first part that I wanted to share with all of you is something that all of us as a group have been working on, and several other members were not here, so that you get a sense of where we are trying to push in terms of increasing advocacy, awareness, and education. And then we'll talk a little bit about some innovative studies and trials from Dr. Nash and Dr. Blakely. And then we'll kind of go through new concepts in medical oncology as you think about new treatments. You've heard this morning about immunotherapy, chemotherapy, but how do they interface with peritoneal mesothelioma? I've just told you it's very different, but how do they interface? And so we'll hear that from our medical oncologists. And then what we can do is we'll just kind of go through some basic clinical trials that are open right now, and then we'll discuss some cases, think about how do we make those decisions. And then that would be a great opportunity for all of you. If you want to ask questions, we can kind of go through that. But I think, it is important to recognize that clinical trials for peritoneal mesothelioma are very limited. You are going to hear about some of the trials that are open in the United States right now. But the biggest problem we have, and you heard this, in the session before lunch about radiology and CT scans and PET scans, the biggest problem is it's very hard to measure mesothelioma of the peritoneum. It's very hard to think about. So A, it's a rarer disease than pleural meso, and B, it's very hard to measure it, so it's really hard to put patients on clinical trials. And so you need a very dedicated voice. We need patient support. We need advocacy to do that. I think the other thing, like I mentioned, we don't have good education systems. So in fact, it's remarkable when we think about training of general surgeons, training of primary care physicians, there isn't enough in terms of what we do during their training, as well as resources that we provide them to know how to diagnose mesothelioma. I heard someone ask a question, why does it take a year to diagnose this? It's because very often we don't have awareness, even though we have the tools, we have the mechanisms for delivery, such as, now you have internet, you have phones, things like that. And I think the third thing that's very important for all of you to know is that the current treatment guidelines for a lot of these diseases don't represent all the stakeholders. Oftentimes many of these guidelines are made well-meaning, but they don't include the patient voice. They don't include, physicians that actually treat those diseases. And so it is important for us to know that, recognize it, and push against that. So I think one of the things that we've been working on as a group is we're working on bringing together physicians. This is, demonstrating the power of collaboration. I think everyone across the country has been very generous. Everyone is working together. And we've created this sort of consortium where MARF, the physician groups, and then professional societies such as American Society of Clinical Oncology and Society of Surgical Oncology are all kind of working together to try to create a better way of educating our trainees, a better way of creating pathways for management so we can share it with people across, to conduct reviews, to kind of update the evidence that's there, to make standards for how we take care of these folks, and then to align across different societies, pathologists, radiologists, everyone else. So how do we align to improve the care? Finally, with the goal of improving research to provide clinical trials to every single one of our patients that comes through the door with peritoneal mesothelioma. And the goal, of course, is to accelerate education and research. And so this is something that is an effort that the leadership at MARF has been involved with as well. And I invite any of you who has questions, to certainly ask and learn more about it. So I think with that, I'm just going to hand this over to Dr. Nash to speak a little bit about the Icarus trial so you all understand where this field is evolving and how challenging it is to do trials, but then how some dedicated individuals can move the field here.
Hello, good afternoon, everyone. I just have one slide, and feel free to interrupt or to ask questions. This is the clinical trial. We treated the first patient on the trial just a week or so ago, and this is something we're hoping is going to open up at multiple sites over the coming months. So basically, these are for treatment-naive patients, so patients who've not had any treatment for mesothelioma, so new diagnoses. If it appears resectable based on the preoperative assessment, they can consent to the protocol at that point, and if they're go to the OR, and if they can achieve an optimal site of reduction, then they receive IPEC with mitomycin C, and then they're randomized, and this is the question we're trying to answer. They're randomized to getting the same two drugs, same doses, which is cisplatin and pemetrexed, or carboplatin can be substituted as needed. And they get it either intravenously, sort of the conventional way that most people here would be familiar with, as well as then they get it intraperitoneal. So instead of a port being placed intravascularly, they have a port placed in the abdomen at the time of surgery, and then they could be administered in an outpatient setting, the chemo treatments. If, on the other hand, so those are the patients who are apparently resectable. If it's unclear, if the surgeon is uncertain the extent of disease and whether they're amenable to an optimal site of reduction from the start, they can be taken for diagnostic laparoscopy. Also, if the diagnosis is unclear, you can just get it proven on frozen section before the surgery, but we prefer to be sure about it, obviously, because frozen section isn't 100% reliable. So if the diagnosis is unclear or if it's uncertain that the disease is resectable, then they can be taken for diagnostic laparoscopy with biopsies as needed. If they appear resectable then they go down the left side of the screen there, go to surgery, get the cytoreduction and the chemo. If, on the other hand, they're determined to be unresectable, then they go to systemic chemotherapy and potentially are still a candidate for surgery, but they're not a candidate for the protocol at that point because we need treatment naive, because the whole question is here is, does the treatment work? So you can't give it before you even ask the question. So, so if they respond, you may go back for diagnostic laparoscopy to confirm they're resectable and still can treat them, but they just won't be on protocol. If they don't respond to first-line chemo, then second-line or alternative clinical trial. So that's the basic structure. It's designed for about 60 patients, and this is a phase 2 trial, so we're looking for a signal of efficacy. We don't necessarily expect to prove the difference, but at least to get a sense of the relative efficacy of these two approaches to see if they're equivalent or one may be better than the other or less toxic than the other. So if anyone has any questions about this protocol, I'm happy to take any questions now or later.
Actually, with a show of hands, could we see how many of you in the audience have either personally been affected or have family members, caregivers of peritoneal mesothelioma? Okay. Good. So I think, hopefully most of you also understand the terminology. I know it was gone through in the morning, but cytoreductive surgery and HIPEC is the standard of care for patients with peritoneal mesothelioma. And I think this approach is very novel in the sense of delivering intraperitoneal chemotherapy in addition to the HIPEC. And so I think we can either take questions now or maybe later, but if anyone has any questions or comments. Okay, great. I think next we'll have Dr. Blakely just discuss another new idea for taking care of patients with peritoneal mesothelioma.
Good afternoon, everybody. Thank you very much for inviting me to present, and I really want to thank the patients, families, and my team here for being here, because I think that organizations like MARF are critically important for linking up patients, families, and providers. Without groups like this, a lot of patients would never come to meet us. So thank you. Our clinical trial at the NIH is trying to move towards individualizing peritoneal therapy for the patient. And I'm not going to say personalizing quite yet, just because I don't think we're there at this very moment, but this is moving in that direction. So there's various histologies included in this trial, but I hope it shows up as bolded, the peritoneal mesothelioma histology. So one of the issues that we face is that if we focus on any one component of the tumor microenvironment or where the cancer cells are on the lining of the peritoneum, this is an image from a diagnostic laparoscopy, there are tumor cells, but then there are also a lot of other things around it. And there's other types of cells, there's other structures, there's extracellular matrix, there's immune cells, and really that entire environment impacts a patient's response to treatment and how best to approach removing those cancer cells and then keeping it at bay. Ideally, the model is going to recapitulate what is actually happening within the patient. So it preserves that 3D architecture. It has the patient's own immune cells, the intact matrix, physiologic conditions, and is a platform by which we can introduce drugs and evaluate the response to those drugs, which ideally would then mirror what would happen in the patient, him or herself. And what we do in the OR is when we strip the peritoneum that has mesothelioma involved, is we actually take that, we process it, and we put it on these platforms, as you can see here with these tumor nodules on these pieces of peritoneum. And then this goes into a system in the lab that we can then study. And we can keep this alive for up to 4 days. We found that keeping it alive up to about 2 days is reliable enough to preserve that physiologic condition and facilitate testing over time. So what we do on the protocol is we randomize patients to one of two, I would say, equivalent regimens of either intraperitoneal cisplatin with doxorubicin or cisplatin with mitomycin. We haven't had, of course, a randomized large phase 3 clinical trial to say which one of these is better, but when we look at large retrospective databases, a lot of times we see that cisplatin with another agent is quite effective compared to other regimens. At the time of the cytoreduction, we take some of these peritoneal nodules prior to administering the HIPEC, and out in the lab, we simulate the HIPEC. And so we expose the patient's tissue to both regimens. So if somebody is randomized to cisplatin doxorubicin, their tissue is exposed in one system to cisplatin doxorubicin, and in another system, cisplatin and mitomycin. And then we administer the HIPEC to the patient in the operating room. And right after the HIPEC, we've left one piece of diaphragm to be exposed to the HIPEC itself. Right afterwards, we remove that, and we put that in a different system to then say that this is the portion of the peritoneal mesothelioma that's been exposed to the HIPEC with physiologic in vivo conditions. And then we also have a piece of tissue that's been not exposed to any chemotherapy as a control. So we have these 4 tissue samples overall. And what we're looking for is, do we see a differential effect of the 2 regimens in the ex vivo systems? And have we effectively mirrored what happened in the patient with our system in the lab? And if we can show that this is reliably replicated in the system, then the next step would be towards a more personalized HIPEC to say at the time of laparoscopy, we could harvest some of this peritoneal tissue, put it in the platform, test it against 2 or 3 or 4 different regimens, see which one of them might be most effective for that patient, and then at the subsequent cytoreduction and HIPEC, use that regimen and follow that patient out and see how that patient does in terms of recurrence-free and overall survival. So that would be the next level trial that would be justified through what we're studying right now on this trial. So with that, I think we'll go to other clinical trials that are available, but we're happy to take any questions about that later.
So I think, obviously we've kind of started off with just speaking a little bit about how we think about peritoneal mesothelioma, and I think as we start hearing more about, chemotherapy options, immunotherapy options, I think it'll all kind of tie in nicely when we start thinking about our case studies. But I think I just wanted to give you all a flavor of what are the ongoing clinical trials that are specific to peritoneal mesothelioma. Now, there are some basket trials, there'll be other types of studies, and hopefully you'll hear more about them, where patients can be included, but specific to peritoneal mesothelioma, I think the trials that are open is the trial that you just heard from Dr. Nash, the intraperitoneal paclitaxel group, and this is for patients with resectable peritoneal mesothelioma. So they have surgery and then you get an additional dose of intraperitoneal chemo. We had a clinical trial open in Chicago when I was at the University of Chicago, where we said, let's give patients immunotherapy before we did surgery in the setting of resectable peritoneal mesothelioma. And we actually stopped our trial after accruing our first 2 patients because both of our patients had essentially very significant renal toxicity, which was a very remarkable sort of never before reported. And we had other trials where we've done combination immunotherapy for peritoneal mesothelioma, and we had never seen this type of effects where their kidneys really got affected, and then when we did surgery, then again their kidneys got affected. So it was a very dramatic sort of a finding, and we're reporting that soon. So currently that trial is not open. And then the Alliance study, which is looking at a combination of chemo plus immunotherapy for patients who have resectable peritoneal mesothelioma. So the Alliance study has 2 arms, one where you have chemo and immunotherapy and one where you don't. And then you have other unresectable trials, and I don't want to steal the thunder of my colleagues coming up right now, but there are a few trials that are open looking at different targets, whether it's the EGFR target using the drug erlotinib, again, another trial for intraperitoneal paclitaxel in the Netherlands, and other similar trials. But I think what is interesting, and many patients will ask often, is about PIPEC. And so PIPEC is the delivery of intraperitoneal chemotherapy in an aerosolized form. And we know that HIPEC essentially delivers chemotherapy. It's inside a solution, it's placed in the abdomen, it's circulated for about 90 minutes, and it kind of distributes the drug. But I think the drawback is sometimes across adhesions and barriers, sometimes the chemo may not distribute as well. So the theory was, what if you aerosolize the chemotherapy, put it in the belly, and let it kind of spray everywhere? And that technology is called PIPEC. And this is now slowly coming to the United States. It's been in Europe and Asia for a long time. But the trial that is being done in the French group is called the Mesotip trial, in which they're basically doing 4 cycles of this intraperitoneal PIPEC along with systemic chemotherapy to see if it makes a difference compared to just systemic chemotherapy alone for patients with resectable, unresectable mesothelioma. So this is another sort of an interesting space where, you know, new technologies are being applied to study peritoneal mesothelioma, but also a very good example of where groups have gotten together, advocated for it, and now they're able to do randomized trials in a fairly, you know, uncommon disease. So I think this is sort of a good model for us to think about in the US as well. So I think with that, I'll invite both of you to come speak a little bit about systemic therapy options, and then we'll go into some cases and discuss, and hopefully we'll have a lively discussion.
It should be the middle guy. I got it. All right, so we'll be discussing some of the non-surgical management of malignant peritoneal mesothelioma, which we'll just call peritoneal mesothelioma. So in general, most trials and clinical annotations and discussions, it's about pleural mesothelioma, which is the cancer around the lining of the lung, but this is more of a cancer of the lining of the abdomen. Other issues that can occur in the abdomen as well can be a testicular mesothelioma, pericardial mesothelioma is also possible in the chest. We're not going to talk about those today, but a lot of the time, the data we have, the way we treat these, it's kind of relegated to extrapolation and inference from pleural disease. So I do think it's super important that we identify peritoneal mesothelioma as a separate disease state, do studies in it as such, and look at outcomes in it as such. Here is just kind of the ways in which, when you do a quick census, how people present, and they can be quite vague. It can be abdominal distension, abdominal pain, increased abdominal girth, people saying like, their pants are tighter than they expect, but they don't feel like they're gaining weight. You can also at times have disease both in the belly and the chest. So that's kind of colloquially called dual compartment, meaning both spaces can be involved. And that kind of in and of itself is we treat that as a kind of more spread problem where surgery is usually not discussed. I like this here. This is a paper we did, but there's several papers out there kind of asking the question, should peritoneal be considered the same as pleural? Clinically, it's different, and genomically and pathologically, it's different. And so the more we learn about this disease, we learn that the biological underpinnings of it are different, and so we can't just assume treatment outcomes will be the same. So not to go too deep into the details here, but I liked just including some of this because we're talking a lot today about interventions, but I think it's also important to talk about diagnostic workup and like how do you get all the information you need to make the right decision. The first step to that is obviously good imaging, interdisciplinary discussions, medical oncology, surgical oncology, deciding if surgery is right for you and when, if it is, but also learning a bit more about what makes the tumor itself tick. So in peritoneal mesothelioma, unlike pleural mesothelioma, the guidelines actually say there's a specific gene that could be actionable. It's rare, but ALK, which we talk more about in lung cancer, but we can find ALK fusions in peritoneal meso, so it's always something that should be looked for. And similar to pleural, peritoneal meso guidelines would say we should do full genomic testing if there's available tissue, because that helps look for ALK, it helps look for some other rare fusions I won't go into, but can also help open up ideas about clinical trials. The other thing at the bottom here, this is inherited genetic testing. I don't think the point, there it is. So we also do recommend doing inherited or germline testing for all people that are interested. Similar to mesothelioma in the lining of the lung, if it's in the abdomen, there's also about a 10 to 15% chance of inherited predisposition to cancers. Whether or not there was a concern for asbestos exposure, it's still something we would advocate be considered if the family's interested in knowing that information. So I put this slide up just to kind of exemplify how far we've come in the last year or so. Peritoneal mesothelioma never had its own distinct guideline, let alone a consortium discussing the right ways in which to explore and expose the population to those guidelines. So we now actually have in black and white in the NCCN, which is our kind of large consortium, a separate way in which we should be considering treating the disease, which talks to the fact that it is a separate disease state. I put this up here just to start the conversation about systemic therapy as opposed to going through hundreds of trials and some that were good and some that didn't work out so well. This is kind of the way in which we would consider treating people's standard of care with many nuances. My colleague will be going over immunotherapy in a few moments, so I'm going to focus a bit more on the chemotherapy. So in mesothelioma in general, a lot of that data I'm going to be talking about here is kind of taken from Plural. Now, some of those studies did allow peritoneal patients on. However, there was a much lower percent of patients with that type of disease on those trials. So for the most part, we would consider standard of care, as we would in Plural, to either be a combination chemotherapy regimen or most of the time a combination immune therapy regimen. There was a recent trial looking at a combo chemo plus immunotherapy together, but that's not in the guidelines yet for Plural, and we don't really know if there's going to be uptake in peritoneal. For IV chemo, which is what I'm specifically talking to now, we would consider platinum and pemetrexed, also called Alimta, to be a standard option. You can add a third drug to that called Avastin. That's an antibody against blood vessel formation, trying to starve the tumor of blood flow. The other options of immune therapy, again, we're extrapolating from the Plural disease, but we ask ourselves the question, what's the right treatment to start with for a person who can't do surgery? Chemo versus immune therapy are both options. How do you choose? A lot of that has to do with patient preference, underlying medical problems, if one makes more sense than the other, and histology, what it looks like under the microscope. That can be both, the type. Some people may be familiar with the word epithelioid or non-epithelioid, biphasic sarcomatoid. You can go even deeper down that rabbit hole. Within epithelioid, you can break it down further to solid, trabecular. There's all these fancy words that we can see in the pathology report. That gives us a bit of an inclination about maybe which one is a reasonable one to start with first. But it's always important to talk to your doctor about any concerns you have with one or the other and vice versa. So again, I'm going to stick on the chemo vein, and I'll kind of leave ipilimumab, nivolumab to my colleague. But there are other options for chemotherapy through the vein after the initial therapy may or may not benefit. So I choose that word carefully because I was talking to a lovely family a few moments ago. They had, she had platinum pemetrexed, and she's a year out doing well. The question is, could I ever do it again? And the answer is, with nuance, yeah, it's a possibility. If a person's well enough and they've got a durable clinical benefit, which is discussing what that means is kind of a bit esoteric, but if we think they've gotten several months, 6 months plus of benefit, they tolerated it well, you could consider giving the same regimen again. There is a limitation to how much of a certain chemo you can give before you get side effects, so it's with caution. And there are other chemos like gemcitabine, also called Gemzar, people may be familiar with. Another drug which we've started using, ramucirumab, also called Crimza. Vinorelbine is another one. So these are several different IV combinations your doctor could help navigate with you. And of course, clinical trials are always provocative. As we spoke about, those dedicated specifically to peritoneal mesothelioma are not as common, but there are what we call basket trials in early phase development that allow it, and several of the Plural trials don't explicitly say you can't have a different site of origin. So it's really navigating those trials with your doctor and understanding who is the best fit. With that, I'll turn it over to my colleague.
So I'm going to try to help answer a few questions about immunotherapy and peritoneal meso. So the first question is, does it work? So let's start with answering, does just one immunotherapy work? So in particular, this is a study that Dr. Offen and I did together, looking back at all the people that received pembrolizumab or Keytruda. And this was, in particular, patients with peritoneal mesothelioma. And you may have seen these types of plots before, but just in case you haven't, I'm just going to walk you through it for a second. Any line that's going down means that the tumor is shrinking. Any line that goes up means that the change from baseline, the tumor is growing a little bit. And so I've outlined here that those that go down the most, and that was about 21% of them, had a greater than 30% reduction in the tumor. So those are the biggest lines going down. The next group is that group plus the yellow, which is that the tumor actually didn't really change that much up or down. That's our stable disease group. And when looking at pembrolizumab, that was about 73% of patients. So the majority had some clinical benefit. They either had good shrinkage or stable disease. And then there were 26%, so about a quarter of patients that did have growth that was 20% or more. And then the spider plot on the right is actually just kind of a representation at each time point. That's each line represents a patient and how their disease, how the tumor either grew or shrunk. So going down, lines that go down means it's shrinking. Lines that stay kind of the same means stable disease, and going up means that it's growing. So in general, there was benefit for pembrolizumab. There's people that got tumor shrinkage as well as stable disease. So is 2 better than 1? What about combination immunotherapies? So this again is another look back at patients, in the real world treated. This was one center. This is treated at MD Anderson. There were 20 patients that received the combination ipilimumab and nivolumab, and there were 9 patients that had a single immunotherapy, so just one of those drugs. And again, here I've shown you those lines. So we see actually something pretty similar. So 19% had that really nice reduction in tumor size of greater than 30%. And then you see the 65% had about either stable disease or a reduction. And then you do see another, another small group that had tumor growth. When you look at side effects, because I think that's one of the questions that comes to mind, you say, well, if you're giving me 2 immunotherapies versus 1, is that going to be more toxic for me? And on paper, there is a higher risk of some of the side effects from immunotherapy, but for many of you that are familiar with immunotherapy, the toxicity is really not predictable. So some people have very few side effects from immunotherapy, and some have, quite a few, and it can happen at any point. But in general, there was no significant difference between outcomes, either whether you got 2 immunotherapies or 1 immunotherapy. So what about, we've talked about 1 immunotherapy, we've talked about double immunotherapy. How about if we add something besides immunotherapy to the 1 agent? So this is immunotherapy plus. And this is a trial actually that was done prospectively, so that means that patients signed consent to be treated with this combination in peritoneal mesothelioma alone. And this is a fairly recent trial. So not part of a bigger trial. This was just, for peritoneal meso. So it was about 20 patients. The drugs that were used were atezolizumab, which is similar to the other immunotherapies that we've been talking about, and then bevacizumab, which is a drug that targets VEGF. And I just put a little schematic here in case VEGF hasn't been talked about a little bit. Here where you see the food truck, the tumor sends off signals calling the food truck to it. So it needs food in order to grow. It's saying, feed me, and that signal is VEGF. If you give an anti-VEGF agent, you shut down that feed me signal, and the food truck can no longer arrive to the tumor, and hopefully the tumor shrinks. So here we have, the lines that are going down again are those in red and yellow. And here we have about 40% of tumors that shrunk 30% or more. So a little bit better, actually, than what we saw with single agent or double agent immunotherapy. I will say the one caveat to that is this was a prospective clinical trial where there are lots of enrollment criteria, and the other 2 studies that I showed you were retrospective, meaning that they just looked at what happened to patients in the real world. So we know that patients that are on clinical trials, there are a lot of monitoring parameters. They may, outcomes may be different. They may react differently than what happens in the real world when people have other, medical problems going on as well. So immunotherapy in a nutshell. It's active in fighting peritoneal mesothelioma. Both single and double immunotherapies have similar efficacy, and the addition of something like anti-VEGF may be particularly beneficial. And a bonus was that trial was done in peritoneal mesothelioma, so we have extra assurance that it could really help people with peritoneal meso. Just a few kind of moments on supportive care in peritoneal meso and how it might differ from supportive care in pleural. So this is kind of a nice schematic of all of the types of things that could be involved in supporting a patient that is undergoing cancer treatment. For patients with peritoneal mesothelioma, fertility preservation, for example, in patients that are quite young, some of these surgeries, high PEC, they can reduce fertility. Support groups, obviously, for patients and caregivers are crucial to both, families and caregivers of patients with peritoneal and pleural mesothelioma. This is a rare cancer. I think you guys have probably more stories than I do about navigating the financial issues with trying to get treatment approved in a rare cancer where there are very few FDA approvals and we have to go on small trials, and trying to explain that to insurance companies is very challenging. And then for peritoneal meso, there are, nutritional services are particularly important because there may be complications from surgeries or times when it's more difficult to eat, that we really do need their help. So what does living with peritoneal meso look like? Again, lots of people in this room could tell me a lot more, but really no two patients have the same treatment course, and that depends on. There are different histologies, epithelioid, sarcomatoid, biphasic. There are different extents of disease. The disease you can have a lot of disease or very little. And the location, if it's in a bad location that can't be resected, that's very different than disease that is easily resectable. And although the disease is not curable, many patients can have sequential surgeries and non-surgical therapies over years and years that can keep things under control. Others, unfortunately, may have disease that's more resistant, and that's why this is such a heterogeneous group of people. There's a lot of data that's extrapolated from pleural mesothelioma. Many people have talked about that, but there are clinical trials, as we've mentioned, that are specifically looking at peritoneal mesothelioma, and so it's really important that we support those so that we can move the field forward. And then lastly, being seen at a center that sees this disease, and in particular surgeons that do this type of surgery a lot, is also critical to this to treating this disease. Thank you.
Thank you.
Thank you, everyone.
Questions? Do we have any questions in the room? I have a question from the chat, and then we can come to you. I have meso in both pleural and peritoneal. The doctor made the assumption the source was pleural that metastasized to the peritoneal, so we never biopsied the peritoneal. Do you think we sold ourselves short by not biopsying the peritoneal?
Yeah, so I think maybe I'll ask the panel to also speak about this, and maybe I'll start with Dr. Offen. So how, in your mind, do you approach someone who, say, has pleural mesothelioma? And let's do this in two settings. So one where there's initial diagnosis of what looks like bicavitary mesothelioma, meaning both in the pleura and in the peritoneum. And then how do you think about someone who's been treated for pleural mesothelioma and then has something show up in the peritoneum? And finally, what would you do, and maybe we can go around the panel, and finally, what would you do when someone has been diagnosed with peritoneal treated and then is diagnosed in the pleura? So maybe let's look at the three options.
So in general, it can be difficult at initial presentation if a person comes with issues both above and below the diaphragm. A lot of the time we have to kind of take a look and see where the dominant disease is, if there's a lot more bulky disease in one area than the other. But it's really hard to say. And to the specific question in the chat, without knowing the full story, it's kind of hard to fully comment. But when somebody's diagnosed, it's in both the chest and the belly, for the most part, never to speak for a surgeon, that makes surgery much less likely to be considered if it's involving both compartments. And so the treatment, again, knowing that pleural and peritoneal are somewhat similar, you're probably still on a reasonably good path. And I could say clinically, if a person comes in, one site's biopsied, it makes sense that both sites are involved based on the picture. If somebody needs treatment, then they move forward with treatment. So I just wanted to say that to answer that question first. If for a person, maybe I'll answer the first part of it. If somebody presented with pleural disease to begin with and the abdomen looked clear, depending on the institution, sometimes people will actually take a look with a laparoscopy to take a look at the abdomen. Otherwise, it's just a really good cross-sectional imaging. We would treat the pleural disease as, my colleagues this morning talked about. Surgery may or may not be considered with a lot of nuances, and then medication therapy. If somebody had a really good response there and then later noted to have progression in the abdomen, in that setting, if it's the only site that had an abnormality and it was new, we would tend to consider sampling it if it was safe to do so to make sure we're dealing with the same problem. I wouldn't make the assumption, like, common things are common. If somebody had pleural mesothelioma and let's say it was a male and they were 60, 70 years old and now they have a new spot in a lymph node in the groin, I'm not going to assume it's peritoneal meso until I actually can look at it under a microscope and prove it's not something more common like prostate or something else. So first, confirm the diagnosis. And then, usually in that setting, we would have a discussion. Probably wouldn't be surgical, but again, there's a lot of nuances. And I think the most important thing to say out loud is we are only as good as our colleagues at our institutions. So when I meet a person, it's not my job to assume surgery doesn't make sense. And the amount of times I email Dr. Nash and I'm just like, I'm seeing a patient today. I don't think they need to see you, but what do you think? Like, that's the way we operate. It's to make sure that we're exploring these avenues for you. So if somebody had a new spot and it was only one spot, I would talk to my colleague to see does it make sense for a consult, and then I would move forward from there.
Great. I think, Dr. Blakely, you have the mic. So maybe speak to me of how you think about peritoneal spreading to the pleura. And then in this diagnostic situation, do you offer patients diagnostic laparoscopy if it's pleura potentially spread to the peritoneum?
So I was going to take a step back. And in this setting, I think that whenever somebody presents with bi- or tri-compartmental disease, the importance of genetic testing cannot be overstated. If somebody has a germline BAP1 mutation, I would reclassify that patient as having two primaries. I don't know if medical oncologists would agree with that, but we've had a couple patients in our practice who we have reclassified as having pleural mesothelioma metastatic to the peritoneum or vice versa as having primary pleural and primary peritoneal. And in the setting of a germline BAP1 mutation, we would treat the compartments sequentially, starting with the dominant one. And that's where, in that setting, it would probably be rational, even if one chest doesn't have apparent disease radiographically, to do a laparoscopy and bilateral thoracoscopies and stage all three compartments. That, and having seen that clinically and having seen when folks are coming in from other centers and not having that sort of approach, that's one immediate thing we can improve with care. I think when we're looking at somebody who has BAP1 germline wild type, where it was a clear pleural primary that has gone to the peritoneum, it depends. In that setting, then it is metastatic. And at that point, it's very much personalized to what can we achieve with surgery and how can we improve that patient's quality of life at the same time as trying to optimize control of disease. And so in some circumstances, it might make sense, especially if somebody has ascites that's refractory to systemic treatment, and they're very symptomatic from that. Sometimes we would probably call it palliative debulking and HIPEC may help with symptom control. So there are going to be certain situations. And then on the flip side, when patients have a primary peritoneal and then pleural involvement, that's likely from direct seeding, because those patients I've seen have frequently had a prior cytoreduction HIPEC. It's not uncommon for us to end up violating the diaphragm from the abdominal side and probably have direct extension of tumor cells into the chest. But again, that's going to come down to systemic control and potentially thoracotomy and decortication in order to control the chest that is secondarily involved.
I think, and I'd love to hear the other panelists' thought as well, but just to kind of summarize big picture, maybe how to think about this. If someone has cancer that is in both, if mesothelioma is in either chest and abdomen or chest, abdomen on both sides of the chest, I think it is critical, and just to reiterate and emphasize Dr. Blakely's point, it's critical to make sure that we're testing these patients for germline disease. So BAP1 mutated tumors will have a very diffuse appearance. So you see very small nodules that are across the entire peritoneum, and in fact, if you look at even normal peritoneum and you look at it under the microscope, you'll see mesothelioma in there, not infrequently. So it's actually a very remarkable disease. It is sensitive to platinum chemotherapy, but at the same time, these patients do remarkably well, even with bicavitary disease. So you can, like Dr. Blakely said, you can clean the abdomen, then the chest, then the other side, and despite doing multiple surgeries, patients can actually live very long. This is very different than when the cancer starts in the pleura and is a classic pleural mesothelioma and then subsequently develops a peritoneal metastases or recurrence or whatever. In those situations, the prognosis is much more different. It's a much more serious disease, and then I think to Dr. Offen's point, making sure you're diagnosing it appropriately, biopsying it, I think is critical, and then thinking about trials or chemotherapy or immunotherapy as appropriate makes sense. Not very often do we offer those patients surgery. And then finally, if it's in the peritoneum and dominantly in the peritoneum and then has spread to the chest as a subsequent occurrence after they've had surgery for the abdomen, it is quite often because of violation of one of the planes. So I think those are sort of three critical points. They all have different meanings when we think about these patients clinically. I don't know if either of you have any comments to add.
Yeah, I have a couple of comments. I will say that not all chest disease that shows up after abdominal surgery is related to the surgery. A lot of times the reason why we've had to violate the diaphragm is because the disease was growing through the diaphragm at the time of surgery. Oh, I'm maybe not close enough. I was just saying that the spread might have happened even before the surgery at a microscopic level, because often the patients who I've seen who get subsequent pleural disease after abdominal disease, they had a lot of diaphragm involvement, and there was probably some transmission through the chest. And we've seen that in other peritoneal malignancies like colon cancer, ovarian cancer, appendix cancer, that it can happen completely independent of the surgery, but temporally appears to be related to surgery, but in fact it happened before. The other thing I'll say about biopsies, the most important question to ask when deciding if you need another biopsy is, will it change management? Right, so you don't want to go through, any biopsy is an invasive procedure, and though for the most part they're outpatient, relatively safe procedures in most contexts, there's always some risk. So, it has to somehow change management. So one of the common situations I see is where we don't biopsy is when someone has bulky abdominal disease, may or may not be amenable to surgery, but they have then small lymph nodes in the chest that are indeterminate. And a lot of times that creates a lot of anxiety. What are these? But ultimately, if it's the disease in the abdomen in those situations is what's going to drive the outcome. And we somewhat disregard small things in the chest, knowing that they're going to be getting chemo and they're going to be treating the disease wherever it is in the body. There may be some differences in response, but essentially you'd be picking the same drugs anyhow in most cases. So often we, just treat them. Sometimes they go away, sometimes they're stable, sometimes they get bigger, but that tells you a lot about what's happening just by monitoring their behavior. But again, for the most part, patients with bulky abdominal disease, that's going to be the driving factor throughout the course of their disease, even if they do have some small component of the chest. So a little different than the patients of extensive disease, or quite different from the patients of extensive disease in the chest, but small amounts of disease in the chest, sometimes we just sort of treat incidentally and not become the center of the treatment.
Great. Are there any other questions? Otherwise, we can kind of go ahead.
I have just one thing to add while.
Oh, sorry. I didn't mean to.
No, that's okay. While you're walking over, is I think about the role of surgery in peritoneal mesothelioma is really important, and if you're able to get surgery, that's one of the key parts of treatment. And I think now in pleural mesothelioma, we're just not as sure that it's the same. It's as important as it is in peritoneal. So thinking about disease that's in both the pleura and the peritoneum, there is a different weight placed on whether surgery is done or not.
Yeah, good point.
My question is to you. Your presentation, there's a sentence in your presentation that said peritoneal is not curable. And I just need to understand what that means, because with other cancers we hear after 5 years, 10 years of NED, you're considered cure. I'm 10 years NED, and my doctor keeps saying, I think we can use the word cure. And I said, no, the texts say no. Can you explain how you define cure or not with this disease?
Yeah, I think that's a really good question and a difficult question to answer, actually. And it's something also that we are running into in other cancers that treatment is becoming, more and more effective for. I would say in the breast cancer world, they use the word cure a lot more, even though disease recurrence still happens. So I think it's a little bit of the terminology. But if the outcome is the same, that people are living a long time without disease coming back, I think it's just the semantics. So I don't know the right words to use. I usually say, with patients, I say controlling the disease and, keeping it at bay is really the goal, and trying to have long periods of time where you're not on treatment that is affecting your quality of life. And if you never need another treatment again, then that's great. I don't end up using the word cure with many of my patients just across the board, because unfortunately I don't have a crystal ball and I don't know what's going to happen in the future, even in patients that have early stage diseases that could be curable. So I think it's a tricky word, and I can appreciate that it gets confusing.
I agree. I substitute the word with control. I think control is what we aim for. I think 5 years is kind of an arbitrary time point. We've probably all had patients who have had stage 1 or 2 disease that have come back 10 years later. And so, that recurrence curve probably never quite gets to zero, probably gets close. But I would be reticent to stop following anybody after just 5 years. And I think really it's lifelong surveillance. But I think, control is a much more appropriate word.
But I do want to congratulate you. I think, it's a remarkable thing. I think you're a true cancer survivor.
It is tough to say when someone's cured. I had a patient who was being followed for 6 or 7 years after treatment, had no signs of cancer, felt great, and then very tragically died of something totally unrelated. But they did an autopsy and they found small amounts of pleural and peritoneal. We only knew she had peritoneal, we didn't know she had pleural, but these were tiny amounts, never would have shown up in a scan, and we don't know what would have happened to that disease as well. It's like the patients with germline BAP1 mutations, where I've seen patients where they had biopsies 30 years before, which was highly suspicious but not definitive of meso, and they didn't get BAP1 testing. That wasn't on their physician's radar, but it took 20 or 30 years before it manifested itself in some measurable way. So, there's so much we don't understand, and it's a very heterogeneous disease. We know people have lived for decades with this. Some having long periods off of treatment. So I agree, it's really tough. I mean, no one walks into their oncologist's office without thinking, can I be cured, right? That's what, and I agree that, it almost becomes this buzzword, like it's all or nothing. Oh, I've got terminal cancer or I'm going to be cured, right? And many people, it's hard to separate those two extremes. And for most patients with meso, it's very much in the middle, where it can be hard to document how active the disease at any particular point in time. So it makes it so hard to call for that. So I don't want anyone to be discouraged, particularly people who are sitting here, hoping that they will never have to face treatment again, because there are many people who won't. And there are many cancers we've learned people die with, not of, right? Now, unfortunately, most mesos are more aggressive than that, but, we know prostate cancer, thyroid cancer, quite a number of cancers that if you do autopsies, you find them, but they didn't harm the person. So I think, you have to, it's not binary, it's not all or nothing. So again, I agree. congratulations to you, and what a wonderful thing. And I would remain optimistic. I don't think this should make you fear that you're going to die of meso one day. But it's just a very gray area.
Great. Well, I think, maybe what we thought we could do is maybe just think a little bit about how we evaluate patients, how do we think about patients a little bit, so that you all get an insight into how treating decisions are made. So maybe I'll start with both Dr. Blakely and Dr. Offen. Can you speak a little bit about how do you approach a patient that comes to your clinic with a diagnosis of peritoneal mesothelioma when they're sort of at the extremes of age? So let's say they're young, like 20s to 30s, or they're much older, like in their 70s. What are things you think about? What are factors that you think when you're looking at them?
So, I mean, I can kind of take a little more perspective. I'll start with the diagnostics and things like that. Regardless of age, I always recommend both tumor and inherited genetic testing if the patient and their family is open to it, for many of the reasons we've alluded to. Also, somewhat regardless of age, if a person is of potential reproductive capability, I think it's important, so I'm not going to say the extreme young or the old. If a person is of reproductive capability and wants to preserve that, we always do recommend consideration at the first visit of sperm banking, egg preservation. If there's time to do these things, now's the time to have that chat. Again, I don't think age is a definitive predictor necessarily of surgery is a good idea or not, so I would always advocate seeing our surgeon for a collaborative discussion to see if the disease is amenable to it, to decide if it should be a multidisciplinary approach or we should start with systemic therapy. Those are my main points. I don't think I would determine the type of drug I give based on age. I base it more so on the extent of disease, symptoms, underlying other medical problems, and labs.
I think all those are excellent points. I don't think there's one way to approach it. Certain things I take into consideration are going to be, the patient's physical status coming in, how much ascites the patient has, and if we think we can improve ascites, improve nutritional intake, and get a patient more ready for surgery through chemotherapy. By the same token, I've had patients with peritoneal mesothelioma who have done worse with chemotherapy and did much better after surgery. And so it's all individualized. We find that sometimes mesothelioma, especially bulky disease, can be pretty inflammatory, and it can be something where a patient is actively losing weight and really losing their strength because of the disease, and the chemotherapy can get on top of that, but sometimes it doesn't. But and I agree, the extremes of age, I don't think there is an age range to say germline testing is more or less beneficial. I think it's across the age spectrum. We've had patients diagnosed with BAP1 mutations in their late 60s. And so, I think it's one of those paradoxical situations where the germline mutation actually portends more favorable biology a lot. But when it gets to be pretty bulky and significant later in life, it's, pretty substantial. But really individualizing that is so critical.
Great. Dr. Nash, question for you. When we think of mesothelioma, obviously we're thinking of the common epithelioid mesothelioma, but are all mesotheliomas bad? Are there good mesotheliomas as well?
Yeah. Well, I don't know if there's good ones, but there's ones that are less bad for sure. I don't know we've got a good way of discriminating at diagnosis other than the well-diff papillary mesos, which appear to be not a true malignancy, and the majority of those, unless there's some feature that makes you suspicious that that's not fully telling you the story, that they have symptoms, bulky disease, because you can have, I suspect that well-diff papillary meso is a precursor that and we've seen it, I've seen it in BAP1 germline mutated patients where the first thing they get is well-diff papillary meso, and then they ultimately develop malignant meso. So I think that is a very important distinction. The patients who are asymptomatic with minimal disease and their biopsies just show well-diff papillary meso, we're just watching. And I don't think we've found anyone to progress to disease. There's a couple of cases, or progress to need treatment. There are a couple of cases in their literature of people who had Wilder-Papillary meso who ultimately died of meso, but there's actually more case in the literature of patients with Wilder-Papillary meso who've died of treatment-related complications and have died from the disease. So we're very careful to really think through these patients and make sure they're adequately sampled. So that's sort of the one very striking subgroup. But once you've documented invasive meso, which generally like a percutaneous needle type biopsy is not sufficient. Usually you need a chunk of tissue. So usually when someone comes to me without a tissue diagnosis or an ambiguous diagnosis, I'll take them for a diagnostic laparoscopy so we can get a substantial amount of tissue and be really sure that we've nailed down the diagnosis. But there are some patients who present with absolutely no symptoms. Their performance status might not be so great, or they're not very enthusiastic about treatment, and we've watched them and ultimately found in some patients it can take years. Dr. Raff and I share a patient who recently started treatment, maybe in the last year or so, but he had 6 or 7 years before he had any. He had very, very slow progression. So it's certainly not wrong in an asymptomatic patient who is not enthusiastic about going right to treatment, to observe them for a period and get a sense of what the pace of their disease is, because there is a big range, and I don't know how to identify those patients other than based on their symptoms at diagnosis.
I think something else just to add again, kind of hearkening back to genetics. So well-differentiated papillary peritoneal mesothelial tumor, because they're trying to differentiate it a bit now from a true mesothelioma. Looking at the genetics of these tumors, if there's equivocation, if people aren't sure, can sometimes be helpful. There are certain genes that we find more so and well-differentiated than you would in invasive mesothelioma. And for the most part, the proof is going to be in the biopsy and the clinical presentation. Another relatively rare entity would be a multicystic type of disease state, which a lot of the times can just be observed or surgically managed without the need for systemic therapy. But again, these are very unique clinical presentations that a lot of time require a good biopsy.
Yeah. I think let's think a little bit about the other end of the spectrum, though. So, Dr. Marmorelis, if you have a patient who comes in with, say, a biphasic or sarcomatoid peritoneal mesothelioma, how do you think about that? And maybe speak a little bit about how important is histological assessment when you think about peritoneal mesothelioma? Do you use just grade? Are you using just, like we heard before, the trabecular formation, deciduoid formations? Are you using Ki-67? How do you think about how aggressive a disease is? And maybe also if you could speak a little bit about when you see someone with sarcomatoid peritoneal only mesothelioma, how do you approach the first line of treatment there?
Yeah, so I think this is actually something that peritoneal and pleural share. So we're now starting to think about the histology as guiding treatment. So in peritoneal mesothelioma, if I see someone that has biphasic or sarcomatoid peritoneal mesothelioma, I'm, for the most part, not considering a surgical approach. Sometimes for those with biphasic, which is a mix of epithelioid and sarcomatoid with low volume of disease, we would consider surgery. But I'm starting to think about systemic therapies a little bit more seriously, especially in those with symptoms. And just like in pleural mesothelioma, we're borrowing some of their data where they actually looked at chemotherapy versus immunotherapy, and saw that those that had biphasic or sarcomatoid histology did much better if they got immunotherapy. And so we've borrowed that in peritoneal mesothelioma as well. And so patients that have biphasic or sarcomatoid, I would start with immunotherapy first.
Yeah. I'm going to keep asking questions, but if any of you have questions in the middle, feel free to just raise your hand, and I'm absolutely happy to stop and take your question. But I guess the question for the surgeons, we heard that, surgery, cytoreductive surgery is critical in the management of patients with peritoneal mesothelioma. And so maybe Dr. Nash and Blakely, can you share how do you make decisions about what is considered resectable? And so we all know there's a score called the PCI score, which maps the abdomen into 13 zones. It gives a score of 0 to 3 in each of the zones. So the score can go from 0 to 39. And because mesothelioma is a disease of the peritoneum, it's not uncommon for us to look inside and see a ton of mesothelioma all over. And so the question is, do you use PCI score as a cutoff, or is it more the distribution or the ability for you to do surgery, or a combination of factors? And how do you decide if someone is resectable or not?
Yeah, it's definitely a combination of factors. You sort of have to match the extent of the disease with the patient's performance status. You know, there are some patients who come who I think would be able to undergo an operation, normally my voice is not a problem. I don't know why I'm having difficulty today, but so you want to match, if someone has extensive disease, they need to be very fit. And you also need to factor in, while age is, to me, not a absolute contraindication, you have to factor in what would happen to this individual and their quality of life if they had a major complication. You know, someone who is 30, 40, even 50 years old is going to tolerate a complication and get back to a functioning life again much better than someone who's in their late 70s or early 80s. Even someone of that age who's very fit, I often say to them, you know, yes, I think we can do the surgery. Yes, you seem fit. But if you have a complication, your life may never be the same again. You may never, you know, return to that degree of fitness or performance status. So I think, you know, you always have to think about the worst possible scenario, and that often comes in very significantly in older patients who, you know, and again, I don't think you can make absolute rules, but for the most part, younger patients want duration and older patients want quality, and that's an overgeneralization. But for the most part, I've discovered that the older a patient is, the less interested they are in undergoing a high-risk surgery that might take away what quality of life. Because when you think about it in pure, you know, economic terms, you're getting more bang for your buck with successful treatment at a young age because you got more years of life potentially ahead of you. So I think these require really, really extensive conversations with the patients. These are hour-long minimum and sometimes 2 office visit type conversations before committing to, you know, a large operation. So I would say the performance status of the patient, the goals of the patient is also equally as critical, and then the extent of disease. The absolute contraindications are extensive bowel involvement. Because there's little we can do surgically if there's extensive small bowel involvement, because you need at least half of your small bowel to maintain nutrition. And, you know, as most of you will know, the leading cause of death among patients with peritoneal meso is bowel failure, bowel obstruction, malnutrition. So, you know, we have to be very mindful about how much bowel has to be sacrificed in order to clear the disease. So PCI is important, and patients with very high PCIs, I'm obviously very concerned about how well we can control their disease with the surgery, but the distribution is more important. I've had patients where the bowel is almost completely spared, but there's heavy involvement on the non-bowel surfaces, and that's usually quite manageable. It's still physical trauma to the patient, and there's still a lot of recovery from extensive peritonectomy and from other organ resection, but bowel resection increases the risk of short-term and long-term complications, so that, I think, is probably the most important factor to consider. Losing a gallbladder, losing a spleen, ovaries, these may have some implications, but not nearly the implications of the bowel.
I think when we think about 2 of the things that are most prognostic for cytoreductive surgery in HIPEC, PCI is one of them, but so is completeness of cytoreduction. And if even with extensive disease, if we think we can get everything down to 2.5 millimeters or less, which is a completeness of cytoreduction score of 1, you know, removing all visible disease is 0. But if we can get down to a CC1, the long-term outcomes are pretty similar, and we can still provide quite a benefit. And that's also going to make a difference as far as how we approach organ resection. So if it's going to be the difference between a CC0 and a CC1, I'll be more aggressive. But if somebody has extensive disease, but it's all small volume and it's still within that CC1 range, then we might say we're going to hold off a little bit for right now. And I would actually look at it in a different way. For younger patients, our treatments are getting better. And what I also don't want to do with my surgery is overstate the benefit and then compromise that patient's ability to go on to some subsequent treatment because they have relative shortcut syndrome or have a complication or some other reason that I have then taken a treatment option away. And so a lot of it is balancing what is going to be the benefit of the surgery versus what is going to be the cost, not just in the perioperative phase, but also in the long term. We don't want to plan our second operation with our first operation and say, we're going to come back and do this again. But leaving that option open, some patients do undergo 2 or 3 or hypex over their lifetime. And so I think that's where that 1 or 2 hour discussion also lands. And I think that also is so important to be guided by a laparoscopy, to really see what is the distribution and the morphology of the disease and what do we think we can technically achieve and how do we balance those goals.
So I think that's a nice segue into this sort of next comment, which is, say you look inside and you see there's extensive disease, and Dr. Offen and Dr. Marmaris, they do some magic and, you know, things are working, and we'll talk about the magic in a minute. And then you go back and you do another laparoscopy, and there's still pretty high burden disease on the bowel. You still feel like you cannot clear this disease. The patient is young, motivated, goals are to live longer. At what point do you ever consider surgery in this setting where you know you might not have a complete cytoreduction, or do you never offer this person surgery?
I think a part of that question, or part of that answer, is going to be formulated by the symptoms. So if we're running into somebody who has abdominal pain, a lot of ascites that's refractory to treatment, those can be reasons, and those can be symptoms that we can treat with the surgery and potentially improve. But there are certain situations, and so I think, again, it goes back to being individualized, and I think part of it is the extent of the cytoreduction. It's pretty low risk for patients to have their, what we call the parietal peritoneum, or the peritoneum on the underside of the abdominal wall, down in the pelvis, under the diaphragms, for that to be stripped. I think that, you know, that can still provide quite a bit of benefit, but it really depends on what the patient's coming in with as far as symptoms.
Yeah, I mean, I think the general rule is if you can't get them down to minimal residual or CC1 or CC0, the role of surgery is much more limited and needs to be very targeted. And there, you know, the concept of just decreasing the amount of cancer surgically doesn't really seem to have value. You know, if you're leaving, you know, a lot of disease around the bowel, how much value is there stripping the disease off the diaphragm? I'm fairly skeptical that it matters that much, unless there's symptoms. Like I had one guy who had chronic hiccups from diaphragm disease, and we cleared his diaphragm and his hiccups stopped, and he was just hiccuping 24/7 until then, so he was extremely happy that his hiccups went away. But we couldn't clear all his disease, but we served a purpose with the surgery. Other examples are people losing weight, their appetites decrease because they're evolving into a focal bowel obstruction, not global bowel failure, but an area of bowel that's narrowed or kinked that you can address in order to, you know, allow them to eat better. So I think when you can't achieve an optimal cytoreduction, then I think it's up to you to figure out what can I achieve and have a very frank discussion with the patient and their support group as to, you know, what are their goals. And, you know, in my mind, like, for example, I would have never thought if someone said, can you do surgery for my hiccups? I would have laughed probably initially. But, you know, this guy, it changed his life. For a year, he stopped hiccuping. So for him, it was hugely important to do that. Probably the best thing we could have done for him. But, you know, those are very much case-by-case type situations.
I mean, I think that the thinking has changed a little bit in peritoneal meso. You know, unlike other diseases, we know from other peritoneal metastases that you absolutely have to remove everything. But there was a study that came out in the late 2000s from a big group, SOGI, in one of our important journals, Journal of Clinical Oncology, where they found that even if you had a CC2 cytoreduction, so you heard completeness of cytoreduction, meaning you've removed it down to at least less than 2.5 millimeters thick. But the study found that when it's even 2.5 millimeters to 2.5 centimeters, which is like pretty substantial, like an inch, and they got intraperitoneal chemo, these patients actually did better. But then I think over the years, the data has been refined where I think all of us have come to this understanding that that is not acceptable in our patients, and generally we'd only operate on patients when they're symptomatic or there is a focused area of need for the patient. So I think that's a key evolution of the way we've thought about cytoreduction in mesothelioma. So I guess Dr. Offen, Dr. Marmaris, maybe speak a little bit about, in this scenario, how would you approach, if it's an epithelioid mesothelioma, How do you think about whether you would do chemotherapy or immunotherapy in this evidence-free zone of peritoneal mesothelioma? Do you check PD-L1 status? Do you look at the tumor profiling? How do you kind of decide who gets what?
So it's a good question. A lot of it comes down to, again, medical comorbidities, patient preference, what we think may be the safest of the options. To just address PD-L1, I'm not sure how familiar people are in the room with that, but it's basically they'll take a slide from the biopsy or surgical material. They literally will stain it and they'll give you a percent, 0 to 100%. The higher the percent, the higher the PD-L1. And in certain tumors, most archetypal being lung cancer, let's say, the higher the percent, the better the chance immune therapy may work. That is not as well vetted in mesothelioma, either in the chest or the belly. So it may sway me one way or another, but it's not necessarily the defining feature in my practice based on PD-L1 alone. A lot of it has to do with histology. So if a person comes in and they're not resectable, or let's say they see my surgical colleagues and they're borderline resectable, but we need a response first. If it's epithelioid, standard is still to consider chemotherapy technically, but nowadays immunotherapy is also very viable, albeit somewhat data-free. If it was non-epithelioid disease, so biphasic or sarcomatoid, again, as Dr. Marmarella said, I think extrapolating from the pleural literature, a lot of us would be more prone to give immunotherapy up front. But again, it's a very individualized question.
The only thing I'll add is I also take into account whether there's fluid in the abdomen that's causing a problem. So there's some evidence that adding agents against VEGF like bevacizumab can help to reduce some of the fluid that's in the abdomen, and that's often combined with chemotherapy, but also can be combined with immunotherapy. So that's another consideration in terms of the systemic therapy options.
Can I ask what other situations you would use Bev in first line as part of your combination? So ascites you mentioned is one. What other scenarios? And what scenarios would you not want to use it in?
In a patient without a reason not to give Avastin, and if we did not think surgery was immediately a viable situation where there'd be a concern about potential healing, if I'm going to give chemotherapy and the patient's otherwise physically fit, we think about cisplatin, pemetrexed, also called Alimta, and I would consider Avastin. And that's been a lot of the caveats and discussions in the pleural literature from some of the trials where people will say Avastin's not completely standard. It's in the guidelines. It does have benefit for some. Yes, it does have complication, but in my practice, unless you're telling me give them 4 cycles and I'm hoping to get them to surgery, if I'm going to go for chemo, I would add the Avastin if there was no reason not to.
Just for those of you who aren't aware of this, Avastin interferes with wound healing, so it's a dangerous thing that can be used in the pre-op setting. It can be dangerous. So when we know someone's going to surgery, we generally don't like patients to have Avastin. Plus, you have to be off for 8 weeks before surgery. So most of the patients I see aren't on Avastin, which made me curious about how you do decide.
Great. I think we'll pause for a minute here, see if there's any questions. We do have another case discussion if you all are up for it. But are there any questions from the floor?
We are also a little bit short on time, so let's do the non-surgical case study.
All right, so since we are, what time does the session end? Just 5 minutes? Okay. No pressure. So basically what I'm going to do is just go over a lovely patient of mine that I'm actually seeing Tuesday. I shared with Dr. Nash. So this was a 61-year-old woman who presented initially with very vague symptoms, abdominal discomfort, bloating. This was in the very beginning of the pandemic. She, as many people did during the beginning of the pandemic, tried to say it was no big deal. She was fine, waited about, a year or so until things started to get more noticeable, more discomfort, weight loss. She got an ultrasound with her primary care clinician and unfortunately was noted to have a quite large abdominal lesion. She was seen at another very good cancer hospital initially. Before they knew what the diagnosis was, they were thinking about things like ovarian cancers, gastric cancers, the more common, if you will, belly cancers, but they did the right thing. They biopsied to figure out what it was. And they called this, on the next slide, an epithelioid peritoneal mesothelioma. And I just put this little snip here of all the fancy terms and words. When we did make the determination of an epithelioid or a non-epithelioid mesothelioma, it depends a lot on the kind of how good the biopsy material was, but it also depends on the pathologist. And so this is kind of the nuts and bolts behind the scenes of what we look at, what they look at. It's all these different stains. It's not just visual, but it's also these diagnostic tests and workups that help us figure out and confirm the diagnosis. So before I get going, I guess just onto the next part, I'll ask Melina, Dr. Marmorelis, what other, if any, diagnostic test would you want to have sent off concurrently for a new diagnosis?
Yeah, so one of the other things we look at is Ki-67. So that's basically a marker of how quickly the cells are turning over, how quickly it's growing. The higher the number, the kind of more rapidly it's growing. And so that can give us an idea also about the aggressiveness of the tumor. So that's one other thing I look for in pathology. I don't use PD-L1, so that's not something that I would look for necessarily.
The other thing we did do with, in her case, as I mentioned, we offered her somatic and germline testing. At this time, she transitioned her care to our institution just based on geographic preference. It came back with a BAP1 and a PBRM1 alteration. So these are tumor genetic alterations. So it's something she was not born with, but something the tumor acquired over time. And the inherited genetic testing was negative. So my next step in management, when I met this, lovely 61-year-old fit patient, had some symptoms, pretty bulky disease. We've confirmed the diagnosis. I called Dr. Nash, and I asked him, what do you think? We looked at the cross-sectional imaging, and he said maybe it was possible, but it wasn't an upfront consideration. She had a lot of bowel involvement, and she would have needed a good response. So I guess I'll turn the question to the panel if anybody wants to comment. So a person that has borderline resectable disease in what we could call the neoadjuvant intent or pre-surgical is the intention setting, what would you consider giving this patient? I guess I'll ask the medical oncologist.
So I think the data is probably best for chemotherapy without bevacizumab. So we would, and we do routinely offer a few cycles of chemotherapy to see if we can get a good response to get them to surgery.
She passed the boards. We gave 4 cycles of platinum pemetrexed, also called Alimta. The choice of carboplatin versus cisplatin is very nuanced and can cause some anxiety for patients with mesothelioma. Cisplatin is technically what we would call preferred. There's a slight advantage based on some old literature, but there are different toxicity profiles. And if you need to use carboplatin, it's not really a loss. They're both very good drugs. That decision is individualized to the patient. For her, she had hearing difficulty, and giving her cisplatin could have caused more deafness, so we decided to use carboplatin. So we did interval imaging, and we thought there was a nice response, actually. There were some questionable issues in the chest, but we were hoping it was inflammatory. Unfortunately, when she went to the operating room, despite best attempts, there's a lot of fibrosis, so a lot of almost scarring, it looked like. Dr. Nash dutifully took biopsies, and we looked at it, and unfortunately, it wasn't just scar. It was a viable disease that had kind of adhered and matted her bowel together, making surgery not a realistic option. So she came back to me with this very unique situation of, on imaging, she wasn't progressing. In fact, she felt better. She had better quality of life. But surgically, she's now high risk for a bowel obstruction and pathologically had viable disease. So then I'm stuck in the situation of what do? I've just given her the 4 doses. We usually don't extend it beyond 4 initially, for the most part. So we decided to go to the other part of our armamentarium, and we tried Ipi-Nivo, dual immune therapy, saying she got some response to chemo, but it wasn't enough. Let's try another approach. So we gave her the immune therapy, and unfortunately, she felt much worse on treatment, and I got an early look scan, and there was actually pretty rapid disease growth in the chest. So I'll broach this a little bit, but it's a whole different conversation we probably don't have time for about, with immune therapy, sometimes you can see disease get bigger, and the question becomes, is it a flare or a pseudo-progression, meaning it's getting bigger before it gets smaller, or is it real progression? The unfortunate truth is we see a lot more real progression than fake progression. And the only way to know that is time, but clinically. Like when I saw her, she felt worse, her scan looked worse. That's clinical progression, regardless of what the scan showed. So I knew we had to stop the Ipi-Nivo. In the meantime, we always explore clinical trials, and I had her seen concurrently with our cellular therapeutic service and they consented her for CAR T therapy, a trial we have and many other institutions have different designs of. And so she had cells taken and frozen for potential use in the future. So now I have this person who's progressed on immune therapy, didn't technically progress on the chemo, and now she's feeling worse. So what did I do? I had the choice of either a gemcitabine-based regimen. At this point, the cells weren't ready. They take a few months to manufacture, so I couldn't use the CAR T. So I gave her the chemo I gave her the first time around because it had been several months. She had benefit from it. And I gave her 4 more doses, so a total of 8. And again, this is a very nuanced consideration. Her kidneys were fine. She tolerated the first 4 fine. Not everybody will give or can tolerate this many doses. And she had a beautiful response. Since I knew surgery wasn't an option, as Dr. Nash was just discussing, I gave her the Avastin because at that point, we were kicking for the goal here because we didn't have many other choices in backup. And I'm happy to say, we got her 18 months on Avastin with no symptoms. And I only recently stopped her because she came in with hip pain after traveling to Italy, and she had a complication of the Avastin, which is avascular necrosis because it affects the way the blood vessels form everywhere, including the bone. So I stopped it, and I'm managing her, and I see her Tuesday because we're actually going to have this very nuanced but good conversation of her cells that we harvested 2 years ago are going to expire because we thought she would need them sooner. And so the question now becomes, does she want to explore this trial now or let the cells expire because she's doing wonderfully? And so I think this is kind of exemplifies the importance of all the kind of treatment modifications we've had, the new developments in disease treatments we have, the interdisciplinary discussions, and a person who's had, knock on wood, a very good outcome from when I met her. So, questions on that? Comments from the group?
Man, I was really hoping that story had a good ending, so thank you.
So far, so good.
I have just sort of a general question, if it's okay to do that at this point. First, I just want to thank everyone on the panel for even caring about peritoneal mesothelioma. It's so rare, and the fact that you all are dedicated to finding treatments for it really means a lot to us out in the world. So my question is, what do you wish, like general medical practitioners knew about peritoneal mesothelioma when it's a possible diagnosis for someone? Considering that it is rare, not a lot of doctors see it, they don't know what to look for. So just what do you wish people knew?
Well, the easy answer is go to a specialist, send them to a specialist, right? Because there's no way a person in primary care could really understand how to manage this condition, as probably everyone in this room is aware. They get overwhelmed, right? So I think the key is, reaching out to an organization like MARF or to, a cancer center where they have a track record of treating the disease, and then, be there to support the patient. One of the problems sometimes we have, because patients come from a distance for care, because just that's the nature, it's a big country, and there's many centers who treat this, but not that many. So we need the primary care to stay involved with the rest of their medical management, because obviously we're very focused on this disease treatment, their cancer care, but they still have high blood pressure and diabetes or whatever else going on. So sometimes we have this complete disengagement of the primary care physicians because they're afraid that they're going to mess something up. But we don't have good primary care physicians at Memorial Sloan Kettering. I mean, we all do our best, but in most of the major cancer centers, they're not focused on that. So I think it's important that the primary physician stays engaged, is there to help the patient in many other aspects of their care and their life, and then stay in communication with the specialist as well. But I think that's, because otherwise there's just far too much they would have to possibly absorb otherwise.
And I could, just 2 points I would say. It's not plural. And so understanding there are similarities, but there are important differences. And the disease management teams are slightly different, obviously. They bring different surgical expertise and medical expertise, and the importance of the proper initial diagnostic workup. That includes genetic testing, proper pathologic assessments, good cross-sectional imaging.
And in the community, no one's ever going to suspect it's peritoneal mesothelioma, right? It's not the most common thing. And so it's never wrong to get a biopsy. And once you get tissue, knowing then when to send to, actually a pathologist. It really needs to be reviewed at a center that has pathologists that have seen this before as well.
And I think just to add to all of that, one thing that I think is very important is to make sure that they're not nihilistic or prognosticating the patient before knowing what it is or sending them to the specialist. And I think that is unfortunately a big part of this disease. When you look at national data, 60% of patients with peritoneal mesothelioma never make it to a specialist. So it's a rare disease, but of the rare, what we're talking about are those patients that made it to see us. But what about all those that never made it to see us? So I think that's the big part where primary care physicians make a big role. And I think this is not ready for prime time, but many of you might have heard this already. The tests like the MCED test, the liquid biopsy test, was just published in Lancet a couple weeks ago as a test, as a liquid biopsy for identifying cancer in a primary care-ish type setting. So there will be an opportunity, hopefully in the next few years, where you can get a blood test on your annual physical, and your primary care might be the one finding these sorts of even rare conditions.
Thank you so much. Thank you. We appreciate it. We have a break right now, so please go ahead and stretch your legs, and we will be back here at 3:10.
Yeah, we haven't even started.
Yeah, no, I looked at it and I saw Dr. Cohen talking, so I was like, we got some time. Did you get heated in there? The doctors that were in here were like, we want to be there for that.
Okay, let's do yours, and then I'll figure out how to do this.
Do you have any information?
Well, do you have your email on that?
No, this is the hotel.
I can do it real quick.
Do you have a question? Do you have an
I know these breaks are feeling shorter and shorter, but that is on purpose. We have a few more sessions today, and I promise you they're extremely interesting, and you will want to be here for them. So we will be starting back from break with radiation oncology for mesothelioma, and then we'll also have a genetics session, which I know many of you are looking forward to. And then we will finish everything off with the legal panel, and finally we will get a summary from the scientific meeting, and I'll tell you what, that meeting is getting heated. And I'm not talking about the temperature of the room, which is actually quite chilly. So I really look forward to hearing the update from the scientific clinicians meeting and what they talked about. So without further ado, I would like to bring up Dr. Keith Sengel from the University of Pennsylvania, and he's also a member of our board of directors. So welcome, Keith.
Thank you very much. Here, my disclosures. So I wanted to start out, it told me to talk about what radiation therapy is like and the sort of nuts and bolts. So I wanted to start out with an accurate depiction of an average day in clinic. As you can see, there's me on the left and delivering radiotherapy. On the right is one of my physicists I work with quite a bit, Michelle Kim, helping to keep me honest as we sort of think about how we apply radiation for this difficult disease. So in radiation therapy, we have control of space and time, which sounds a lot cooler than it really is. Essentially, spatially, what we do is we try to conform the radiation to the target, put more where I want and less where I don't. And temporally, we try to spread the dose out in a way that allows us to more selectively target cancer cells. And this is typically done by fractionation, where you give some amount each day. And obviously outside the scope of this meeting, we're working on some pretty novel and exciting ways to look at dose rate, which I hope to be able to talk about when we have more results in humans. However, as pointed out by Michelle repeatedly to me, they're the laws of physics, they're not suggestions. And so we sort of ended up in this difficult position. Radiation is extremely effective at treating mesothelioma, but even with the best modalities that we have available, I cannot treat the entire pleura, I can't treat the entire peritoneum safely. So thinking about the different modalities that we have, and I guess what I'd like to start with this is there is no best radiation. There's only where a tumor is, what I want to treat, and what the tools that I have available. And different modalities will do well in different scenarios. So here you can see what traditional 3D. So if you think about the radiation field, you can come from a couple different angles, you can shape it from the outside. And so in this case, we're treating a lymph node area or a tumor that's near the center of the chest, and you can create a somewhat conformal dose around that area at the expense, with x-rays, of some normal tissue. So here the red is the highest dose, green is intermediate, and blue is sort of a low dose. If I get really fancy, and you can see here, instead of just shaping a little bit of the field, what if I use this dynamic MLC? And so the idea here is this can actually move to shape the beam while the gantry is turning, and I can get really fancy in the various words for this. We probably have more different acronyms than patients treated at this point, but this is IMRT or VMAT type technology, and essentially I get better conformality, but you see what happens. Now, instead of having this somewhat intermediate and a little bit of low, I get probably a little bit more intermediate and a bunch more low dose. If I want to get really, really accurate to treat small areas, and this has become very commonplace now, I can treat spinal metastases and miss the spinal cord. We can treat lung metastases and miss the other stuff. We can treat a liver met and miss the rest of the liver.
But you can see again, when I sort of show you the actual dose being deposited, all of this conformality comes at the expense of a low-dose wash. And so that's because X-rays have exit dose. So you think to yourself, okay, well, why don't I use a kind of radiation that doesn't have exit dose? And that's essentially what protons do. So when you have protons, you have a cyclotron or synchrotron or cyclosynchrotron or some sort of accelerator. The beam comes out. We control the depth of penetration of this beam by controlling the energy, and then we can use magnets to scan it. And so what does that look like? Thinking about this particular volume being cut up into little bits, we can basically scan each layer with a new kind of energy and create these highly conformal dose distributions that have no exit dose and limited entrance dose. So what does that look like in space? Here's that same patient with 3D. Here's what IMRT might look like. And here's protons. So you can get this very nice dose distribution that can be very conformal. But again, no best form of radiation. Everything has drawbacks. You'll see what happens here. Because I don't know where this is in time and space, I kind of have to overpaint it in case it's moving as the patient's breathing. And that creates this sort of extra horn of radiation that kind of goes off. So under certain circumstances, it's less beneficial. In that patient, say, with the liver metastasis, now you can see I can make a highly conformal dose that actually is very nicely sparing all of that normal tissue. So it's unequivocally going to be better in that case. One of the things that we suffer with in radiation is this great paradox, which is the bigger the area I want to treat, the lower the dose effectively I have to use and the longer it takes to treat. And I think anyone who's had radiation, certainly any of my patients, when I talk about doing 6 to 7 weeks every day, and I usually get a very crestfallen look and every day. And I'm like, well, if you say every day, it sounds better. 7 weeks is a really long time to come in for radiation every single day, even if it's only 10 or 20 minutes. And not only do I have to slow it down a bunch to treat this bigger area, I end up using a potentially less effective dose. If I'm treating a very small area, I can use that same 70 gray. I can partition into 1, 2, 3, 4, 5, treatments that are quick and easy. And that's essentially the teeny-weeny living space that we live in. And you'll notice when I show, say, something like the whole pleura, I'm treating the external part of the pleura. I cannot go in and treat the fissures, and we'll see that in a moment. In terms of other things that we do to control the dose, it turns out patients breathe. A lot of people don't know that, but yeah, it's definitely conducive. So we need to minimize respiratory motion. Things move around a lot. And in fact, a lot of patients are very interested in getting proton radiotherapy. And the simple way that I put it about protons being better or worse, if you were a block of wood, where I would know exactly what you were made of, and I could precisely locate the tumor within that, and it never moved, and I could accurately position it on a daily basis perfectly, protons would always be better. And to the extent that you breathe, things move. When you think about the lungs or the peritoneum, you have gas bubbles, you have the lungs changing, you have the heart beating, and you have all of this motion we deal with. So one of the things we can do is simply apply what one of my patients referred to as a scientific boa constrictor. So we can actually compress the abdomen and reduce respiratory excursion and sort of force the body to breathe more through the ribs. Or we can even use a scuba mask-like device that allows us to have you hold your breath during the radiation. Using all of the technology, we can incorporate biologic information with PET-CT. We use a lot of radioactive sugar type PET-CTs, but there are now a whole variety of novel types of PET that are being developed that may allow us to more accurately target the highest risk areas of tumor that might come back. We can do this in both space and time. We can incorporate MRI, and we can incorporate all of these other modalities. But at the end of the day, we create a dose, or we create a map of where we want the radiation. all of the normal tissues around it, and how you can see here in this sort of movie loop during, not much of a movie loop. All right, so this is moving in space and time. There we go. We can see it like moving a little bit with breathing. All right, so enough physics. What do we do with treatment? So with pleural mesothelioma, again, we treat a number of different types of patients. Primarily, we do a lot of treatment of things like isolated recurrence or isolated areas that are causing pain or compression or problems. So, for example, here's an anterior mediastinal recurrent mass that's growing on top of the heart. Very difficult to deal with surgically. It's growing on systemic therapy, and we're able to very nicely treat this and miss most of the other tissues. Other cases that we do some of, that's a little bit more elegant, is the idea of treating the entire external pleura, but you'll notice again, I can miss the lung with protons and some very fancy technology, but I cannot treat those fissures that go between the lungs, because if you do that, you're going to overdose the lung. What does this look like with protons versus photons? So sometimes protons can be dramatically beneficial, as in this patient, or this particular patient, for those of you aficionados of anatomy, this is a kidney, and you'll notice what's missing on this side. This is a patient who congenitally only has one kidney, had a recurrence of his mesothelioma, and we're able to treat his entire pleura using protons and have 0 dose to the kidney. In the peritoneum, one of the things that we suffer from is that the space is just so much more convoluted. So the peritoneum covers each organ specifically and then covers the whole outside, and that becomes extremely difficult. In the old days, maybe 30 years ago, before chemo and immunotherapy got better and surgical techniques improved, we used to think about treating whole abdomen, and you know, some of you may have heard about this in the past, where we treat the entire abdomen, and we'll actually, with a very large field that's pretty unsophisticated, and will block the dose to the kidneys. This really isn't done anymore. It's just too toxic. So in the peritoneum, most of the time we're spot welding. So for example, this is a patient who'd had multiple surgeries, who had a recurrence in the peritoneum right outside the liver that was invading in the liver, causing pain, and both being the only site of progression. I'm able to treat that while she stays on her immunotherapy. The other sort of, and this kind of brings up this idea that we call the oligometastatic paradigm. So this is, we have this ability to treat these very small areas in a couple of treatments, maybe up to 5 total treatments, so it's not too much of a drag to come in with pretty minimal symptoms. And when you think about cancer, it's a clonal disease, so you can have one area seeded by a tumor cell that's resistant to the current systemic therapy, that's growing, everything else is under control, or one area is growing and causing pain or compression or problems. And this is where we've really started to radiate a lot more patients in oncology now. So we can do these very conformal, either proton or photon-based techniques, and we can treat little deposits. And so one of my patients once called this radiation whack-a-mole. And again, what we can do with this, and this is actually the patient, over the course of about 7 years, he would have isolated recurrences, and each time I was able to treat fields, and he was in the very early days of proton radiotherapy, where my techniques are getting more sophisticated as his recurrences get more widespread, and we're able to actually keep him going for many additional years with 5 courses of radiotherapy, and he had almost no side effects whatsoever from it. So it can be very powerful under select circumstances. And then just to finish, and this is sort of the magical fairy dust of radiation, we know that immunotherapy works, and it can work when nothing else does. As I think you've heard from a lot of people, we're struggling to figure out whom it's the best to use in, what are the biomarkers that will tell us which patients are going to have the best responses. One of the things that has to happen, though, most of the immunotherapies we're dealing with actually just take the brakes off the immune system and help you use a pre-existing immune response to attack that tumor. So most of them don't create a new immune response out of nothing. One of the things that radiation can do is to kill the tumor cells in a way that's very interesting to the immune system. So the idea is you kill the tumor cells with radiation, the immune system comes in to clean up the mess, and in doing so, learns about this tumor a little bit more, and we use immunotherapy then to take the brakes off the immune system, and we can see some very, very dramatic responses. So this is a patient very, very early on when we were just starting to use nivolumab immunotherapy, and you can see here, this is a tumor that was outside the radiation field. She was progressing. I radiated a little area that was causing pain, and we suddenly saw this incredible and persistent response in tumors well outside the radiation field for a drug that had previously not been working. This can be wonderful. One of the biggest difficulties we now struggle with is just it's very hard to make it happen on purpose, and just like a lot of the immunotherapy, we will use it and see what we can get, but again, it gives you sort of a little extra hope sometimes when you get radiotherapy that your systemic therapy is going to start working quite a bit better. And I guess with that, I will stop and ask for questions. And please don't tell my daughter I use this because she's 17, and but it's perfect. Anyway, thank you.
Any questions?
That was all. Just curious about side effects with the radiation.
So everyone gets a little bit of tiredness from radiation. That's sort of a universal side effect no matter where we treat. Bigger area, more tiredness. And then most of the other stuff from a side effect, if you think about it's all local to where we treat, there's acute side effects that might happen during the radiation or for the first few weeks or months afterwards, and those are all inflammatory. So inflammation of the area, so like for example, if we treat near the esophagus, the swallowing tube, you can get sore swallowing. If we treat the lung, you can get a bit of a cough from inflammation in the lung. And then most of that settles down or might be treatable with steroids or those sorts of drugs. And then the long-term side effects that might occur years later are typically scar tissue related, where we have scar tissue developing in the lung that makes it less effective at breathing, or scar tissue developing. And that's one of the reasons why we don't use it in the peritoneum anymore, because A, we can't get a high enough dose to really fully control meso, and B, 15 years later, you're dealing with severe liver or gastrointestinal or kidney complications.
You're right on.
Oh, one more? Oh.
Just have a question. If you have isolated spots and you would like to make a decision between proton radiation and cryoablation, which would you take?
So that's a difficult one. So you can, instead of doing radiation, you can go in with an external probe and either use heat or freezing to kill the tumor. What we have typically done is we prefer radiation where we can, or where it's fits well into the treatment paradigm, and we reserve the cryoablation and heat ablation for patients who've either failed radiation or don't want it. So for example, I have a patient we just saw back in clinic again. She's 8 or 9 years out from surgery with a recurrence in her chest wall, but I'd already radiated her once post-op, and she had breast cancer radiation 25, 30 years ago, and the area is right between those fields. So that was a great case. We referred her to the interventional people to do it. When you got a hammer, everything looks like a nail. I tend to prefer radiation just because it's sort of got a better, longer track record, but for certain locations, cryo can certainly help. Well, thank you very much.
All right, our next presentation is something that a lot of you have asked about, especially recently, and it is genetics. And we have, who goes first? Alexandra Lebenson, and Azam Ghafour from the NCI, both of you. Am I correct? All right, come on up, and I will get your presentations going. Yeah, just thank you so much.
All right, I will get started right away. Thank you so much for having me. I'm a genetic counselor for all of NCI, but I really have the honor of working very closely with Dr. Hassan, Dr. Ghafour, and the A-team, Kathy Maria Tenon. Shout out to you. We've heard a lot about mesothelioma today already, but I just want to emphasize that all cancer is genetic. And I say that because some patients come to me and say, I don't have the genetic kind. All cancer is genetic. When it comes down to it, it's just about our genes and if there's an issue, if there's some kind of misspelling there. So in order to explain this concept a little better, as a genetic counselor, I like to break up big concepts into small pieces. So, you know, our bodies are made up of billions of cells. Every single cell has a nucleus. The nucleus is what contains all of our genetic information. And so that genetic information is called DNA. And I always call DNA our body's instruction manuals. It's there to tell our bodies what to do, how to function, how to grow. And so it's very important that our DNA is written correctly so those instruction manuals can work and our bodies can do what they need to do. Our genes, our DNA is basically divided into little segments called genes, and we have over 23,000 different genes in every single cell, times 2, one from mom and one from dad. And so, like I said, we want those genes to be spelled correctly in order for them to do their job. And so this picture is just a fragment of DNA made up of 4 letters, A's, C's, T's, and G's. And you can see that, you know, if this sentence is supposed to say the gray cat ran down the hall, but we have a small little spelling error that makes it say the gray cat ran down the ball, that's a big enough difference that the message to the body is different, right? And so either that gene doesn't do what it's supposed to, or that gene doesn't get transcribed or read at all, and that's a problem. So all cancer is actually caused by mutations. But are mutations acquired or are they inherited? That's a question that comes up. And so acquired mutations are mutations that occur during a lifetime. All cancer is due to acquired mutations, but people that get sporadic cancers get that cancer because of only acquired mutations that happen during a lifetime. And so we know that environmental factors we're all exposed to, right? Nobody can help it. We all live on planet Earth, and we're all constantly being bombarded by different factors in our environment. When we think about mesothelioma, we think about asbestos exposure as one potential thing. But basically, it's something that happens during our lifetime, and we find acquired mutations in tumors. So somatic testing or tumor testing is going to look for mutations that occur sporadically during a person's life. And it's really something that's performed at the time of your biopsy or at the time of surgery. That's when they take a small slice of the tumor and they do this particular kind of analysis. So really, tumor testing or somatic testing is really used to look directly at that tumor, nothing else, but just at that tumor and see if there are spelling errors there. What are the genes that got messed up along the way? What are the genetic pathways that are relevant and cause that cancer? And so the future of medicine, we hope, is to be able to actually use those tumor test results to say, okay, what are the drugs or treatment options that would best target that genetic pathway? So that's really the reason why tumor testing has become so integrated into people's care. And most cancers that happen actually happen in this way, just sporadically. They happen because of a combination of genetic and environmental factors. So 90 to 95% of cancers are just sporadic cancers. On the other end, there's inherited cancers. So as a genetic counselor, I'm always looking for what are the chances that this cancer could be inherited versus sporadic. I look at factors like early onset disease. I look at, was that person diagnosed with more than one primary cancer? Are there multiple affected generations? And so when I'm asking those questions, I'm interested in germline genetic testing. So inherited mutations or germline mutations are found in every single cell of the body. So we're not focusing on just that tumor anymore, but just every cell of the body. And so germline testing looks for mutations that would have been inherited at birth from a parent. And we perform this testing on blood or saliva because that would be representative of every cell of your body. And when we're looking at germline mutations, it's a little bit different from looking at mutations that occur in a tumor because germline mutations are giving us information not just about that cancer or that tumor. It's telling us about a gene that's not written correctly and therefore could have implications for all different types of cancers. And when I talk about inherited cancers, really I'm talking about a minority of cases. 5 to 10% of all cancers happen in this inherited fashion. So to just hammer this in a little bit, somatic mutations are only found in the tumor, and that means that there's no potential for passing on those mutations to the next generation. Whereas germline mutations are present in every cell of the body, and that includes your reproductive cells, so eggs, sperm, and therefore it makes it possible to pass it to the future generation. This is adapted from a study by Dr. Hassan's group at NCI and University of Chicago. Many years ago, they took a cohort of mesothelioma patients and wanted to see, is there a hereditary component to mesothelioma? Because in the past, it was really attributed to asbestos mainly. But when they performed germline genetic testing on these patients, they found that about 12% actually carried a mutation in an important DNA repair gene. And out of that 12%, most of those mutations were in a gene called BAP1. So we know that if there's a mutation or a spelling change in the BAP1 gene, it can cause a syndrome called BAP1 tumor predisposition syndrome. The reason for that is because BAP1 is a really important gene in our bodies. It's actually what we call a tumor suppressor gene. So that means that its whole job is actually to prevent tumors from forming. It works to suppress tumors our whole life. And so you can imagine that if you have a spelling change in an important tumor suppressor gene, you just don't have as much protection in place as you should. And so we tend to see cancers happening in places where BAP1 is supposed to be working really hard, where it's supposed to be active. So it causes a cancer predisposition syndrome in those specific spots. And like any other hereditary cancer syndrome, we see cancers happening at earlier ages than we would in the general population. And this tends to be about 20 years earlier than we would see normally. So specifically, the cancers that we see in BAP1 tumor predisposition syndrome, malignant mesothelioma, unfortunately, is the highest risk in this syndrome. And, as opposed to the general population where pleural mesothelioma is most common, we've heard today from a couple of speakers about how peritoneal mesothelioma is a lot of times associated with BAP1. So about 50% of BAP1 patients have each of these types. And the lifetime risk within the syndrome, it can be up to about 30%. The next most common cancer in the syndrome is uveal melanoma, so cancer of the eye, because BAP1 tends to be very active in the eye. We think that, according to the literature, it could be up to about a 28% lifetime risk for uveal melanoma. BAP1 is very important in the skin. It's very active there. So cutaneous melanoma is an increased risk, along with other skin cancers like basal cell carcinomas and squamous cell carcinomas. Renal cell cancer or kidney cancer is another risk with BAP1 tumor predisposition syndrome because BAP1 is also very active in the kidney. We think it's about a 7 to 9% increased risk. And meningiomas, or tumors of the central nervous system, the brain and the spinal cord, can be seen at a higher percentage in BAP1. There are other cancers that we're seeing an elevated risk for, including cholangiocarcinoma, bladder cancer, and breast cancer. There are even benign findings that we see in BAP1 tumor predisposition syndrome. The name for this has changed about 5 times over the years, but the most current name is BAP1 inactivated melanocytic tumors. And these are just dome-shaped raised papules that are flesh-colored, don't really cause sensitivity to touch or temperature. And these are things that have been found to be present in most BAP1 carriers. So this study done in 2017 found that 75% of BAP1 germline carriers who underwent a total body exam had at least one of these BIMTs found on their exam. So it is highly predictive of BAP1's carrier status. And in this study of the dermatology patients found to have these BIMTs on clinical exam, about 51% were found to carry a germline mutation. So it's actually become a really interesting and great way for dermatologists to pick up carriers in otherwise asymptomatic patients. For the interest of time, I'm just going to fly through that. How is this inherited? It's autosomal dominant. That means that all first-degree relatives have a 50% chance of inheriting it. This chart you've probably seen before, but basically it's showing that dad has his 2 copies of his, let's say, BAP1 gene, and 1 copy is fine, 1 copy has a mutation in it. Mom is the unaffected parent, and she has 2 working copies. So every time they come together to have a child, there's a 50% chance that dad could have passed on that copy of the gene with the mutation, or a 50% chance he could have passed on the copy that was working fine. And so that's why it's a 50% chance at every birth. It's like flipping the coin every time. So if you have 10 siblings, it doesn't mean 5 will have it and 5 won't. It means that 9 could have it and 1 not, or vice versa. It's really flipping the coin every single time. And there is an increased risk for multiple cancers during a lifetime. So I get this question a lot, you know, I was diagnosed with this cancer, does that mean I'm done? Unfortunately, no. Patients with BAP1 mutations do have a higher risk of having multiple cancers because every single cell doesn't have one of their copies working, so they're more susceptible. And different family members within the same family may get different types of BAP1-associated cancers, so that's another question I get often. You know, my family doesn't have renal cell cancer, so does that mean that I'm not at risk for renal cancer? And unfortunately, no. We have to screen all BAP1 carriers in the same way, assuming they're all at risk for all the cancers. I just put this out here to emphasize that there is a technology available for any hereditary cancer syndrome, including BAP1. So pre-implantation genetic diagnosis is a technology that uses IVF in conjunction with genetic testing. IVF, and then at the embryonic level, cells are biopsied and genetic testing is performed, and only the embryos that do not carry the familial mutation will actually go on to be implanted for a potential pregnancy. It can be very, very difficult for patients to learn about a hereditary cancer syndrome. So I could go on and on for hours, and some of my patients out there know that I can talk for hours. But I'm just kind of laying out there and acknowledging that these are so many of the issues that we talk about with our families. It's a relatively rare syndrome with less available resources, which can make it really difficult. Patients need support in coping with anxieties associated with lifelong cancer screening. I heard the word scanxiety out there, and that is a real thing. Guilt associated with passing cancer risk to children, of course, as a parent, you know, that tends to be the most important thing. There's something called survivor's guilt in family members who do not inherit a familial mutation, but they see other family members, suffering from these diseases. there's fear of passing cancer risk to children, leading to changes in family planning, because the truth is reproductive technologies are not really available to everybody. It's not the most accessible thing, unfortunately. There's a huge burden of informing relatives about this. You'd be surprised, how separated some families are and how difficult this can be to talk about. And I've heard it today, and I've heard it a million times. There's a common feeling of responsibility to educate providers who just don't know a lot about BAP1 in local communities. So we're hoping to help with that. So to drill down some points and pass it to Dr. Gafour, when to seek germline genetic testing. I really do recommend all mesothelioma patients to consider genetic testing. I think you've heard several times today, and I've showed you that a significant portion are associated with important DNA repair genes, and so it can have important clinical implications and can affect your management. BAP1 mutations are most likely to be found in patients who develop early onset mesothelioma and or have more than one BAP1 associated tumor. And the highest risk is in mesothelioma patients with a family history of meso or uveal melanoma or kidney cancer. And how can it make a difference? There are huge benefits to doing genetic testing. As Dr. Gafour will talk about, it may allow providers to consider a specific treatment or management plan. It can provide important prognostic information. It can alert patients to a higher risk for other cancers and allow for proactive screening. Proactive screening then leads to early detection when treatments are most effective. And then it can really allow family members the chance to undergo genetic testing themselves to understand if they are also at risk and need extra screening. And finally, allow family members to use reproductive technologies if they're available to them to prevent transmission. Thank you.
Okay, sure.
And let's get out of here. And then here we go. Just takes a moment. There we go.
Thank you.
And so you just use the.
Okay. Hi, good afternoon. I'm just going to give you a disclosure. I have a little bit of cough, so bear with me. My name is Azam Gafour. I'm an assistant research physician at the National Cancer Institute in Bethesda. And I'll extend Alex's talk talking about the treatment strategies and surveillance guidelines for patients with inherited and acquired genetic mutations in mesothelioma. So as we know, acquired, as Alex had mentioned, acquired mutations that are found in the tumor of mesothelioma, the genomic landscape has been defined in many studies. And what we are finding is that the genomic landscape is defined in mutations in what Alex was mentioning, tumor suppressor genes. And this actually leads to the loss of the gene and the protein. And there was one study in 2022 which looked at about over 1,000 tumor samples in patients with mesothelioma, and they found about 19 or so genetic mutations in these genes. As you see here in the pie graph on the left, BAP1, NF2, CDKN2A, and CDKN2B were the more common ones. And going further, we looked at some of the data at the NCI with Dr. Hassan and his group, and we actually broke it down between pleural and peritoneal disease. And when we sequenced about a few hundred patients, we found also similar picture that BAP1, TP53, NF2 to be significantly mutated. And that's here on the right-hand side. And this confirmed prior studies in 2016. You see on the left side, of BAP1. The circles are representing, the size of the circle is representing the frequency of the mutations. And you see here on the left, BAP1 with the largest circle being the most significantly mutated gene in the tumor, followed by NF2 and TP53. And these are all tumor suppressor genes. So why do I mention this? Well, they do carry some prognostic and treatment decisions. And first of all, the bottom line is that as of right now, there is no actionable mutations for somatic mutations. These are mutations that are found in the tumor of mesothelioma. However, there are some exceptions. We know prognostically, BAP1 in the tumor, loss of BAP1 in the tumor, also called a somatic mutation, may have longer survival when compared to patients that have an unmutated BAP1. And they may respond favorably to chemotherapy. This was described in a retrospective study that we wrote an editorial, and you can see the citation there. TP53, which is another commonly mutated gene in mesothelioma, unfortunately is non-targetable. This is known as the guardian of the genome. It's a very important gene in maintaining tumor suppression. As of right now, there's no treatment for this type of mutation. Going on to NF2. NF2, some of you might know that it's associated with other tumors like neurofibromatosis. That's where it gets its name. In mesothelioma, it has been correlated with a shorter overall survival. Unfortunately, there's no approved therapy to target this mutation. However, there is an ongoing clinical trial. As you see here, there's a phase 1 study which is evaluating this drug called VT3989. And this is a trial open for all solid tumors, but it does include mesothelioma. This year, they had some preliminary results showing about a 10% response rate with this drug. And finally, I include ALK. ALK is another important gene. It is not as frequently mutated than the BAP1 and TP53, but we know that in a subset of peritoneal mesothelioma patients, they may have a genomic alteration called a rearrangement. And why that is important is actually we do have a drug that targets this type of alteration, and we adopt it from the lung cancer world. So in our clinic, if someone is young and they have peritoneal mesothelioma, we routinely check for ALK translocation because of its predictive implications. So switching on to germline or hereditary mutations in mesothelioma. These are genes that you, as Alex was mentioning, that you've inherited one copy from one of your parents. And we know that from the NCI cohort and the University of Chicago, about 12% of patients with mesothelioma can harbor a germline mutation in a DNA repair enzyme. These are very important genes that involve in repairing your DNA in all your cells. What we found was that BAP1 was very commonly mutated in our cohort. So what does that mean prognostically and treatment-wise? If you look on the left-hand side, you see this is showing that the overall survival of patients with BAP1 compared to patients without BAP1. So there was, if you look at the left-hand side, the yellow checked line are patients with BAP1 mutated mesothelioma, and you see a nice clear separation in terms of survival when compared to a cohort of patients from the SEER database. So as you see here, patients, what we typically know who with mesothelioma, they may have survival 2 to 3 years, but with BAP1, they can survive more than 5 years, even up to 10 years. So clearly, they have a better overall survival than BAP1 wild type or non-mutated. On the right side, we looked at BAP1 patients who were treated with chemotherapy, and this is from Dr. Hassan's work. And we found that patients, when we looked at the survival that's plotted on the x-axis, this is on the right-hand side here, we found that patients with a germline mutation in one of the DNA repair enzymes actually have a better survival when compared to no mutation. And these are patients who were treated with chemotherapy. So what this is summarizing, what this is showing is that BAP1 patients in their germline that have this mutation not only live longer on average, but also when they're treated with chemotherapy, they have a better survival. So given all that data I presented, how should BAP1 patients be managed medically? So we always counsel patients on the improved overall survival. I think that's very important. Why that is important is because not all patients require intervention. We may adopt a wait and watch approach by scans every 6 to 12 months. And we always involve our surgeons, our thoracic and our abdominal peritoneal surgeons, because tumors may arise in different compartments in the body. You may have developed tumors in one chest or both chests, or tricompartmental, which may include both chests and the abdomen. And rather than these being metastases, these are actually different primary tumors and different originating tumors. So they may be dealt with surgery or local therapy rather than systemic therapy. However, there are some scenarios where we may favor chemotherapy, and that's mostly individualized. And lastly, the significance of BAP1 is that we like to enroll our BAP1 patients on surveillance programs. And that is because, as Alex has mentioned, they are at risk of developing numerous other cancers, and also their family members are also at risk for developing cancers as well. So I'll sort of shift gears and talk about our screening trial at the NCI for BAP1 patients. This is a natural history and cancer screening protocol for mesothelioma patients and family members with a BAP1 gene. And you can see the clinicaltrials.gov identifier there. So BAP1 syndrome, we know loss of BAP1 has been studied internationally in families. There is a higher likelihood of different cancers. As Alex had mentioned, mesothelioma, you have your skin melanomas, ocular melanomas, and other solid tumors, including breast, renal, and others. We know that tumors, BAP1 with this syndrome is an autosomal dominant syndrome. So as Alex had mentioned, you have a 50% risk of developing the syndrome. And it does affect every generation. And we know that rates of mesotheliomas increase in this population with an earlier onset of presentation. So since BAP1 patients are at risk for multiple malignancies, there was an unmet need to screen these patients and their immediate family members. So we developed this protocol at the NCI it's a surveillance protocol. And hopefully our goal is to determine the frequency and incidence of malignancies, and also develop treatment plans for early intervention. The primary objective was to look at the natural history of patients and family members, and also define the risk of developing mesothelioma and define screening guidelines. We essentially have two cohorts of patients who are eligible. We have patients with mesothelioma and harbor a germline mutation in BAP1 or another DNA repair enzyme. Again, these are germline mutations. And then cohort 2 involves first or second degree relatives of patients from cohort 1 who have germline mutation. And all patients are seen by Alex, our genetic counselor. And this is the study schema for the long-term follow-up. Eligible patients who have a history of mesothelioma and a pathologic germline mutation, or they have a first or second degree relative from cohort 1. They are evaluated by Alex, and they're offered saliva or blood testing to test for an hereditary cancer, genetic mutation. And then at baseline, they're offered different consultations. We do an ophthalmology consultation to look for ocular melanomas. We have our patients see the dermatologist so they can do a thorough skin exam, and what we're looking for are melanomas of the skin and other non-melanoma skin cancers. As Alex had mentioned, there are at risk for basal cell carcinomas, and also these benign skin tumors, what we call BIMTs. And then we do imaging. We establish a baseline MRI brain, chest, abdomen, pelvis. The reason we do the brain is that we're looking for meningiomas. Typically, meningiomas are a slow-growing tumor in the general population, but we know for BAP1 patients, they can be aggressive and they can be more malignant. And then with a chest, abdomen, pelvis, we're looking for the other tumors, including mesothelioma of the pleura, and also in the abdomen and renal cell carcinoma. Then we also offer MRIs of the breast and mammographies if you're age over 40 to look for breast cancer. And we do the skin and eye exams on an annual basis and the imaging every 2 years. More recently, we implemented cystoscopies because we are seeing that about a 10% risk of bladder cancer in our patient population. So we have screening cystoscopies as well to look for bladder cancer. So this is a little bit old slide. As of right now, we have about 144 patients that have enrolled. And this is, obviously this is old as well, but we've determined patients, we've seen patients with mesothelioma and renal cell carcinoma and other solid tumors. The more common are non-melanomatous skin cancers, including basal cell carcinomas, squamous cell carcinomas, and also benign lesions called bapomas or BIMTs. So this slide I really want to focus on because you know, a lot of patients ask us, well, you know, are we at risk for developing multiple cancers? And what is the risk over their lifetime? So we are seeing there is an increased risk of multiple cancers. We don't know the exact frequency, but we have seen some patients develop either 2 to up to 6 different primary cancers. And I illustrate here one such example. This is a patient who ended up developing 6 different cancers in the course of their lifetime. They initially had melanoma, which was treated with surgery. In 2014, they developed this pleural nodule, if you see here on the right-hand side in this CT scan. You see this nodule near the front of the chest. This turned out to be pleural mesothelioma, and they were treated with chemotherapy and surgery. And they've been pretty stable on immunotherapy. In 2017, they had this nodule here that was bright on the PET scan, and this turned out actually to be breast cancer. And so this was a third type of cancer they developed, and this did require surgery and more chemotherapy that was directed to the breast cancer. More recently, they've developed recurrent bladder cancers. Typically, these are superficial. They're not the invasive type that invade into the muscle, which are more aggressive, but they can reoccur. And so they do require frequent surveillance, cystoscopies, even treatments in the bladder, including chemotherapy or immunotherapy. So in conclusion, this protocol that we've developed, it's one of the first prospective imaging and clinical screening studies for BAP1 patients. We know BAP1 patients are at risk for several co-occurring malignancies. We know that the management of BAP1 really involves a multidisciplinary team. As I said, we involve our surgeons and our pathologists, genetic counseling. We do offer cascade testing for patients and their family members who are at risk. And it does involve a long-term follow-up. The goal of this study eventually is to define the lifetime risk of developing these cancers in the setting of BAP1 and eventually develop standard surveillance protocols and treatment guidelines. I would like to acknowledge our patients and family members. You've been a great asset. Our team at the Thoracic and GI Malignancies Branch, Dr. Rafid Hassan is the PI, Maria Agra, Kathy Wagner, Tedin Maglo, our nurse practitioner, Alex, our genetic counselor, and also our thoracic surgery branch at the NCI. Thank you very much.
I don't see any questions, so thank you very much. You guys, yeah, feel free to come up. I will set up your presentation. So, Joe, you sent me a PDF, which is fine. I have it up, so you can still,
Okay.
you know, back and
Great.
forth.
Where do I hit to advance it?
The
Great.
arrow forward, the arrow back.
Beautiful.
So All right, excellent. And I have some questions as well before we run out. I'll introduce you. Okay. If you're okay.
Yeah, sure. Yeah.
All right, our next session is our legal panel, and I know that many of you have questions about the legal aspects of mesothelioma, which is completely understandable. So we have brought together a panel, and we have Joe Bellick over here and Don Besserman. And the panel will be moderated by Cheryl Bruner, who is our organization's board member. And she's also an attorney, but she will introduce herself, and she will be moderating the panel. Thank you.
Thank you, Maya. A little bit about me. My mother was diagnosed with mesothelioma in 2014, and we found the foundation immediately, and it was really a godsend to our entire family, and continues to be. We've got a family connection to this as well. I joined the board a few years ago, and that too has been such a blessing to me to be part of this. And I am an attorney. I live in Louisville, Kentucky. I do not practice in the mesothelioma space. I do estate planning and elder law and other kinds of things. But with my mom's diagnosis, our family did have a lawsuit at the time. So I've been through that process as well. So I'm honored to have these two quite capable mesothelioma lawyers up here with us. And so we're going to start with Joe Bellick, and he's got some slides that he'll go through, and then we'll just facilitate some questions and answers and go for about 40 minutes or so. So Joe, over to you. Thank you.
Great. Thank you so much. Good afternoon, everyone. I appreciate you staying here towards the end of this. We know, because we've been doing this work for 25 years, that this is a long day for a lot of you, so we very much appreciate it. I've been here since the morning, and I don't think you could get better medical information and up-to-date information than you got today. I've been doing this work for 25 years, and I learned a lot just listening to the amazing doctors and researchers who are trying to help. And we also know as attorneys that your primary goal is to get good treatment, to extend your lives as long as possible. We try to help you do that, but we're very cognizant that the legal part of this is often a secondary concern or something that you feel is necessary to pursue to get the funds to protect your families and help pay for treatment. I do want to say one thing about BAP1. It's not a cause of mesothelioma. Asbestos is the cause of mesothelioma. This is a battle that we fight in the courtrooms around the country every day right now. So I just want to be clear about that. My law firm actually paid for some of the initial BAP1 research that was done at NYU with Harvey Pass and some other folks, and we did that work to try to find biomarkers for mesothelioma, not to interfere with the work that we do as lawyers. So the NCI is doing incredible work on this, but just to be clear, BAP1's not the cause of mesothelioma. We know what the cause is, and the only cause is asbestos exposure. So I also, just before I begin, wanted to give a shout out to all the law firms that are supporting this conference. We are competitors, but we're also colleagues. We share a lot of information. We work together when we can to take on these big corporations. So Monty Reichel and Gori Julian and the Early Law Firm have also contributed to support this work, and they deserve credit as well. And like I said, we're a close-knit community, and we share a lot of information. Even though we are competitors, we do work together when necessary to help you and your families. So I just wanted to briefly go through some of the legal options for people who have mesothelioma. I'm going to do that sort of quickly because we want to allow some time for questions. But there are a number of compensation legal options for people who have mesothelioma. And the law firms that represent people like mesothelioma, like Dawn's firm and my firm, we help with all of these things. We're sort of one-stop shopping. So the first one is mesothelioma trust funds. There's a lot of confusion about this. A lot of our clients think there's a big trust fund that the government has set up to compensate people for mesothelioma. That's not true, okay? In some ways, it's the fault of lawyers, advertising, to give you that impression. In some ways, it's the media also. But the reality is that there are lots of companies that made asbestos products. A number of them, about 50, have filed for bankruptcy. And when they file for bankruptcy, they set up an individual trust fund for that company. So a company like Johns Manville or Owens Corning has an individual trust fund for that company. And if you were exposed to that product and can show that you have mesothelioma or lung cancer, you can file a claim with that trust fund, and they will pay you what we call a scheduled amount, okay? It's like a matrix. They plug in some information about you, they spit out an amount, and as your lawyer, we help you do that, okay? So those are the trust funds. In reality, it's a small part of the compensation you receive. It's a little bit easier because it's not filing a lawsuit, but it's the values that these trust funds pay are lower than what you typically get in a lawsuit. So one thing that we do for you is file these trust fund claims. One of the main things we do for you is file a lawsuit on your behalf in the court where we think you'll get the best result. That could be the state that you were exposed, the state where the shipyard was that you worked at or served in. It could be where you live. Every state has different laws, and one of the things that we do as lawyers is figure out what's the best place to file a case for you. That could be New York or California or Illinois, but we take a work history, we take a life history. What did your parents do? What did you do? Where did you go to school? Do you have hobbies? We're trying to figure out any way you might have been exposed to asbestos, and then we come up with a strategy of where to file the case. And again, every state is different. Some states are faster, some states have better law, some states the juries award more money. So those are some of the factors that we're looking at. So individual lawsuits, that's another path that we pursue for you. Workers' compensation. That involves a claim against your employer. In some states, you can sue your employer, like Pennsylvania, but in many states, you can't. You have to use the workers' compensation system. Your employer purchased insurance, and there's an availability of a workers' compensation claim that we file against your employer to collect money from their workers' compensation insurance carrier. So that's another component of this. And again, that depends on what state you live in and where the case is filed. Veterans benefits. If you served in the military and were exposed to asbestos and you have mesothelioma, there's a disability benefit available. It's a service connection disability that you can get from the Veterans Administration. It's not the best process. It's slow. They do not handle the claims the way they should. If you follow any media, you know what goes on with the VA with respect to veterans' health care and veterans' disability. But it is a decent benefit. It's a monthly benefit. There's a portion of it that can be retroactive and a portion that can be available for your family. And there are also VA hospitals that can provide medical treatment. Again, they may not be the best place to go for medical treatment, but they can be a resource for certain things like prescriptions and testing and some other things. And some of them provide very good care. So if you're a veteran, there are these benefits available. Our law firms help with those veterans' claims. Social Security disability. If you're working and you get mesothelioma, you can file for Social Security disability. It also qualifies you for Medicare, even if you're under the age for Medicare. So that's another thing that your lawyer can help you with, is filing a Social Security disability claim in the right circumstances to enhance your Social Security benefit or get a Social Security benefit, and also potentially qualify you for Medicare. Disability insurance. If you're working, your employer may have a disability policy, or you may have purchased one on your own. This is another benefit that your lawyer can help navigate through. It may provide some additional compensation for you. And lastly, health insurance. It's a very important part of benefits that are available to you, whether it's Medicare based on age, Medicaid based on income, a private policy, a supplemental policy. It's a very important thing to talk to your lawyer about, because these programs will provide the first level of payment for your health care, but they're also going to want to get paid back through a lien, and your lawyer needs to be involved from the beginning to help minimize what the payback is and negotiate the best reimbursement for them. So all of our offices, all the firms involved with this, we have dedicated people that all they do is deal with these medical liens and try to negotiate the lowest payback, so the money we recover for you goes to you and not just to these medical insurance programs, whether they be government or private. I just wanted to briefly sort of go through what we do, and again, it's similar for most law firms that do this. When you contact our firm or these other firms, we get back to you very quickly, usually the same day. And we either over the phone, by Zoom, or in person, depending on your preference, take down information about you, okay? Biographical information, your name, address, date of birth, where you were born, what your parents did for a living, where did you go to school, what did you do for a living, what did your spouse or partner do for a living, what did your kids do for a living, do you have any hobbies, did you do any work outside of work, like work on your own automobiles or do work in your house. We are trying to figure out any possible connection to asbestos that you've had for two reasons. One, it helps us get the best result for you, but also in these cases, the way that these big asbestos companies defend themselves is to try to find some other way that you were exposed to blame, okay? So anybody who's a parent and has kids, they understand this. It wasn't me. That's what they do in these cases. So the best way that we can help you is to be thorough in understanding all of the exposures that you've had. If you agree to move forward, we have you sign a retainer agreement. All of the firms involved here, depending on the state, work on a contingency fee. That means you don't pay us anything unless we recover money for you. And if we recover money for you, we take a percentage of what we recover. That's the basic contract. There's no financial risk to you to hire us, because if we don't recover money for you, you never have to write us a check. All of us, as you're moving through this, do a lot of preparation in investigating the claim, preparing you to testify, meeting with you. We are very skilled at this type of work. We know a lot of the job sites or trades that you worked in. We know who made the products that you worked with. And we, depending on where you worked and what you did, prepare the case for you and also prepare you to testify in these cases. We then file what's called a complaint against the companies that were responsible for exposing you to asbestos. Again, we know that. Many of these areas of work, there weren't 20 companies that made the products. There were 5 or 6, and we know who those are, and we know what areas of the country they sold the product, what years it contained asbestos, what it looked like, how you would use it. And we help prepare you to be a participant in the case by talking you through that. The companies we sue have an opportunity to answer. That's basically them filing a court document saying we've gotten the complaint and we're engaged. And then we get into what lawyers call discovery, which is exchanging information about you, and most importantly, having you testify at a deposition. This is the most critical part of the case because everything that we do is based on this deposition. It's based on the testimony. If you're not able to testify, we try to use family members or coworkers to supplement the testimony and build the case. But this is the most critical part, and if you're working with a law firm, this is the part that you need to demand they give you full attention to, because this is the part that is the basis for everything, okay? My firm, I think the other firms do this, we go to your home, we meet with you, we prepare you, we go over the questions, we talk about, you know, what the law is and what type of work you did, and we're with you during the deposition physically, we're next to you, and help getting you through. And it's not an easy process because you all know better than we do. You're undergoing treatment. There are good days and bad days. It's a tiring process. You're talking. You're already short of breath in many instances. And part of the specialty we have is getting you through this process. It's a skill that we've all developed, managing the time and managing the process to get the testimony done. So with that...
Testing 1, 2, check 1, check 2.
Good time to stop. Thank you all very much. I'm going to sit down and we'll go from there.
All right, thank you, Joe. Okay, so now is the time for questions. I have some questions that I'm going to ask, and I'm already seeing hands go up, so that's good too. Maya, are you going to help? Okay. So as Maya walks back there, I'm going to throw a question, Dawn, out to you as we get started. Can you talk about why it's important to contact a lawyer very quickly after a diagnosis?
Sure, Cheryl, thank you. I'm Dawn Besserman again. My firm is Monty Rakel Hartley.
Hold it closer. It might be, but hold it closer to your mouth, maybe.
Is this better?
Yes.
Okay, great. Again, my name is Dawn Besserman. I'm from the firm Monty Rakel Hartley French and Mudd. Cheryl's question is an important question and something that every person and family member of a person diagnosed with mesothelioma needs to keep in mind. Of course, when you're first diagnosed, it is absolutely devastating news, and the most important thing that you should be thinking about and taking care of is your medical care and treatment. But the legal side of your situation is very important, and each state has different laws, including the trust funds that Joe just talked about. There are limitations on the amount of time that you have in every state and with every trust to file a claim. And some of those limitations can be very, very short, a year or even potentially less. So it's very important that you don't delay too long. I know that it can be extremely overwhelming, but I will tell you, the worst thing that happens when we first talk with someone who calls our office is to hear, I was diagnosed 5 years ago, or my mom passed away 5 years ago. And most of the time, in almost every situation, that's going to be way past the limitations period, and there isn't going to be any legal recovery, any financial compensation that your lawyer will be able to get for you. So it is really important. While there are things medically that you need to take care of first and foremost, you can't forget or continue to push aside the legal because you are overwhelmed. So I really do urge every person that is diagnosed with the disease and their family to contact an attorney and find out what their rights are and what those limitations are in their case so that they can govern their conduct accordingly. You don't want to let that time period just slip by and be barred from pursuing any recovery.
Yeah.
And
They're tricky.
Yeah, I would even go a step further because many times when we're contacted, this literally just happened to me, the client said, I want to get my medical treatment squared away before I hire you. And first of all, whether you're filing a lawsuit or filing a trust claim, you're going to be in line behind the people that file before you. So no good comes from waiting, because if you wait 2, 3, 4 months to file, you're going to be 3, 4 months down the road. And these companies do go bankrupt. The funds do become more limited. The insurance policies become more limited. And also, we need you to participate. We need you to testify. We need you to help us understand what you did. And as you go through the treatment process, anybody in this room who's been through chemotherapy or immunotherapy or surgery, understands that sometimes can limit your ability to participate because you're tired, you're sick, you're not up to it. So getting this out of the way early and letting us get the process started is only going to benefit you in terms of getting compensation.
All right, thank you, Joe. So, question.
Hi, thank you. My name's Laura, and a couple questions. What percentage of your cases actually go to court?
That's a good question. A very, very small percentage actually go to trial.
Yeah.
And when I say very small, we're talking single-digit percentages. The vast majority of these cases do settle out of court, and for good reason, and that's because the conduct of these companies that made the products that exposed people to asbestos is egregious, and those companies at the end of the day know that they don't want a jury to be deciding their fate.
Uh-huh.
And just one sort of add-on to that when you're picking a law firm. You want to pick a law firm that, even though the case is likely to settle, is willing to go to trial. Because I have some news for you. This may be shocking. The companies that made asbestos products are not paying you settlements because they feel bad about what happened. They're paying settlements because they're afraid about being in the courtroom.
Yeah.
So they know which firms are willing to go to trial, and they know which firms are not. And the values differ dramatically. And just like you heard from the doctors, get to a mesothelioma center, get to a mesothelioma lawyer like Dawn or myself or these other firms, because we're going to give you the representation that's going to get you the best result.
All right. And then my other question, thank you. My other question is, does the family members have any grounds to sue if they're not the patient?
Yes, they do.
And how does that work?
Okay, so let me just explain. There are probably at least two different subsets of family members that do have rights under the law. The first is the spouse. The law, and I believe every state recognizes that if you're married to someone and that person is injured, you suffer an injury as well. During the course of their treatment, you suffer what's called a loss of consortium, and the law allows the injured party's spouse to also recover damages for their suffering and the damage that the disease has done to the marriage, and financially, if for instance you have to take off work to help care for your husband, or you have to bring in other people to perform services around the house. Those are all kinds of damages that are taken into account that those companies are responsible for. If the injured person passes away, then the family also has a right to recover under states' wrongful death statutes. And each state has a different statute and a set of guidelines as to who has the right to recover. Obviously, if there are minor children involved, those children almost always have a right to recover damages. The spouse has a right to recover damages. Sometimes adult children, even though they're not financially dependent, also have a right to recover damages.
Or they are. What if an adult child that is financially dependent?
Is financially dependent? Absolutely.
Yeah.
They have, generally, I think every state recognizes that a financially dependent adult child also has a right of recovery for loss of a parent upon which they were dependent.
Okay, thank you very much.
And let me just say one thing about your question, which is an excellent question. And it's a hard subject to talk about, but having a clear will, having a clear estate plan is one of the best things you can do, because in many states, when someone passes away, the person who controls the legal process is the executor of the estate. And the people that benefit are the beneficiaries in the will. So, for example, if you're living with somebody who you're not married to, in many states, that person may not have any rights to do anything. It's the heirs, the kids, or something like that. So, and among your children, you may have one child who you want to be responsible for interacting with us. So, having a very clear will, we have an estate expert here, is a really good thing to do, even though it sometimes can be uncomfortable to talk about.
Mm-hmm. Yeah, good points. Okay, question here? No. Yeah. Do you remember what you were going to ask? No? Oh, okay. All right. So let's see. When you're choosing an attorney, we've already talked about making sure that you go with a firm that's experienced, like our centers of excellence with our doctors. But what are some of the other factors that you all think are important if people are interviewing, contacting law firms, and trying to decide which one is the best for them?
Sure, you should always do your research before you even meet with a firm. Research as much as you can about that firm and be prepared when you sit down and meet with the representative from that law firm. You have a list of questions and that they're able to answer your questions. The questions that I recommend asking every person that you interview include things like experience, ability or desire to go to trial, and ask them what their trial experience is. Some firms are advertising for cases, and they are really settlement mills, and they are never going to actually take a case all the way through to a jury. And the reality is that the defendants know that, and those types of firms probably aren't getting the same settlement values that firms that are committed to seeing a case through trial will get for a client. It's important to ask who's actually going to be working on your case. Is the person who came to meet with you the person that's going to be handling your case? How is your case going to be handled once that person leaves your living room? Are you going to be assigned to an entire team, and what does that team look like? What is the process for handling your case once that person walks out the door with a signed retainer agreement? Those are important questions. You want to know if the people that you're speaking with are actually going to represent you or whether they're going to refer your case to another firm. Because obviously you want control over who's going to be working on your case, and the worst thing that can happen is you sign with a law firm and then later find out that they're referring your case to another firm for handling. You want to know the experience of the folks that are going to be working on your case. Another thing that is important to find out is how much of their time do they spend working on mesothelioma cases versus other types of law. At my firm, we only handle mesothelioma cases, so we are 100% dedicated to that particular type of law. There are other firms that spread out their practice, and there are attorneys that spread out their individual practice. So you want to know how experienced and how specialized are the attorneys that are actually going to be working on your case. There are a million good questions that you can ask, but you really need to do your homework. And at the end of the day, you need to make sure that you're comfortable with your legal team. If there's something that feels off, if you feel like you don't quite trust them, there's probably a good reason for that. And you should continue talking to people until you find the right fit for you and your family. And I would also suggest that you look at, you ask them what they're thinking in terms of where your case likely could be filed. Do they have attorneys that are licensed there? Do they have an office there? Are they familiar with that judge and court system? Those are all important questions as well. I'm sure Joe can think of.
Yep, good. Okay, do you remember your question now?
So in regards to the statute of limitations, if a company becomes identified that they had asbestos exposure after you've already settled, your other suits. How does that work? I mean, for long-term survivors or family members, how does that work? So if a company just gets put in the media that they have potentially exposed a lot of people, and you had, used that product, and it's been 5 years since your diagnosis, are you still eligible for that, or is it case by case?
It's probably, that's a really broad question, and it is somewhat case specific. If the statute of limitations has passed, probably you're not going to be able to pursue a claim against that product manufacturer. There are exceptions. For instance, if a company would later file for bankruptcy and a trust is created, oftentimes we're able to go back and examine exposures that a client may have had at a particular site that later becomes approved for payment under a trust. So that's a very good question, but there's not an easy black and white answer to it.
Yeah, this is a question that's coming up a lot, in part because of the TELC claims, which were not pursued a lot 5 years ago, 4 years ago, but now are a big part of what we do, both cosmetic TELC and baby powder. And we are trying some creative strategies in trying to deal with that. And we're working on a case right now where we literally filed the case one day before the statute expired. So I would encourage people to reach out to an attorney and let them evaluate the situation if they feel like may have missed the time frame or something, because we'll try. We'll try whatever solution we can. We can't give any guarantees, but we do try.
Yep.
So it depends on the state. New York is 3 years, the state of Maine is 6 years. It's a state-by-state thing, and that does also impact where we might choose to file it.
The state where you live or the state where the exposure?
It could be either. Sometimes we file where you live, sometimes we file where the exposure occurred, and yeah.
Yep. Okay.
I think that you're speaking about primary exposure where somebody was exposed themselves. Can you speak a little bit about the difference to secondary exposure, where you think maybe a family member brought something home that had asbestos?
Sure. I don't know what Dawn's firm's experience is in terms of the percentage, but our firm right now, probably about 20 to 25% are what we call take-home or secondhand cases where either a parent or spouse or partner worked with the asbestos product and brought it home on their clothing. So it's a big part of what we do. Obviously, we need to be able to back that up with experts who talk about it. But, like many things in life, this idea of secondary or take-home exposure is not new. It's not new at all. In fact, the literature about this goes back into the early to mid-1900s. Some of the very first case reports about asbestos disease and mesothelioma came from mines that mined asbestos, and it was family members who were getting sick. And it's part of the presentation that we do in the courtroom about the history of asbestos knowledge. So, there were many ways for employers and companies that made asbestos products to advise workers how to not bring this home on their clothes. Take a shower, change your clothes, things like that. When you get home, take a shower also. There were many, many ways that have been known since the early 1900s, and it really hasn't changed. Right now, part of industrial hygiene is not wearing the clothes from work home, having them laundered at work, taking a shower at work. And so these concepts have been around for a long time, and it's, again, part of the presentation that we make to the courtroom.
I don't have the percentage of cases that we handle that involve secondary exposure. I can tell you that it is a significant portion of our practice. I tried a case in Miami in May of this year, and the only known exposure that my client had was take-home exposure through her husband's work as a professional mechanic. So these cases are common. They can be successful from a legal standpoint in holding the responsible parties accountable. So it is something that if you suspect that you have been exposed through work or asbestos brought into the home by a family member, that's something certainly worth pursuing.
And in fact, sometimes those take-home cases are worth even more because you don't have the workers' comp exclusivity bar. Do you want to talk about how that's different too?
Sure. So oftentimes the person who is working with the asbestos product, in this case that I was just talking about, the mechanic, the husband, he wouldn't, if he had gotten sick, he wouldn't be able to sue his employer, right? But because that's banned by the workers' comp exclusivity in almost every state except, like Joe mentioned, Pennsylvania and a couple others, Missouri. But because she's not an employee, she could sue the employer in that situation. Unfortunately for my client, that employer was no longer in business and there was no trust fund, so there was nothing to pursue there. But that's an important distinction in a take-home case. Oftentimes, we're able to pursue the company that we wouldn't have been able to pursue if it had been a direct exposure case.
Hi. Okay. Thanks for coming in and sharing with us your expertise in dealing with the legal parts of this mesothelioma that we suffer with. My question is, and you mentioned that you take the cases on a contingency basis. So when you settle a case, whether it's in court or through the trust funds, is the compensation that you receive standard throughout the industry for each law firm? Is it always the same, or is it different for each law firm?
So, so with the trust funds, it's basically the same, but many of the trust funds do have as part of their algorithm some factor related to the law firm or the jurisdiction that the case is being filed. So there's sort of a standard set of considerations, and then there can be like an add-on for the law firm's history with that company and the jurisdiction that you're filing the case in. So, if your case is filed, for example, in New York, where a lot of my practice is, that's a jurisdiction where the values and the settlements are often higher than, say, if you were in North Dakota, okay? For obvious reasons. Cost of living is different, people make more money, the jury pool is different. So it does matter with the trust funds a little bit which law firm you choose, and with the actual lawsuits, it matters a lot. Because again, as Dawn and I have both mentioned, the insurance companies and the companies themselves, they know the difference between the law firms. They know which law firms are willing to go into court, take a verdict, and get a lot of money from a jury, and which ones are not. And that very much impacts what the settlements are, and they are not standard. It's a negotiation between your lawyer and the insurance companies or the company that we're suing, and who your lawyer is will impact that greatly.
And on the flip side of that, the compensation to the law firm itself, is that standard through the industry? Is it a certain percentage of the compensation that's received, or does each individual law firm have a different percentage that they will expect based on the settlement?
Yeah, so some of that has to do with what state you're involved with. Like in New York, our fees are capped at 1/3, right? There are other law firms that will charge, if you're not in New York, 40%, because their state allows the lawyers to charge up to 40%, right? So some of it depends on which state and which law firm you're dealing with. But you know, if you are dealing with a lawyer, trying to select a lawyer, and they say to you, our fee is 40% or our fee is a third, I would encourage you to talk to them about lowering that percentage a little bit. Many of us will have that conversation with potential clients. And also, there's another variable, not to overcomplicate or waste too much time on this, but some law firms will deduct their fees from the gross settlement, and some will deduct their fees from the net that goes to the client. So my firm, for example, always takes it out of the gross, which means that the client gets more, as opposed to it coming out of the client net, which means the client gets less. So that's another thing to talk to the lawyer about and say, you know, I'd rather have the expenses come out of the gross rather than the net. If that makes sense.
Okay, question in the back?
Hi, thank you. Thank you for being with us today. You know, I've never pursued legal action because I'm not really sure where I was exposed. I have a hunch as to where I was exposed. You know, does someone like me have a case where they don't really know where they were exposed?
So I'm sure Dawn and I could both talk for hours about this, but you know, the weird thing about mesothelioma and asbestos exposure is that even people who had a lot of asbestos exposure may not know that without talking to someone like Dawn or I and having us go through your life history, either because you may not have realized it could come from a family member, or be in cosmetic products you used, or, you know, you were into ceramics and didn't realize that at a certain point in time clay had asbestos added to it, or you worked at a bowling alley and you didn't realize that the bowling balls had asbestos in the core, so when they're drilled, what you're really getting when you hire a lawyer like Dawn or I is that expertise, sitting down with you, going through your work history, your life history, and figuring out where the exposure occurred. So, Dawn, I don't know if you want to.
Yeah, I can just follow. Everything Joe said is absolutely accurate. You know, we're specialists in this, and we're used to. We understand we're dealing with a huge latency period, and we're used to going back and historically trying to piece together all the puzzles, all the puzzle pieces in your life history that in which you were exposed to asbestos. So, you know, we have investigators that are committed to trying to uncover every single potential exposure that you may have had in your lifetime. And frequently, our clients come to us and say, I know how I was exposed. I was exposed when I served in the Navy for 2 years. And absolutely, yes, sir, you were exposed when you were serving in the Navy for 2 years. But let's keep talking, because I guarantee you had substantial exposure after that. And we're usually able to uncover many, many exposures that people had that they had no idea that they were working with products that contained asbestos, and they had many exposures that they were completely unaware of.
Right, yep. Okay, thank you all for your questions. Joe and Dawn are going to continue to be here. Our other sponsors as well have their booths outside, so I would encourage you, if you didn't get a question answered, come up and talk to them. Thank you all so much for providing that information. Thank you again for your sponsorships. It means a lot to the foundation and to this event. Okay, Maya, are you going to lead us on to the next thing?
I will.
Before we move on to our next thing, which is extremely interesting, and I cannot wait to hear about it. I wanted to share with you a couple of things about tomorrow, and that is that, actually one thing about tomorrow, and that is we move rooms tomorrow. So for those of you who are staying for tomorrow, we will be upstairs in the congressional room. So that's just off the lobby, just really a couple of floors up. And then later today, right before our dinner, we will have a reception downstairs. They call it the bird cage, but it's right in front of the swimming pool. I don't know if you had a chance to see it. So that is not in your schedule, but that's where we will be for the reception. So with that said, I would like to invite back to the podium the chair of our board of directors and also a medical oncologist at Memorial Sloan Kettering Cancer Center, Dr. Marjorie Zotterer.
Hi, everybody. It's always a little challenging to be the last person between a group of people and liquid libation or a snack, but I wanted to give you an update from some of the things we talked about today in the scientific session. You know, what was, I thought, really worked well with the group today is in the morning we had a lot more sort of formal presentations. We talked about updates from recent meetings like the American Society of Clinical Oncology, the International Mesothelioma Interest Group, as well as another meeting on AACR that was in the spring, and updates from those meetings that were relevant to mesothelioma. We had some presentations from different researchers about the novel therapies that they're working on, in particular at their institutions. And then we had some talks about modes of investigation to look for novel therapies or unique aspects of the biology that maybe were heretofore poorly understood. We heard from some former grant recipients, and I think there'll be more to come from that because it was really powerful to hear from folks who had gotten a Meso Foundation Award, you know, back in 2010, and how it was really a springboard for other research, and it grew into federally funded grants and clinical trials. You know, it took many years, but it was sort of amplified their work and really helped propel them to the next stage. And then this afternoon, we actually spent a lot of time talking about Mars-2, which I'm sure you guys have heard about and talked about a bit today. And really as a group trying to piece apart what does it mean, what should it mean, and what are we going to do next? And really what was great about the conversation we had in the room was people spoke very candidly about their own personal institutional approach and perspective on the role of surgery in pleural mesothelioma. And there was really a shared urgency to collaborating on trials that are going to more definitively answer, I think, some of the remaining questions. And we left that conversation with a few very specific action items that I wanted to share with you. So the first was really, one, working towards having more randomized multi-center trials, so where the same thing and the same questions being asked at the big centers around the country, that we come together and we decide in this moment the most pressing question is, you know, how we give immunotherapy in combination, let's say, with a surgery. And we answer that question and we all work together, we get people involved, we answer the question, and then we move on to the next question. The second thing that came out of that conversation was standardizing the way every institution collects biospecimens, pieces of tumor, blood samples, so that even when people aren't necessarily being treated on the same clinical trial or at the same place, that we have a repository and a resource across all the different institutions that's the same and can be combined and consolidated for study. And I know if you're not maybe a medical researcher, it's sort of, the things I'm saying are kind of like, well, that's sort of obvious, right? But believe it or not, it's not, each place does it a little bit differently. And so I think we had a lot of the conversations today about why folks do it differently and have some action items for really, focusing where we already have alignment and really probing in some of the places where we don't. And I think the group was really energized, and we left those conversations with a few tasks that I think people are excited to do stuff about. And what else did we hear about? Oh, we also heard from Dr. Taraga earlier in the afternoon, and he talked about his work with the peritoneal surface malignancy group to similarly really get consensus about how peritoneal mesothelioma, particularly in the context of other peritoneal malignancies, should be treated, and what that means and what that looks like going forward, and really establishing a network of institutions that treat the disease the same way, and making sure that new surgeons and new researchers really are up to date and having resources available so that folks, while we would still encourage treatment at a big center, that even if you're going somewhere where it's not as common, that the person involved in your care would have the resources they need. And so I think it was a really invigorating meeting. And I, feel that there'll be a lot of further discussions and information in more formal written format that we'll disseminate out to you guys about sort of next steps and papers and projects that come out of this. But I left feeling really excited about the future and hopeful. And that was really the point of today. And I look forward to having some social time with you guys this evening for those who can stay. And I'll see those of you who are still here tomorrow. I'll see you tomorrow too. So thank you so much. It's been a long day, but I think it's been a valuable one. So thank you.
I have nothing else, except we will see you back here. So for our reception, I think that was 6 p.m., 5:30. At 5:30, we will see you down at the Birdcage for the reception, and then we'll come back into dinner at 6. See you soon.
This foundation is very, very near and dear to my heart. Without the foundation, I wouldn't have the direction or know-how to be successful in the outcome of my own treatment. So I'd like to welcome you formally to tonight's awards dinner. Before we get started, though, I'd like to give a quick round of applause to all the doctors and patients who joined us this evening to learn about all the great treatments that are upcoming. So please, thank you. I'd now like to introduce your curators for this evening, Dr. Keith Singal and Dr. Dan Sturman. Please come right up.
Good evening, everybody. I'm going to get started because if Keith gets started, this is going to go off the rails really quickly. So I'm the straight man, and he's the comic relief, if you didn't know. Yes, color commentator. So I'm going to be serious for just about 33 seconds and just talk about my relationship with the foundation. I still feel young inside, but I go way back. I think Maya, where Maya is, but she was reminding me of how far I go back. She goes, I have pictures of you when you were a baby at the foundation. But literally, I don't exactly remember how I got sucked in, but I think I was involved at the inception, literally from the very beginning. I started my career in mesothelioma in 1994. Yes, I was 6 years old at the time, a child prodigy. They called me Doogie Howser. And I think somewhere around 5 or 6 years later, the foundation was visualized somewhere in Santa Monica, California, a place that I've spent relatively little time in my life. But it's been a big part of my life over the past 25 to almost 30 years. It's hard to actually believe. And this night and this symposium has been a really important part of that. And I just want to say that this event is very special to me for a variety of reasons. Number one is I get to often meet patients and family members that I've known for quite a long period of time, for patients that I care for now or cared for many years ago. And that unique relationship that we have with the scientists, the physicians, the medical staff, and the patients and families all being in the same place, I don't think you realize how unique that is in the medical universe. I do a lot of other things in lung disease. This does not exist. And so the fact that we're here together, we're breaking bread together, we're enjoying each other's company, we're learning from each other, it's a really unique phenomenon, and this foundation allows us to do that on a yearly basis. So I think we should just take some time and just absorb that. That's really cool that we get to do that and spread the word that this is something that others should share with us for next year, because it's really special. And even just the conversations that we had about the future of the field and how we're going to develop the next generation of treatments, and the fact that our patients and families are there in the room as we're having these really important cutting-edge conversations and contributing, that, again, doesn't happen in other fields of medicine. So I just want to say that. And then I'll give it to Keith and see if he wants to talk a little bit about the meaning of the symposium to him. And I apologize if I need to interpret for him.
Indeed,
I'll be
right?
glad to interpret for him as well. So thank you.
So one of the things I think that is unique about this meeting and this foundation, there's two ways to view patients. You can view patients as a patient afflicted with a cancer or a cancer afflicted with a patient. And I think we do the former much more than the latter. And I think it's really important that this organization puts together the physicians and the scientists and the patients to help us develop novel therapies, to develop a new pathway. And I think, God willing, we can get back to CDMRP funding, but it's kind of a very unique vibe where we as physicians and scientists meet with the community and ask, what should I be doing? What do you actually need, as opposed to what I think you need? And I think it's a really critical distinction, and I think this foundation is very unique in that respect. And I think all of us who have traveled this journey together really realize that.
Yeah, I was going to say, yeah. What I thought Keith was going to say, actually.
Oh, well, I can say that too.
Was that in some areas of medicine, as medicine has changed, it becomes almost like a provider and a client. And the reality is, in this world that we live in, we're all partners. And it's not just the partnership with the patient, the family, the physician, the scientist. It's the donors that are here today that are partners in this process. I think we have to remember that too, that we're all in this together, and we're all here for the same goal, which is try to cure this horrible disease. And so I think we need to take a moment and just thank all of the partners who are here. I think the patients and the families that are here, the ones that can't be here but have been watching online all day, and then our sponsors, without whom we wouldn't be eating chicken and fish and gluten-free pasta and whatever else Keith had to eat tonight. And I just want to make sure that we acknowledge them, because they are the unsung heroes, because they support not only this dinner that we're having tonight and the symposium at large, but much of the research that we're able to do, the grants that we're able to give for the young scientists who are out there around the world, literally, who were trying to get interest in this relatively rare cancer, to be able to dedicate their career, to be able to create those next generation of treatments that we so much need. So a round of applause for all of you, and then for all of our donors, please. I do want to mention the donors by name, because many of them are here tonight or were here over the course of the last couple of days. Of course, our top sponsor is the Belloc and Fox firm, and I know Joe Belloc was here today. I had lunch with him. I think he headed back to New York, maybe on his motorcycle. Hopefully he made it back safely. But MRHFM, Bristol Myers Squibb, Polaris Pharmaceuticals, Merck, the Gorey Law Firm, Equina Ecology, the Early Firm, and Novacure. And I just want to thank all of them for all their current and past and hopefully future contributions to help us find a cure for this disease. So thank you so very much.
So at this point, we'd like to move on to the award ceremony for the night. We'll be honoring the individuals in our community who've contributed and build advocacy, volunteered their time, volunteered their heart, given everything to this organization, the Meso community, and to honor some of the scientific pioneers in our field. So, for starters, we have the Bruce Vento Hope Builder Award. Some of us are old enough. Me, I'm only 24, so I don't remember Bruce at all.
He was born in leap year, do the math.
Indeed, indeed. But the Bruce Vento Hope Builder Award, the last year's recipient, Maria Tao, is going to come to present this award to a very deserving recipient.
Well, good evening, and it's just truly an honor to be here among all of you, because this community has given me so much hope and support through the years. So I'm truly sort of honored to be here to present this award to Jessica. The Bruce Vento Hope Award was named after the beloved Minnesota congressman who lost his life to mesothelioma in 2000. This award honors an individual who, through advocacy, works to achieve our mission of eradicating mesothelioma. We are fortunate that Jessica Blackford Cleeton found the Meso Foundation after her diagnosis. And over the years, between treatments, raising and her family obligations and raising 2 young, adorable children, she has served the foundation in many ways over the years. She has served as a consumer reviewer for the Congressionally Directed Medical Research Program. She was a member of the inaugural Community Advisory Board and is now a member of the Board of Directors of the Foundation. Jessica has spent years advocating on behalf of mesothelioma funding and support. As a member of the board, she now uses that experience to help coordinate all the organization's advocacy efforts and lead the organization forward. Jessica is an inspiration to me, and I've had the honor of sitting with her through dinner, and just inspiration to all of us. And she really embodies the spirit of this award. So I would like to ask her to come up so we can present her with the Bruce Vento Award for 2023.
Good evening, everyone. I'm going to do something I don't really like to do, and it's read what I wrote off my phone, because I know if I go off cuff, I will get emotional, and I don't want to be Oprah tonight. So I'm going to do what we can. I first want to say how incredibly honored I am to receive this award. I'm in great company with past winners, many of whom I greatly admire and have helped me along my journey. I somewhat jokingly say that I'm the luckiest, unluckiest person alive. In 2015, when I was diagnosed with mesothelioma, I could not begin to imagine being here today, and not so much in this room, but above the ground. Although I had been feeling crummy for a few years before diagnosis, my career, I traveled with my career, the concerts and nights out, I was going to change it for hospital gowns, needles, and Googling things like, can people with cancer still have margaritas? It was a true life-altering event. In all seriousness, I spent many months getting my hands on whatever research I could find on meso, hunting down specialists and trying to find anyone like me who had gone through something similar. I soon found Heather Von St. James, who was gracious enough to introduce me to Mary and the foundation. I was lucky enough to find my oncologist, Dr. Kindler, just 3 hours away, who recommended a great surgeon, newer at the time, in Wisconsin, Dr. Sharaga. My brand new husband, Brandon, was and is and always has been an amazing support. My parents never left my side. Those individuals, along with countless others who helped care for me or gave me encouraging words of support, are the only reasons why I'm here today. A very fortunate set of events and connections of people and places that I didn't know previously and probably never would if it wasn't for this disease has kept me alive. Not only that, I was able to have 2 healthy and smart baby boys, now 4 and 6. Something I never could have imagined upon diagnosis, when I just wanted to make sure I could enjoy a margarita on a faraway beach somewhere should my time be short-lived. Anything I've done since then for other patients or for the foundation is simply me giving back, a small payment for my time here. I many times feel like I'm not doing enough, but I will continue to do what I can for as long as my unlucky luck continues. I'm humbled by this recognition and grateful to be here, both above the ground and in this room. So thank you very much.
So the next award is the Pioneer Award, and I say a little something about it, what it means to be a pioneer. When you start out in medicine, you start out in research, everyone gives you advice, and essentially it's you should be more like me as your advisor, and why don't you follow the path?
You should be more like me.
Indeed. And you find a cause that you're passionate about, and you follow it. And most of the time, when you're really doing pioneering work, you follow it against the grain, and you do the things that everyone tells you, well, this will surely be the death of your career. This is a terrible idea. You shouldn't do that. Why don't you do more like what all those other people are doing that are successful? And I think the Pioneer Award is particularly poignant for scientific clinicians and physician scientists in that these are people that see a need and see a passionate need. And how could you not be inspired by the stories of the patients that we see and we take care of in clinic every day? And you see that and you say, no, I'm going to go forward when everyone else tells me to stop. I'm going to proceed down this particular pathway that everyone says is the ruination of your career, or you shouldn't go that way. And I'm going to make a difference in this particular thing. And I think the Pioneer Award really embodies that pioneering spirit. And this year, to present that award, the associate head of our scientific review panel, who helps us generate the next generation of pioneers, Kara Haymaker, will be presenting the award.
Okay. All right. I am so honored to be able to present this award today to Dr. Fennell. Dr. Fennell has really been an amazing scientist in our community. He is a superb translational clinical scientist who is responsible for leading several major trials in mesothelioma, and he is a globally respected expert, but incredibly humble by nature. Overall, Dr. Fennell has made transformative academic efforts, including leadership of multiple trials that have been seminal in our understanding of how to treat this disease. Unfortunately, Dr. Fennell could not be in attendance today, as he is currently attending the European Society of Medical Oncology in Spain, but he has sent us a video accepting his award. So with that, I'll turn it over to his video, except I don't know how to do that.
But I do.
Wonderful. Thank you, Maya.
Hello, everybody. I'm really sorry I can't be with you today to physically accept this MARF award. I'd like to thank the committee and all those involved in the decision to grant this, and want to express my deep gratitude for this recognition. You know, the work that I've done has not taken place in a vacuum. It really has been the collective efforts of many people, and it would be wrong of me not to mention these individuals and to thank them for their support. I would actually like to start, first of all, by thanking all of those members of my group, my fellows, postdoctoral researchers, in the laboratory setting, technicians, and so on. You know, the opportunity and the privilege to really work with that team has been fantastic over the years. So it's to past and present collaborators within the lab that I'd like to, first of all, thank. I've worked extensively with Gareth Griffiths, who's been a statistician and co-developer of a number of clinical trials. His ability to work with me with some heavy envelope ideas, thoughts, and to be flexible in thinking has allowed us, I think, to work in an agile manner and, you know, develop some of the trials in the past. And we have a lot of work still to do together. So thank you, Gareth, for your support. There are a number of others I'd like to mention. Honji Yang, Junli Lo, Min Zhang, Frank Dudbridge, a friend of, I won't even mention how many decades, a great mathematician, statistician, and geneticist who works with us on Medusa. Ed Horrocks, our nurses, in particular Liz Darlison, who's been a fabulous collaborator over the last decade and has really supported us in our trial efforts, but also to our research nurses who work diligently in helping us achieve our recruitment targets in the manner they work so professionally and loved by our patients. And finally, really, the patients themselves and carers, without whom we simply wouldn't have this opportunity to advance the field. And, at the same time, for them to give us their trust in exploring these new treatments and moving our therapy into new territory. Thank you for that support. Our mission is very simple. It is to simply improve treatment outcomes for patients. We try to leverage technology now to help us achieve the goal of precision medicine. And although the goal is a relatively simple one, the action required to achieve that goal, the challenge itself, is formidable. I've said that this is not work that can take place in a vacuum, and one of our efforts is really to move forward with international collaboration where we can, to build that capacity, that essential capacity that we need to really achieve these goals. I hope in the future we'll be able to continue to achieve more for patients. I think we're in perhaps one of the most exciting periods in mesothelioma research. Technology is helping us see further and potentially achieve more, particularly with some of the newer drugs that are coming. So I think we enter into a very exciting period at the turn of this year. I'll stop by thanking you again for this award. It means an awful lot, not only to myself, but obviously to my team, to my institution, that we can be recognised overseas. So I'd like to wish you a fantastic meeting, and I hope I'll get to meet some of you in person at upcoming meetings on the road. But in the meantime, goodbye and thank you so much again. Bye-bye.
So before I invite the next speaker to introduce the next award recipient, I have to say a couple comments about Rich Mosca. So if there's a face that I associate with this dinner and this symposium, it's Rich's. I walked into the hotel right from the train station, and I don't know the last time that we were here, but I had this incredible sense of deja vu when I walked right into the door of the hotel. I think the meeting was here, 12 years ago. I don't know when the last time it was here, but sometimes it feels like yesterday, and sometimes it feels like 100 years ago, especially if we've all lived through COVID. And I walked in, and I checked into my hotel room, and of course, it's been a long day, so I went to the bar, and I walked to the bar, and there's Rich, right, at the bar, buying me a drink, and how appropriate for that. But I do remember that 12 years ago at this dinner, I was sitting with Rich and talking as others were getting the award. And there are essential people. Everyone's essential, but Rich seems to be one of those essential people. So I want to invite as the 2022 Above and Beyond Award recipient, to the stage to present the next Above and Beyond Award. Rich.
How do I follow that? I don't know. So, Klaus Brock was a meso patient and the Foundation's first volunteer. Through his illness, he worked tirelessly on creating the first real iteration of the Foundation's website, and it's had quite a few iterations since that time. His words are still sprinkled all over the Foundation website. Recognizing and remembering Klaus through this award and through the efforts of those who came after him is a testament to his work and not being futile. We all work towards something bigger than ourselves, and each of us, in our smaller ways, is an important part of the big solution we all seek. Many of us believe that our caregivers are the unsung heroes, and they are, and I know. Throughout our fight, they're right there next to us with their hand on our shoulder, supporting us, making sure we get to our appointments, silently sharing our pain without showing it, keeping us in a positive state of mind, keeping us buffered from the outside world when we need to be alone, answering questions from family and well-wishers, and we know we get a lot of those, and keeping up with our changing dietary needs, keeping the immediate family and household together through trying times, and taking the brunt of our emotional roller coaster ride, just to name a few of them. And I can tell you, if you speak to Laura, we've had emotional roller coaster rides through all my treatments and everything. This year's recipient lost her husband, Pete, to peritoneal mesothelioma at a relatively young age, almost 5 years ago. Because meso can have a long latency period before symptoms show up, a large portion of the patient population falls into the mid-60s and above. The foundation recognized the age disparity in the existing loss support group and approached Claudine at the proper time, asking her to host a new support group for young widows and widowers, as they have similar but different issues. Claudine rose to the occasion and hosts on a monthly basis those meetings on a monthly basis with open arms, creating this. And I'll quote Claudine because I kind of went to her interviews and I picked as much information as I could off of it. A safe place where people feel like they can talk about anything that's on their mind, and we don't judge them or try to give them cliches. Another quote from Claudine is, "I think it is important that the bereaved community stay engaged. We try to make a path easier for the next person who comes along, that comes along." Claudine didn't stop there. She also stays engaged and is an active member of the Community Advisory Board, whose mission is to represent the needs of the patients, caregivers, and the bereaved in decisions made by the foundation. So she's kind of lobbying for us against the foundation, so she knows what we need. So it's with great pleasure, honor, and privilege to present the 2023 Klaus Brock Award to Claudine Benmore. That's okay. You don't know how much I'm shaking here. So. Thank you so much. No, thank you for what you do for those. I know it was easy to turn around and walk away.
Thank you so much to the foundation for this award. I hardly feel worthy, although at the same time, I hope there's something beyond, because I also feel like I'm just getting started. So it is such an honor to have Rich hand me this award. Rich has been helpful to countless meso patients over the years, and my husband was one of them. Before he went in for his first surgery, he made sure that I had Rich's number, and man, I used it. Before Pete was even in the recovery room, I was like, Rich, I'm freaking out, because they had said that he would need a second surgery, and I knew that would be hard news for him. Rich was on the line, helped me calm down. Laura was on the line too. They knew exactly what I needed to hear in that moment. You were lifesavers to me and so many others. So the legend, Rich Moska. And that's what it's about, right? That's what it's about. That's why we are here, this community working together,
against this horrible disease. You know, Rich just told me, and it's true, like it's so hard to come back into the world of mesothelioma after losing someone. You know, and there were moments, I remember specifically this moment where I had forgotten a drug name, and I was like, what was that miracle drug that was gonna be our last resort? And I was like, oh, it was Keytruda. And I was like so glad that some of that like medical information was being purged from my brain. You know, you also feel this drive to honor the person you lost. I do want to take a moment to shout out the other members of the Young Widows and Widowers group. I mean, I host the group, but it's really at this point just a group of friends who get together every month and talk. I also want to mention my mother-in-law, Pete's mom, who found this group, and it changed everything for us, you know? It changed everything. My heart breaks to think of people who confront this disease without this wealth of knowledge and expertise. You know, the foundation is just amazing. I listened to a lot of punk rock music in high school. Any Johnny Rotten fans in the audience? Yeah. Okay. See, I knew it would be you. I knew it would be you.
He is Johnny Rotten.
Yeah. One of my favorite songs from that era had a very simple refrain: "Anger is an energy." Just repeated. Anger is an energy. And the main thing I want to say tonight is that grief is also an energy. It's an energy that motivates you to go to Capitol Hill and lobby for research funding. It's an energy that motivates you to organize a golf tournament or a fun run for fundraising. And even if you never do any fundraising or advocacy, it's an energy that helps you move through the world with more kindness and empathy. And I'm so thankful that the foundation makes room to include us in its mission. I know it's difficult, what we represent. But so that said, I just want to say that I'm so thankful for this award, and I'm glad that the foundation gives me a way to channel my grief into something useful and allows me to honor through those activities the very love of my life. Thank you so much.
I'm just going?
You're going.
All right. Fasten your seatbelts. Laura? So this one is near and dear to my heart, to everybody that's in this room. I need my hand on my shoulder. I need my caregiver's hand on my shoulder for this one. So we're talking about the inaugural Bonnie Anderson Changemaker Award. And I just want to say a couple of things. Actually, I want to break out a second. I've served on the board a few years back, and I know what it takes to put this event together. And under very trying circumstances, our good friend Maya over here made this come together with her staff.
And the whole staff.
The whole staff.
The whole staff. Thank you. Yeah, the whole staff.
She's hiding. She's always the one in the background, but she's hiding there.
Maya and the whole staff.
The whole staff,
Thank
yes.
you. Yes. Yes. The whole staff.
So when I was asked to present this award, it took me about 3 seconds to respond honored. And that was just the amount of time it took me to type it in. Then I had to worry about what I was going to say. But gathering info about Bonnie was pretty easy. You just go to the website and you type in Bonnie and you get a library. What I'm going to do here tonight, and there's a lot of new people in this room, and there's 2 or 3 of us that know Bonnie since Bonnie was here. And when I say I'm only going to scratch the surface of Bonnie, it's going to be about 0.5% of what we should be saying about Bonnie. And there's one other thing I want to clarify up front. When I wrote this last week, I gave it to Laura to edit for me, and she comes back and she says, "You're talking about Bon, you're talking about Bonnie." And there's another, when I first met Bonnie, the first thing she said to me was, "You need a hug." Right? And she says, "I always hug the new patients because they need it." So I nicknamed her Hug. So my phone contacts Hugs. And I'm in my car and I say, "Call Hugs." And there she was. So I'm gonna use these three names of Bonnie throughout this presentation, so please don't be confused. Well, you can't be confused about Bonnie. So 16 years ago, Laura and I were walking back from Advocacy Day on the Capitol Hill, and we bumped into Bon and John, and our lives changed forever. I know. I told them I'm not going to make eye contact until the end. So we first met Bonnie on the website by reading her survivor story. And it was long, it was breathtaking, it was almost hard to believe someone could survive all those things listed. It almost seemed made up. It was like one of those things when you get on a website and you say, "Oh, do this," and there's all this fantastic. Well, that's what I thought when I first read about Bonnie. And then I met her. Our friendship was instant, easy to establish, and lasted until Hugs was taken away from us too soon. We quickly learned we used the same doctor to treat our peritoneal meso. We lived within 1 hour of each other, driving distance from each other. And Laura and I gradually learned who Bonnie was, and more importantly, who Bonnie was going to become. We socialized with Bon and John, and we got to know them even more personally. My first inkling of who Bonnie was came at our oncologist's office, as we often tried to schedule our checkups on the same day. I was sitting in the waiting room, and Bon was in the secretary's office chatting her up as usual. But Bon knew that we were there with several other foundation patients, and in typical Bon fashion, she stuck her head out. I'll never forget this. This is my lasting impression of Bonnie. She stuck her head out from the door. She was wearing a big smile, a baseball cap, a sweatshirt, and yelled down the hall, "I'll be right there, guys." And my first thought was, what kind of person goes to an oncologist's office, has a big smile, and just sits there and just chats everybody up? We got on the Bonnie bus, and we went for the long ride. It wasn't long before Laura and I fully understood who Bonnie Anderson was. So Hugs, she was a true patient advocate on the federal, state, and local levels. In 2009, Bon and John were instrumental. I say Bon and John, there's a reason why I say Bon and John, because you call Bonnie and just, "You've reached Bon and John, leave a message." So that's where I got that one from. I just want to let you know. So in 2009, Bon and John were instrumental in getting the House and Senate to recognize Mesothelioma Awareness Day. Not to mention hitting the Hill every day on Advocacy Day. At the state level, she knew all the representatives and had New Jersey memorialize Mesothelioma Awareness Day as well. At the local level, and this is the downtown Berkeley Heights, was always adorned with many posters and many storefronts made by Bon and John. Often when advocating on the Hill, time permitting, Bon and John would attach themselves to other foundation advocates from different states and go with them just to their appointments just to support them. And when she was walking the halls of the Hill, if someone was listening, Bon was talking. Hugs was a compassionate patient who never put herself first. I never heard herself put herself first. When we spoke on the phone, Bonnie would often mention, "I met a new patient, and she needs our help." And that's when I found out that you don't say no to Bonnie more than once. When it was time to go to the city for a scan test and the results of those scans, or visit a new doctor, she felt terrible John had a driver and all that traffic. Knowing John, I'm sure he said, "Okay, Bon, now get in the car and let's go." When she was upset about the small number of peritoneal research grants that were coming out and being funded, she didn't think about screaming and taking money away from the pleural patients. She sat down with John, and they decided that they were going to fund their own peritoneal research grants, and they've done that for the last 2 years.
3?
3? 4.
Thank you.
Well, how do you not? Thank you. Hugs was a true warrior. She graduated college in 1974, and with a dual degree in education and library science, she couldn't get a job because they were just too difficult to get at that time. It was right after the Vietnam War, and everything was going nuts. So she took a position in a 3-year training program and became New Jersey's first female industrial electrician. She held that position for 12 years. She eventually returned to one of her passions as an educator, and just in Bonnie fashion, never looked back. December 2001, symptoms showed up, and by February 2002, she was diagnosed with peritoneal meso. Her surgery went well, and treatment started. However, an insurance company decided, well, we're not going to pay for this because you're out of state, and we're just not doing this. Remember what I said about you only say no to Bonnie once? Well, Bon, John, and Darcy fought the appeals throughout the state agencies and the insurance companies, and they won. Now, so what kind of superstar is Bonnie? It was listening to all the presentations today. So, and I gave a presentation, a keynote speech at the DOD, and I called Bonnie up and I said, can I use you, because I had no idea what I was going to talk about. And Bonnie had some special words that I can't repeat here, but... Yes, you can. No. I'll let you do that later, John. But Bonnie had some special words, and she only used them in special times. So she said, blank, blank, yeah. So I put this list up. I started to talk about Bonnie, and I put this list up. And I want you to understand, she started out with meso, and every time I spoke to her and she was coming back from a scan, she says, what now? She says, well, hairy cell leukemia, lung cancer, breast cancer. She had all kinds of kidney problems and several other major issues. New patients were often referred to Bonnie as a source of inspiration and hope. Now, I wonder why that was, but that was Bonnie. Anytime I spoke to a new patient and I couldn't get through them, I say, you need to speak to Bonnie because you got to hear what she's been through. So Bon and John planned a 3-week trip to Australia while she was recovering from a partial lung removal. And I'm going to quote Bonnie a couple of times, and I call these Bonnieisms or Hugsisms. But so she said, looking forward is hard, but I just can't let these diseases keep me down or I'd be hiding under the covers. This is who she was. After her return from Australia, she started treatment for breast cancer. So one lung removal, vacation, breast cancer treatment. And John, if I remember right, there was an earthquake like the day after she left. You left Australia?
We left Wellington to go to New Zealand, and I'm getting phone calls after 4 in the morning. There was an earthquake, all of a sudden everybody else in the world heard about where we were, calling us on the phone.
Yeah.
And it was like,
Did they ever figure out what the cause was? It had to do something with Bon.
But the other thing is, you're talking about Australia. While we were there, we met with patients.
Yeah, there you go.
And sat down because Australia has the blue asbestos, which is one of the
Yeah.
worst in the world. And the doctors there and patients there wanted to know what we were doing here. And we also got a phone call from Newark, New Jersey, from a guy that was getting frustrated because they were ripping asbestos down in the school and not doing it properly. And she's just getting on the boat to do something, and I can help you now. Call me back. And we still,
I'll bet you she did.
yes, we don't know to today what happened, but everybody was looking for Bonnie.
And finally, Bonnie was very family-oriented, so her motivation to keep fighting and changing things that were impossible comes from her love for her family. And I'm going to do a couple of Bonnie-isms here again, Bonnie quotes. So strength and support comes from John. I'm going to quote Bonnie again. We have great times together when I'm strong enough, and when I'm not, he helps me get through it. Extremely proud of her daughter Darcy for the woman that she became. And then there's Katie, her granddaughter. I can't recall a phone conversation I ever had with Bonnie that ended up without her telling me about Katie and her latest projects and how smart she was. And another Bonnie quote. My fight to get better was driven by my desire to be as much a part of her life as possible before she grows up too much. That's how Bonnie thought about this. So. And, I forgot to mention, she was also a recipient of the Bruce Vento Hope Builder Award. So what changes are we talking about? Because you have to realize, I've been in this foundation for 17, when I was first diagnosed. And we have the Bruce Vento and the Klaus Brock Award, and there have not been any named awards ever since then. So this is a special, this is big. And so what changes are we talking about with Bonnie? And I'm just going to rattle off a few that just came to my mind without even thinking about it. I believe she changed the face of how we fight this disease. Her tenacity, her fight to change how this orphan disease was viewed by people who knew nothing about it. Her fight to change how we get treated, her fight to change the research funding by our government, her fight to change how newly diagnosed patients were given hope of survival instead of very limited outcomes, and her fight to change how patients approach their treatments with just another quote from Bonnie, just do it attitude. One more Bonnieism that I have here. I've learned not to take any day for granted, to enjoy doing what I can and what I can do, and learn how to live a more limited life. I do whatever it takes to get this disease under control. And in true Bonnie fashion, the end of that statement is, naps included. If we ever needed a poster child for Meso, my nominee would be Bonnie Anderson. My personal take on this is when Hugs enters a room, she brings love and hugs with her. And when she leaves that room, there's a big void. And I can tell you from my personal point of view, there's a big void here that will never be filled because we lost her too soon. So with a heavy heart, but with great honor, it is my pleasure to posthumously present the inaugural Bonnie Anderson Changemaker Award to Bonnie's husband, John Anderson, and her daughter, Darcy Christel.
You did a great job.
I didn't prepare a speech. It was too troublesome. I lost Bonnie July 8th. This really sucks being here, but it doesn't because you're here. Many of you know her. She's been a warrior for many years. And I have my daughter who has a speech all set to go in case I lose it. And I might go back and forth and do different things and say things as they come to my mind. I work with the organization. I'd love to see it go forward. We need more patients. We need more people talking out there to get everybody involved because that's what makes us work for the disease and work to get things resolved. Dan mentioned things before. When Bonnie and we were at NYU and she got announced that she was told she had breast cancer, and I don't remember whether it was within 2 or 3 days, that she has lung cancer. We go walking up to Harvey Pass, who was a researcher and a lung doctor back then with mesothelioma, doing research. And we had back some of his research. We also did research backing outside of the organization, where Bonnie thought things needed to be addressed or helped. We went up to Harvey Pass's office, and some of you have heard the story. And his secretary's there. And Bonnie's trying to explain to her, we would like to see Harvey. And she meant Harvey to go back, and I'll jump around. In Chicago, 22 years ago, on the elevator. Oh, you're part of the conference. And it was a pretty big conference back then. And what we've learned is at the conferences, after the doctors talk, chase them outside and grab them and have some discussions. Bonnie was always looking for what was going on, the latest issues, what the doctors thought. She was always picking brains. So we're up at Harvey's Pass office, and Bonnie's talking. She's not getting anywhere with the secretary. And I say, excuse me. And as Rich will know, I'm really pushy when things get in the way. And I say to the secretary and say, hey, you go find Harvey Pass, and you tell him who's here. You tell him Bonnie's here. And he'll be back here before you get back to your desk. And he was. He came out of his office, came running up to us. We had a nice talk because Bonnie was just finding out with her lung cancer. And we backed his research, but I never thought the man would operate on my wife. We've had other doctors, Dr. Taub from years ago, that started the research with Rich and everything. And, you know, it was phenomenal what he had done. But in the meantime, with Bonnie finding out she has a breast cancer, we're at NYU, boom, boom, we go shooting up the stairs. And Bonnie also had an exotic lung disease besides all that other stuff, which was MAI. And there's Dr. Dan Sturman. And so I'm coming out, we grabbed him. I said, Dan, we need to talk. And as gracious as he was, took us into his office, we explained to him what's confusing with the world is we need a lead man on all these issues with what she has. He took on the job gratefully. No problem, no hassles, helped us out. Was very supportive. I love that man. He was great for the organization. So, as we go on, I miss her. She died quietly. And that thought, I think I'm kind of losing it. So I'll let my daughter take over. But she was a phenomenal woman to be married to. And I thank you.
Okay, I will try not to lose it. Thank you to all of you, first of all, and thank you to Rich for making my speech easy, because you basically said everything I had written on this page.
But you'll repeat it, I hope.
Some of it, yeah. So Darcy Crystal, Bonnie's daughter. Cadence, who you see in that picture, is now 18 and a freshman in college. So that was the last time we were in the Omni, actually, when she won the Bruce Vento Hope Builder Award. Thank you for honoring her as the inaugural Meso Changemaker. I love the fact that she will be remembered forever with this award. That means so much to us. I wanted to say thank you to the Meso Foundation for everything you do every day for patients, for caregivers, for the families, and the friends of these patients. For its supportive research for better treatments, as my mother used to say, this disease sucks, all right? I know we're being live streamed, so I'll watch it, but we want to thank the various medical teams, doctors, the nurses, everybody else on the teams, the staff, because they mean so much to the patients. It's not just the treatment. So I'm on the board now, and when the board hears me speak, I speak on behalf of those families. To me, that is so important that they understand what they're going through and they're able to deal with it. I remember buying cinnamon ice cream, Trader Joe's peaches, and cottage cheese to get her through. Mom was diagnosed about 21, 22 years ago. I believe